angio was done, there was a top of what to do. Now, as we all know, stroke is a leading cause of disability, but it's also a second leading cause of death worldwide. Out of that, ischemic strokes contributes to about 80 to 85% of all strokes worldwide. And as we know, time is brain. We rush along. Why? Because for each about a minute delay, about 1.9 million neurons get lost. But even after thrombolysis was started in 1995, now we are almost 30 years into it. The thrombolysis rates are dismal. In India, still from rural to urban, it's just merely 1 to 4%. And in some best of the states, it's about 12% in the central institutes. In our center, it's still 4 to 5% only. Is the worldwide better? Even in the best centers, it's about 20% after all of it. Why? Because the awareness is not there and the pre-hospital delay still occurs. Last week only, one of my two cousins, well learned, they all thought, oh, my mother had a possible fall and fracture. In fact, it was a stroke. Therefore, it's our duty, all of us, to improve the awareness, increase the knowledge about the stroke so that each eligible patient gets the thrombolysis. Now, why do we do it? What is the basic aim of stroke therapy? Is restoration of blood supply, allow blood and oxygen and nutrients to reach the infarcted or the tissue at risk. What we aim is not recanalization. Recanalization is just opening up the vessel. That is not enough. We have to recanalize well so that there is a reperfusion. Reperfusion means having a good oxygen, blood supply, and the tissue at risk is restored. Right? Now, what is it? This is in simple, the central pink is the area which is already infarcted. That is called as the core of the infarct. That we cannot treat. This is the part which was damaged by the time patient attendants realize, by the time patient is brought to the hospital. The surrounding area, that is called as the tissue at risk, or that is the penumbra. That is area which is receiving little bit of blood supply from here and there. That what we call as collateral. And our whole aim of treatment on my purpose of today's class is that we have to maintain penumbra, we have to continue perfusion to the penumbra. Now, this penumbra, how it will progress, it varies. It depends on the age of the patient, depends on the risk factors. Most important is the collateral circulations. As we know, the brain is richly supplied by circle of Willis. Even in that, even if one vessel is blocked, we know the circulation gets established from other sides. What we want is that the collateral circulation to maintain till we give the stroke treatment. This goes both ways. Treat properly, the penumbra, the core converts into a part of the core gets converted to penumbra. Don't treat it, penumbra converts into the core. This is a pictorial representation starting from the central, from the left side, that from the right to left, the small central core, if we don't treat, it keeps on enlarging to form a core, the infarcted tissue. Now, what has been the management? It's not very old. If you look at it, 30 years have passed, but 1995 only, the NINDS first gave approval for the TPA. In the 2015, there has been landmark changes with the MR Clean study, which showed that you can put a stent and remove the clot from the large vessels. That is called as MR clean study. From there, the initial window was only 3 hours. You could give TPA only for 3 hours. The mechanical thrombectomy, initial mechanical thrombectomy, increases the window period to 6 hours. Now, with the recent trials of Dawn and Diffuse, now we can also treat patients for 24 hours. That is the range of benefit which we have achieved by having a successful ongoing treatments. Many are still going on, but I would like you all to remember the 3 major points. One was the NINS trial, second was the MR clean trial, third was the one undiffuse. Now coming simple to the thrombolysis, what we should or never miss, and what this can be done at each and every hospital, right? Therefore, the first drug was the alteplase. How we give it? We give it as a 0.9 milligram as a bolus, and the rest is given over 1 hour. Maximum is 90 milligram. Initial, the window, as I told, was only 3 hours. Later, it has been slowly extended to 4.5 hours. What does mean? If we know when the patient has when the problem has started, and till 4.5 hours is the window where you can give the IV thrombolysis. It doesn't mean that you can wait up to 4.5. Every second, as every minute is precious, as I showed. Therefore, as early as possible, we should try to thrombolyze. Gradually, what are the inclusions, right? Inclusion criteria, inclusions initially were very large. Now it has been just summarized to 2 points. Do a CT if there is no bleed, and do a score, NIHS score, that is calculate how much disability is there. That's a very simple score. For example, if the patient has difficulty in moving the right hand, right leg, and there is deviation, definitely the score is more than 4, and we can easily thrombolyze. That's a very simple NIHS score. And if we know that, we can just by seeing the patient calculate it and give off. What are the exclusions? Exclusions have come down. If there is a bleed, or if the BP is persistently more than 100, 185 by 110, even after giving emergency drugs, that means they are at a higher risk of bleeding conversion. And recent surgery, that is about 14 days, but that too in areas which we cannot occlude, right? We cannot hold on. That's the abdominal surgery or a brain surgery. They are contraindications. What do we achieve? Achieve what we have, that NNTs patients, then one would have a good end. Now COVID changed the whole picture, and in that, as the contact time was decreased, now in COVID the tenecteplase came into use. We were in India was the pioneer almost, and now almost all our residents give tenecteplase. Why? Because few things, it has a greater affinity for the clot, and it is most important thing is that you can just give as a bolus, right? Just 0.25 milligram per kg body weight. Maximum is 25 milligram. Easily available in each nook and corner of our country, and it's a single bolus. You need not monitor for 1 hour. Yes, routine monitoring which has to be done for 24 hours, but beyond that, it's not that. One important thing is that there was the Extend 1A trial which showed that it may be better in some patients who are having a large vessel occlusion, and it even got the FDA approval recently. Therefore, yes, tenecteplase has been there for long, alteplase has been there for long, and now slowly tenecteplase has taken over because of ease of administration. Now, yes, then why are we, it's so simple, why we are looking forward. Why? Because it has its own limitation. For example, if there is a small stroke, if the small vessels, we do scanning. Nowadays, after the CT scan, we like to look at the blood vessels. Is there a blockage somewhere? That is, either we do In that, if we find there is a blockade anywhere, then the thrombolysis is not so effective. It's in best of the studies, it has been found that if ICA has been involved, only 10% success rate is due to thrombolysis. That is the biggest problem. And most importantly, one more important, as we know, the time window. Even as which has been stretched, it is 4.5 hours. Yes, there are studies which say that now you can extend till 9 hours, but it is not in the guidelines. For us, it is still 4.5 hours. After the 4.5 hours, the thrombolysis window is closed. We cannot. Therefore, and by the time patients realize it's already 2 to 3 hours. Therefore, in patients who has a large vessel occlusion and beyond the window, this may be option where we look at the vessels by doing a MR angio or a CT angio. If there is the occlusion, then we look forward and thrombectomy comes in. This has been a real game changer. As I was passing my DM, the MR clean study came, in which this was the first positive trial which talked that stent retriever can be used. Basic point about stent, it's not that as we place the stent, this was, I thought a long time as it's a cardiac stent, same is the brain stent. It's not that. It is a retriever. That is we pass a channel, I will show it, and slowly we remove the clot. Right? As I was talking, the NIHSS for simple, for ischemic stroke, for thrombolysis is 4. Here they say minimum NIHS should be 6 or more. When less than this, also there are trials, but minimum it should be 6 and more for the patients to have a benefit. Initial window was 6 hours, and gradually new studies, DAWN and DIFFUSE trial have shown that we can extend up to 24 hours. What is this? This is a simple diagram. As we know, the base catheter, along with that there is a distal catheter, and that's the mesh. The mesh holds the clot, and then we can either pull it out or we can have a suction catheter also. These are the new devices that goes into the region of the vessel, tries to hold on to the clot and suck it out. That is in simple methods what do you mean by a stent retriever and an aspiration device. Therefore, as I told, we need to have an angio, we need to have a MR angio, we need to have or a CT angio, both of it is there. Now we are also using AI in this. Automatically we have a software which calculates how much is the core, how much is the infarct, and how much is the area which can be saved. That is called as the penumbra core mismatch. If it is more than 1.8, we push for it. What are our goals? Whenever a patient comes, CT in 20 minutes. Within 60 minutes, in all of our thrombolysis to all of our patients. Gradually, most of the time it's about 60 to 65 minutes. The patient should go to the angio suite within the first 90 minutes. As I told, time is brain. This is the rapid AI photo what we see. The green part of the brain is the part which we can save. The pink part which has got it is more than 1.8. Here it is 6.3. This is called as the of it. These are the patients who can survive well. So how we look at the treatment now is the patient 5 hours window. There is nothing. Thrombolysis. If there is no occlusion, nothing. Treatment stops there. If studies which say already we can, as there is comes down. But till now, if the patient comes within the first 4.5 hours, we go for thrombolysis and then plan for thrombectomy. They have their problems, but this is at this point of time. What benefit we will get? This is a beautiful slide which has calculated how much benefit we will get, right? This is stroke on the calculated as 51 ml. This is the penumbra, which is about 330 ml. Therefore, this is the 279 ml is the part. When there was a successful thrombolysis, the follow-up CT showed that the area which was saved, which was from 330, is now 175 ml. And if you remove the successful of the brain was saved. This is a quantitative estimation what we can also do. What happens is have a deficit is sustained and the period of recovery occurs over weeks to months, 3 months to be precise. If we can quantitate this, we can show to the attendant also, this is the part which is saved, and over months, over weeks and months, he will have a good recovery. Therefore, now we are suggesting such a model. Thrombolysis can be done at each nook and corner. NIHS score is high, and if it gets shifted to a thrombectomy ready center, we may offer that. What do we do after the perfusion? We try to maintain look for any bleed, because we are opening the floodgates, and many times there is a huge bleeding in the brain, right? We try to maintain the BP adequately. We avoid antiplatelets for 24 hours. Simply control blood pressure, sugars, temperature, and push for early rehab. What is the benefit from the trials? In NINDS trial shows us improved MRS at 90 days. MR clean showed there was a 13.5% improved in MRS. MR is the modified Rankin scale. It talks about the disability. Dawn trial, initial for the 6 to 24, that occurs if there's a good mismatch. And diffuse trial also showed if there is a small core, if there is a large area which we can save, patient has a good benefit. What are the future direction? Yes, many trials are going on, that why not thrombolyze in the ambulance only? There are many centers in India where the ambulance normal injection is given in the mobile stroke unit only. Patient is brought and look for any vessel occlusion. Posterior circulation stroke is a big area, but lot of studies coming. You can do the same in the posterior circulation also. Now, the bugbear is that which of the patient simple speck of a blood, there is a high risk of hemorrhage, please do not go ahead. And neuroprotection, the holy grail of treatment in neurosciences, it has not yet been successful. Coming back to our question, as I showed in the first, the young lady with dysarthria, and one point, this I caught yesterday only. All of you, please subscribe to STAT. Your area of interest, you will have one question which is clinical and very relevant to your practice daily. I received 2 days back on the topic which I was preparing. Therefore, this was the young lady, as I told, has a posterior circulation stroke with NIHS of 7, and there is a big basilar artery occlusion, and patient has come within 2 hours. What should be our treatment? The treatment was, patient was suggested mechanical rapid triage is the key. Till now, within the first 4 hours, thrombolysis is the first line. Now we have strategies which we can save. We can go for LVO, if there is LVO obstruction, we can go for mechanical thrombectomy. Most important is that everything has to be done fast, one by one, and always teamwork. The radiology, emergency, neurology, and all many times neurosurgery all come in together and help the patient. Thank you. Any questions? We can take some questions.
Yes. Invite questions, please.
Yeah.
Yes. What has he contacted Canada?
If no questions, we go to the next topic, which we eagerly wait to listen. I request Call Sir to come and talk on newer antiplatelet strategies in stroke practice.
Good morning. When there are no questions, there are only two possibilities, Praveen. Either they have understood everything, or they have understood nothing. They are laughing, which means they have understood everything. But it is great that you have come here early morning. You are the real doctors, those who come early morning. And we are proud to have Dr. Manas here, who is a legend in neurosciences. He's also early morning, so we should all be early birds. But Praveen, thanks for... see, stroke is something that everybody should know, not only neurologists, because it can happen to anybody at any time. It can happen to our father, mother, brother, sister, bystander. And at that time, the first thing we have to do is to take him to the hospital. So there is no bigger emergency than acute stroke, because it has every minute counts after a stroke. And I think Praveen has given an excellent lecture. So I'll talk to you about antiplatelet strategies. What is new about antiplatelet strategies? But for that we have to little bit trace the history of the antiplatelet. See, whenever there's a brain stroke, it is because of an occlusion of an artery. Occlusion of an artery by a clot. Now the clot can come from the heart. 20% of the clots come from the heart. Mitral stenosis, atrial fibrillation, myocardial infarction. 20%. And rest of the 80% occur in the blood vessels, in the carotid artery, right? You can see here in the middle cerebral artery, in the penetrating artery. So 20% of the strokes are cardioembolic and 80% are non-cardiogenic or atherosclerotic. And this is our own data from Hyderabad, which I am showing you. But it is the same all over the world. 20% from the heart, 80% from the vessels. Therefore, stroke needs an investigation to prevent the next stroke. This stroke has happened anyway. Now we want to prevent the next stroke, and for that we have to know what is the source of the clot. So antiplatelet agents are given for these non-cardioembolic strokes, in the clots which form either in the aorta or in the carotid artery or in these penetrating arteries. For the cardiac, there are anticoagulants to be given, you know that. Warfarin, apixaban, all that. We are not talking about it today. We are talking about atherosclerotic strokes, lacunar strokes, for which we have to give antiplatelets. So, what is the role of a platelet in causing a clot? It all starts with a blood vessel. We are all born with beautiful blood vessels at birth. Then as the time goes, we start eating good things, chocolates, pastries, dosa, and that all muck accumulates in our vessels, in our endothelium, and you can see here. Initially there is a beautiful lining, and by the age of 15 or 20, you can see there is this thickening, right? And then if we continue our habits of eating all the tasty food and all that thing, full of fat and all, it keeps on accumulating, but still the lining is maintained. But over the course of time, this lining can rupture, and that's called rupturing of the plaque. The moment there's a rupture of the plaque, it attracts the platelets. Platelets like the ruptured plaque, and they accumulate there. And you can see here, this is the mechanism. This is the blood vessel, and all the platelets need is a ruptured plaque, ruptured line. It is same on our hand also if it gets cut. That is the mechanism. That's how platelets plug a wound. But that is good, what happens on our hand. But here it's not good. So there is a ruptured plaque which is formed over 10 years or 20 years. But the moment it ruptures, platelets get attracted to it. They want to stop that plaque from rupturing. And the result is that this clot is formed, thrombus. And then this thrombus doesn't only form, it disconnects from here. It fragments from here and goes to the brain. And that is how the stroke is formed. Now, this diagram is important for us to have a general understanding. Because normal platelet which is circulating through the blood vessel in all of us at this time is an innocent platelet. It's not doing anything, it's only circulating. The problem is only when the platelet becomes sticky, when it forms a plug, when it forms a clot. So how does a platelet become sticky? How does it form a plug? Normal platelet is good, it is not sticky. Only when there is an injury. And in this case, the injury is in the vessel wall, in the plaque. So you please pay attention to this. This is a disrupted plaque, right? Which I showed you in the previous slide. From the disrupted plaque, there is a tissue factor is released or collagen is released. That is the stimulus. So that stimulates this platelet, this tissue factor or this collagen, and it goes inside the platelet. And inside the platelet, there is one enzyme called COX. It's normally present here, but normally it is not doing anything, right? But once there is this collagen factor or this tissue, this COX enzyme gets activated and it converts the prostaglandin present in the platelet into a very bad substance called thromboxane A2. Thromboxane A2 is the villain of peace. Thromboxane A2 lies at the center of all these coagulation things. And normally it's not present. It's present only when this tissue factor enters and stimulates this COX enzyme to convert the prostaglandin into thromboxane A2. And once thromboxane A2 is formed, it lets loose a cascade of events. It goes up, and again this thromboxane A2 stimulates the platelet only, and this time it stimulates some further receptors and cause the release of ADP. Right? So one release is thromboxane A2, second release is ADP because of thromboxane A2. Right? It's a cascade. And ADP, you should think it's like a glue. It's like a gum. ADP is the thing which makes platelets stick to each other. But ADP has also to act on receptors to make platelets stick. Everything happens through receptors in our body. Everything. And there are various kinds of receptors on this platelet. So there is this P2Y2 receptor. There is GP2B receptor. And through these receptors, the ADP sticks to them and gets more platelets. So therefore, we are having antiplatelets which act on these various sites. So aspirin, our age-long favorite antiplatelet, acts on this COX-1 enzyme. So it's a COX-1 inhibitor. So it does not allow thromboxane to be formed. So we should remember that. Then we have got this clopidogrel, ticagrelor. It acts on these P2Y12 receptors, so that it does not allow ADP to act on that. So therefore, platelets will not. Then there are another one, new one, the one which intervention radiologists use, that's called tirofiban. It's an intravenous IV infusion. It acts on another receptor. So most important in clinical practice for us to know is aspirin, which is a COX-1 inhibitor, and clopidogrel ticagrelor, which is a P2Y2 antagonist. But basically, this is the mechanism. And we have to know one more mechanism, that inside the platelet there is also ATP, which is normally converted into CAMP, and CAMP is an anti-aggregant. It works against the accumulation. And there is one compound called phosphodiesterase here, which metabolizes this, which means it finishes this, it depletes the CAMP. So that happens normally, And there is one compound called silestazole or dipyridamole. So they inhibit the degradation of the CMP. And if there is more CMP in the platelet, then there will not be aggregation. And the additional advantage of these phosphodiesterase inhibitors or cholesterol, they are also vasodilators. So these are our main players in the stroke management, which act through different mechanisms. Thrombexin inhibition, right? And then these ADP receptor inhibition, and then the increase in the level of the CAMP and vasodilatation. So the main players are aspirin, clopidogrel, dipyridamole, cilostazol, ticagrelor, tirofiban. There are other antiplatelets, prasugrel, we are not worried about them. They are in cardiology. These are the neuro antiplatelets. So I'll just go through quickly through them. So the role of antiplatelets is number one, primary prevention. Right? That means that before the stroke occurs. Second is secondary prevention. That is the most important. That means after a stroke has happened, we don't want second stroke to happen. And now the third thing is treatment of acute stroke, once the stroke occurs. So normally aspirin has no role in primary prevention. Please remember that. And as physician, you should know that, because I have seen physicians indiscriminately writing aspirin to everybody. That should not be. That is wrong. But by chance, if you see that a patient has got a tight MCA, you have done investigation for some other cause. Patient has done carotid stenosis, carotid Doppler for some other cause, and you know that this patient is having a carotid stenosis. You know patient has MCA, he has not yet had a stroke. But once you know, you will give him in these patients so that you don't get a stroke. But definitely aspirin should not be given in asymptomatic lacunes. We have a tendency to give it. If we find patient is diabetic, there are some lacunes, we give it. But studies after studies have shown we should not do it because there's a risk of hemorrhage in these patients. There's a risk of brain hemorrhage, right? Please remember that. So most important is secondary prevention for antiplatelet, which means after a stroke has happened, the patient should not get a second stroke. That is our main challenge. Now, long-term risk of a recurrence is about 10% per year. So if we keep a stroke patient just like that and don't interfere, by 5 years, almost half of them would have got a second stroke, and second strokes are very disabling compared to the first stroke. So this is what we have to prevent. This is the role of antiplatelet agents. So the first antiplatelet agent was aspirin, which is being used for the last 3-4 decades now. But as you see, aspirin is not a very effective antiplatelet agent. It prevents only 30%. So if you take 100 stroke patients and give aspirin, only 30% you can prevent the stroke, and 70% will still have a stroke. And people knew about the limitation, and the best dose is 50 to 75. You need not give 325 or 150, that has long been solved. 75 milligram is the best dose, but it is not very effective. Only 30% effective, 70% will still get. So there's a need for some better antiplatelet strategy. And anybody knows this movie? Anybody has seen this movie? Sholay. So Sholay taught us that if we have to beat a villain like Amjad Khan, you don't need one hero, you need two heroes. And one of whom died recently, Rip Dharmendra. But Dharmendra and Amitabh Bachchan together could kill Amjad Khan. So Amjad Khan in this case is a stroke. So it was realized that you need two antiplatelets if we want to prevent the second stroke. So, 1 minute, this is, why it's not coming? I think Amjad are playing some trick. Should I close it? I'll open it again. Huh? It's open. Yeah, 1 minute. Yes. Yeah. Sorry. So we got it back. Huh? It's not coming there. Praveen, you will give me 5 minutes extra, no, for this? Yes. Yeah. It's coming here.
Amjad Khan was himself was enough.
You see? You see? I'll be careful next time. Yes. Okay. Now, so the first combination which was tested, double we are talking, was antiplatelet agent, which is a combination of dipyridamole and aspirin. This red bar, which you can see, red bar here, this one, 23%. So it was shown that this combination of dipyridamole and aspirin was better than aspirin alone, 23%, right? And this was called Agrinox or Erino. We have used it for many times. But people did not like it because it used to cause a lot of headache and all that thing. So, but still we used to use it because that was thought to be the most effective, much more effective than the aspirin alone. So then people wanted something better than that. So they tested clopidogrel plus aspirin combination. It was called a match trial. And match trial, the problem with match trial was that it was negated by very high rates of intracerebral hemorrhage. And the bleeding was spread over 18 months. They gave this combination for about 18 months and they found that there was a lot of bleeding. And most of the bleeding occurred in lacunar infarcts. And the bleeding they found occurred mainly after 3 months. So therefore, they thought that we should make some antiplatelet strategy which is maximally active in the first 3 months. Recurrence also is in maximum 3 months. And bleeding is not usually in the first 3 months. Right? So they thought, let us focus on the first 3 months, because after 3 months when we go, there is more chances of hemorrhage. So that was based on this particular slide, which you can see. This is called stroke prone period. Once a person gets a stroke, there's a stroke prone period, which is maximum in 1 month and 3 months. After that, that proneness becomes less. The endothelium becomes then silent. It is extinguished. But those 3 weeks are very important, stroke prone period. So therefore, further trials were devised to use antiplatelet combinations in mild strokes which are not disabling and which are where the antiplatelet agents are given for 1 week or 2 weeks or 3 weeks or maximum 3 months. So what are minor strokes? What are minor non-disabling strokes? These are the ones where patient has a stroke but still he is able to do activities of daily living. He's able to walk within his home, he's able to brush his teeth and all, because it's no point to do so much aggressive therapy in a bedridden patient who already is disabled, cannot walk. Why to take that risk? But these non-disabling strokes are something where we should do everything possible to prevent a recurrence. And in that there are 3 trials which are very important. First trial is Semipris, which came in 2011. And here they are giving double antiplatelet, which means clopidogrel plus aspirin for 3 months. And particularly in those people where there is a intracranial vessel stenosis, in those patients, for 3 months you give it, and it was found it is better than putting a stent. So that is a very landmark, and even today also it stays like that. Which means even if you have got a patient who has a stroke, who has got a MCA stenosis, you want to put a stent there, but there is no need of putting stent because double antiplatelet of ticagrelor plus aspirin is better than even the stent. Stent has a complication. So this is 2011 Semipris trial, double antiplatelet for 3 months, along with high dose statins and good exercise. Then in 2013, Chinese people came with a trial called Chance trial. And in Chance trial, they gave clopidogrel plus aspirin, but they load. They give 300 mg of clopidogrel and they give 75 milligram of aspirin for 21 days, which means 3 weeks, and after that aspirin alone for rest of the time. And they found this is also very effective. So here they are giving only for 3 weeks, and there was no hemorrhage in these patients. It was a Chinese trial. But then the Americans and Canadians thought that, they always want to test something in their own people, and they thought this is Chinese. How do we know it's applicable to us? So they did a similar trial called Point trial. And in Point trial, they again gave clopidogrel plus aspirin, but here they gave it for 3 months. They gave for 3 months, and what they found, that's also very effective, but there was more hemorrhage. It was mostly GI hemorrhage and other hemorrhage, but there was more hemorrhage. So as of today, we can give double antiplatelet minimum for 3 weeks, but in high risk where there's a stenosis and all, we can go for 3 months, but definitely not beyond 3 months. That is the lesson. And which are these 2 antiplatelets? These are aspirin plus clopidogrel. This is what these all 3 trials are showing: Semipris, Point, and Chance. Minimum 3 weeks, but in high risk you can go 3 months, but not beyond 3 months. So when things seem to be all right, then the stories of clopidogrel resistance started coming. and they came mainly from US. And they came also from cardiology people, where they found patients, in spite of taking clopidogrel, which was a hero at that time, people liked clopidogrel, they found patients are getting recurrent events. And the stories of patients having recurrent strokes and recurrent MI, in spite of double antiplatelets, started coming more. And initially they were ignored. But finally, when they saw, they found that there was a definitely clopidogrel resistance. In America, it was about 50% of the people who were taking clopidogrel got recurrent events. So they issued a black box warning, US FDA, and they say that before you put a patient on clopidogrel, do their genetic testing. And that's called CYP2C19, because clopidogrel is a prodrug, which means to be converted into active drug, it needs an enzyme in the liver. It has to go through the liver, and that enzyme is called CYP2C19. It converts into, but some people have got a mutation of that enzyme. They cannot convert clopidogrel into prodrug, therefore there will be resistance. So therefore, in India also there are studies, this is from in Delhi, this study, and they found that about 60% of the people whom we put on clopidogrel don't respond to that. And currently we are doing a very big project in KIMS only with our genetics department, and we also are finding similar things. It's going to be completed in some time. So clopidogrel resistance is a reality. So indiscriminate use of clopidogrel has to be avoided. And cardiologists have almost given up clopidogrel now. So what to give in place of clopidogrel? So there is another new compound which works almost on the same receptor, on the same ADP receptor which I showed you, and it's called ticagrelor. Now the advantage of ticagrelor is it does not depend on liver at all. It is not a prodrug. It bypasses liver. So it is fantastic. It's an antiplatelet agent, and it directly acts on the platelet and doesn't depend on genetics at all. So it's a wonderful drug. And this drug was tested in a trial called THALIS trial. And to cut the long story short, in THALIS trial they showed that this is very effective compared to the combination of ticagrelor plus aspirin is more effective than aspirin alone. So in other words, it replaced clopidogrel, because here you don't have to do genetic testing and all that thing. But the cost was that the bleeding is little more in these patients, bleeding. So as you can see, the major hemorrhage is little more, but the advantage of preventing the ischemic stroke is much more than the risk of the bleeding. So that's important. And this trial was done by this very famous man, and his name is Pierre Emerienko. He's a French neurologist. He is the father of statins. I've seen him personally. I've talked to him. He's very handsome, as you can see here. He's from France. And this statin story has been started by him only. And he's done this trial of ticagrelor, and he found that particularly it is helpful if there are stenotic vessels and all. So all those places where we were giving clopidogrel, now we can use ticagrelor. But there's one caveat in ticagrelor. Clopidogrel we are giving for 3 months, but ticagrelor they have recommended to give only for 1 month, because that is the stroke prone period in which it does its maximum effect. After that, we don't want to take the chance of hemorrhage, which can occur anytime. So these are now the guidelines, latest guidelines of American Heart Association, which says that for TIA or for non-disabling strokes, you can give ticagrelor and aspirin, but only for 30 days. At 30 days, we should stop it. We are talking of stroke here. See, cardiologists give ticagrelor for 6 months. That is different, because hearts don't bleed. But in brain, we have a risk of hemorrhage. So for stroke, after 1 month, we should stop it and put some other antiplatelet agent. So far, I have discussed aspirin, I have discussed clopidogrel, and I have told you the ticagrelor story. Now comes the last antiplatelet, which I am going to talk, and this is my favorite. This is a Korean-Japanese drug called celestazol. And this, as I told you, the celestazol works on the CAMP within the platelets. It increases CAMP levels, because of which it becomes anti-aggregatory. It also is a vasodilator. So it's the best, but somehow it has not been very much popular here, but it is very popular in Korea, in Japan, and very successful. And there are 2 trials which have been done, one in 2005 and 2010. And there they have given, there is no 1 month period, 3 months period. They have given more than 2 years. You can give it indefinitely, more than 2 years, more than 3 years. And the advantage is that bleeding chance with celestazol is minimum, right? Okay, but it is not, if a patient has a coincident cardiac disease, then you will have to give ticagrelor. But patients who don't have significant cardiac disease, celestazol is a drug to give. Now, this is one of my own patients who has recurrent stroke. Just look at it, how much. First attack, second attack, third attack, fourth attack, fifth attack. So after 5 or 6 attacks, he is coming to me, right? And not only that, he has so much of microangiopathies in this patient. So much of microangiopathies. Now, such a patient, when, once you are having so many attacks recurrently, so he was put on aspirin. But once you put a patient on aspirin and who has got so many microangiopathies, they are definitely at a risk of bleed, and lo and behold, there was a bleed here. So what to do? And you will see these patients, they are at risk of bleed and they are at risk of hemorrhage, both, and you want to prevent both. So therefore, in such situations, celestazol comes very handy, where a patient has both hemorrhage and infarct and you want to prevent, and there is a lot of literature on that. This is a review article in Stroke Journal, and it says that celestazol is more beneficial for ischemic stroke patients with multiple cerebral microbleeds and before white matter changes are extensive. So therefore, this is the drug to be given in those situations where the patient has an ischemic stroke with a past history of brain hemorrhage. Okay. Now, other new strategies are, and this is very exciting, is that now, Praveen just now talked about acute ischemic stroke, we give thrombolysis. But these days, we differentiate an acute ischemic stroke, is it disabling or non-disabling? If the patient has a very mild ischemic stroke, which means mild facial palsy, which means mild numbness, so you don't want to give thrombolysis in those patients, which we used to give, because there's a risk of bleed. In those patients, we can give double antiplatelets. So far I was talking of prevention, but now I'm talking about the acute ischemic stroke. And this trial is called Aramis trial. And this Aramis trial is again a Chinese trial, but very impressive. So what they have shown is that double antiplatelet therapy versus alteplase for patients with minor non-disabling stroke, and they found it is more effective compared to thrombolysis and less chances of hemorrhage, almost no hemorrhage. So this is the meaning of Aramis trial. Among patients with minor non-disabling stroke, dual antiplatelet therapy compared with intravenous met the criteria for non-inferiority with excellent functional outcome. And I think neurology residents know that in many times when patients came with mild disabling, we did not give them thrombolyze. We gave them double antiplatelet and they became totally all right without any bleeding. And now the last exciting indication for antiplatelets is intravenous tirofaban. Now tirofaban also is an antiplatelet agent, but it's given intravenously, and it may come, this is future, it may come. Praveen, we discussed it the other day, that after IV TPA, some people are giving it to prevent the progression without any extra bleed. And some of the neurologists in this country have started doing it. As of now, interventional neurologists are using it. When they are doing any procedure in the page, they feel that there's any block or anything, they give an infusion of tirofaban and it resolves the blood. I think Anantram is expert in it, in giving it. So tirofaban is an IV antiplatelet agent, which also seems to have a great promise in preventing the progression of the stroke. Okay, so in summary, these are the main carry-home points. That aspirin should be avoided in primary stroke prevention. So we should not indiscriminately give aspirin to anybody who is, particularly if he is more than 70, but even below 70 also, no, don't give aspirin unless a patient has a stroke, number one. For minor strokes due to lacunes, aspirin plus clopidogrel for 3 weeks you can give. But if there is a MCA stenosis or any vessel disease, then you can give that combo for 3 months also. But now we have got an alternative to that, that is ticagrelor plus aspirin. I personally give now ticagrelor and aspirin only, because only 1 month you have to give rather than 3 months. But that 3 months still stays in the combination, in the guidelines. But better is to give ticagrelor because that genetic issue is not there. And if these patients of stroke also have a past history of bleed, or there's any risk of bleed, then it is better to choose celestazol because that does not have extra bleeding at all. And most important is that even for acute ischemic stroke, if they are very minor, non-disabling, in place of TPA, we can give them double antiplatelet agent. And the promising drug which is going to come in next few 1 or 2 years is intravenous tirofaban to stop the progression of the stroke. Thank you very much. If you have any question or comment, please feel free. How many of you are using aspirin in a patient without stroke? I'm sure some of you must be given. Because there was a time when whole America used to take aspirin and they used to call it baby aspirin. And then they used to land with brain hemorrhage. That practice should be stopped. Okay?
Any questions?
Yes, sir. Give the mic. Take the mic, sir.
If a patient has a aspirin, due to aspirin has a hemorrhage in the piles.
Hemorrhage in the?
Piles, he has a piles and he has some tendency to get melena and some bleeding. Melena also he gets, the gastrointestinal bleeding. Do you think we should give only clopidogrel then after 3 months? Or on first few days he might tolerate, but in a long term he is not tolerating.
That's true, sir. Mostly when a patient has active bleeding, if it's active bleeding for 1 or 2 days, we should stop it. We should stop any antiplatelet, whether it's aspirin or clopidogrel, we should stop it and we should address that issue. But after that, we can continue any of the antiplatelet.
No, but with the aspirin, he still continues.
Oh, then you can change.
To give now. Now you said that there is a lot of resistance to the clopidogrel.
Yes, 60%.
60%. So should we, which patients should we test, genetic test, what you say? Sir, we don't do routinely that genetic test.
Yeah, your point is very right. Guidelines as such as of now say that don't do genetic in every patient. But it's always better to do, sir. Why to take a chance? But guidelines say it's not required. Guidelines say it's not. Well, guidelines look at millions of patients together. They think it's not cost effective. Guidelines come from America. And if American system has to do resistance in every patient, that will cost them billions of dollars. So they are not expecting it. So better is, as far as possible, to give only aspirin. And if you have to add, you can add ticagrelor, but you can add clopidogrel with this caveat in mind that he may get recurrence. But I have stopped using clopidogrel in my practice.
Now, because a patient who has an acute myocardial infarction and he had this, and he takes now clopidogrel only for his. Now, clinically, we will not have an idea of his resistance to the clopidogrel.
So that is why it should be replaced by ticagrelor if you can. And cardiologists have already started doing that.
Okay.
Yeah.
Can I ask one question?
Yeah, please, sir.
Now, in your summary slide, you said if stenosis is more than 30%, you give ticagrelor, and more than 50% clopidogrel with aspirin.
Yeah.
What is the rationale of that?
No. Those actually, the definition of intracranial atherosclerosis, which was decided few years back, was 50%. So they have brought the bar down now. They are saying more than 30% also should be taken as. So the trial which was done for ticagrelor, they defined atherosclerosis as more than 30%. That is the only rationale. It is not that above 30% we should consider it as an intracranial atherosclerosis. That is their new definition, 30%. And because that is the latest trial, so they are saying more than 30%. Those 50% are older trials. So the thing is that any person whose vessels are more than 30%, we should take it as intracranial atherosclerosis. So we can give him ticagrelor or clopidogrel anyway. But the clopidogrel trial was done on more than 50%. So they thought that less than 50% are benign. But that is not true. Any vessel where there is more than 30% should be taken as atherosclerosis.
Sir, one question from my side. Many times after 3 months we hesitate and many times we decrease to single antiplatelet. Sir, have you any time faced after decreasing to one patient has a recurrent stroke?
All the time.
Yeah.
All the time. The patients you stop after 3 months and then they get again.
Yes.
So then after that we have to stop the guidelines.
Yeah.
Once he has failed the guidelines, then we take the law into our own hands.
Yes.
So then we continue and we mention it that this patient after 3 months, or that is the indication for stenting. Anantaram is silently sitting there. And he believes in this more than us.
Yes.
He believes that, he says, as long as the patient is having double antiplatelet, no recurrence, no stenting. But the moment there is one recurrence, that is for stenting if the patient can afford it. Okay. And if the lesion is stentable. Anantaram, what do you say? Please. He's talking of recurrence despite double antiplatelet after 3 months.
Yes, sir. I think you have answered the question. So if he has failed medical management, definitely he becomes a candidate for stenting.
Yeah. Because indefinite double antiplatelet has been shown with massive bleed. We want to avoid it. Now in stenting, which Anantram will put, again we have to put double antiplatelet. But that double antiplatelet we can stop after 3 months. Then for rest of the life, patient has to be only on aspirin, which will not give him that chance of bleed. Yeah, Praveen.
Sir, many doubts, sir. Please.
Please.
Clinical scenarios. In emergencies, patient, 50-year patient, diabetic hypertension, comes with a severe vertigo, first episode of vertigo. We do not show a stroke. Can we give aspirin? Can we give antiplatelet?
Yes.
Yes, because...
Yes. You can give. Because stroke is a clinical diagnosis.
Yes.
In medical therapeutics, there's always this, everybody knows Chandraprabha and all, Chandraprabha syndrome. Stroke is a clinical diagnosis. Stroke is not an MRI diagnosis. If a 90-year-old or 80-year-old person has hypertension, diabetes, and suddenly says, I'm having giddiness and all, there's no way you can say it is not a TIA. And most likely it may be a TIA. So one option for you is to be very academic and say, no, and don't give him. Second is that cover that possibility of a stroke. So Michael Strupp, you may be knowing him.
Yes.
Michael Strupp is an international authority on vertigo.
Yeah.
Who is very keen that you should make a proper diagnosis. But he says that people above 60, if they have got diabetes, hypertension, put them on aspirin anyway.
Yeah.
Because you don't want to take a chance of, even when there is the slightest possibility it can be a stroke, put him on aspirin. Yeah.
And last, I'm putting you
But on the other hand, if there's a 20-year-old girl who comes with giddiness, I will not put her on aspirin.
Yeah. What is your opinion on the Lackey trial, sir? I have asked you again, but I'm again asking.
Please explain that question so that others understand.
Yeah, sir. The use of silestazole and isosorbide dimethyl. I know these are all the strategies: aspirin, clopidogrel, aspirin, ticagrelor. Still, then there are patients who have lacuna, and according to textbook, according to theory, antiplatelets may not have much role in these lacunar strokes because the thought it is all due to lipohyalurosis. That is the thickening of the vessels. In that, there was a trial which they thought that why not work on the walls of the vessels. Therefore, they combined silestazole with isosorbide dinitrate so the vessels will be dilated. I asked, sir, I'm again asking, sir, what is your opinion about that? Because theoretically it looks good.
Yeah. No, I think that's a good point, but it has not come very widely into circulation or in trials, so we are not yet using it routinely.
Exactly.
But I think it's a promising thing. We'll follow it. Maybe in future we'll use it. Or in difficult patients we can use it.
Yeah.
Thank you, Praveen.
Yeah. Thank you, sir, for...
please.
Sorry.
On a long-term basis, because cardiologists also use ticagrelor, but only for 1 year after stent. After that, they go back to single antiplatelet. But you have said 3 months here. That is, but
For ticagrelor only 1 month.
1 month, but it's not to be used long-term, is it, or what do you suggest?
Because you see, the problem is that we are all, as neurologists and or a physician or neurosurgeon, we are all mortally afraid of bleed. And we don't know which day when it will happen. So we want to give this double antiplatelet only as far as it is allowed or minimum period where it is safe. Beyond that, we don't want to go. That is as far as general guidelines is concerned. But then there are some patients who go beyond the guidelines. Many patients in our practice. So if there is a patient who keeps on getting recurrent attacks again and again and again, and he is not stentable also, then in that patient I will mention it that I have no other option than to give him ticagrelor. We do it sometimes as this. So in a given patient you may do it, but not routinely. Routinely after 1 month we should stop it, just to avoid the fear of bleed. It's a very good antiplatelet combination, but comes at the cost of bleed. Yeah.
But with antiplatelet for the aspirin, as I told you, I have 4 or 5 patients who has a bleeding from piles as soon as I start aspirin.
Yeah.
But when I stop aspirin, just give clopidogrel. So we'll give clopidogrel for a long time.
So that
in that
is okay,
case.
sir. That's okay. I think that is that particular patient behaves like that. Yeah, that is clinical medicine. I would agree with
now
that.
again for a follow-up, the aspirin should be given in a brain stroke for 325 mg or 175. 75 is in.
Yeah, 75 is the best dose.
But I don't know. I have seen several cases where they are giving in the discharges. After 3 months also they are continuing 150 mg.
No, better to give 75 because the trials are showing 75 is as good or even better than 150.
But when a neurologist writes a 320, means 150, and as a physician, if he says 75, the patient will not listen.
Anyway, sir, thank you, sir. Thanks. Okay, Praveen?
I know, sir. Many questions, but please, this is very important topic. One more question.
Okay.
Sir, regarding primary prevention, as you mentioned, we see day in, day out, the patient comes with the CT scan showing grade 1, grade 2, periventricular ischemic demyelination, lacunar stroke. As you mentioned, depending on the risk factors and the chances of stroke, we can. Do we need to proceed and get angio for all the patients, a carotid Doppler? Is it must? Because you mentioned more than 30%. As per the guidelines, there is no indication for antiplatelets in a primary prevention. That's what the guidelines, AHA guidelines also mention.
If the patient doesn't have any clinical event, then you need not do all that. In a given patient, you may do it. I mean, if it's your father or mother, that's different. But we are here, huh? Yeah, that's what I'm telling you. And don't do it. See. So no need. If the patient has no symptoms, then don't do it.
Even grade 1, grade 2 periventricular ischemic, irrespective of it.
Not at all.
So, okay, sir.
See this, today it's become almost routine that if you have a head, you have an MRI of the brain. It's so ubiquitous. Everyone has an MRI, with or without any indication. And what happens is MRI is a very sensitive investigation. When it's sensitive investigation, it will show up a few things here and there. But you don't have to jump and say, oh, there are small vessel changes, there are some mild change in the ventricular size or something like that. We don't have to treat all these because this is nature will take care of them. Most of the time they do, and we know we don't need to interfere. Unfortunately, we're interfering and it is causing unnecessary issue because every drug has an effect but also has a side effect. Sometimes the side effect is worse than the effect. And so if you avoid that, I think we tend to do much better. So this, because the MRI report is factual, they are writing there are small changes, periventricular, there are small vessel changes, which is part of what goes on. So we don't treat these. And if somebody comes with absolutely unrelated symptom, definitely no need. And if he has a possible previous stroke, again from, I don't know whether Dr. Subhash, who is the man for stroke, will agree. For me, there's a difference between when you do prevention for a small vessel disease versus a large vessel disease. Especially antiplatelets are very good for large vessel. Preventing hypertension, diabetes, possibly lipids, do that is much better for a small vessel disease.
Yes, sir. Agreed, sir. Completely. Fully agreed.
So one more question. Sir, your comment.
That is the last question.
Yes, sir. Loading dose, regarding the loading dose of the acute ischemic.
Yeah. So you see, the loading dose has to be given in the setting of an acute stroke. Acute stroke in a drug-naive patient. So because this patient, and a non-disabling, so a patient comes with a mild stroke, clumsiness of hand, and you don't want it to develop into a full, you want to do everything possible. So you have to load him. So aspirin loading dose is just 325. So 325 aspirin is only to be given on first day. From second day onwards, it will become 75. Aspirin loading is 325. But clopidogrel loading can be 300 or 600, depending on the various trials. Better to give 300, because with 600 there is a chance of minimal hemorrhage. So yes, for a drug-naive patient coming with the acute ischemic stroke, which is mild and non-disabling, 4 tablets of clopidogrel, 325 aspirin. From next day, 75.
So that's for minor?
That's for minor stroke.
NH less than 580?
Yes, exactly. Yeah.
Thank you, sir.
Thank you,
It was
sir.
a wonderful discussion.
Thank you, sir.
Yeah, all were interested in that.
Thanks, Dr. Mohandas, for your comments.
Now I request Manas sir to present the talk on revascularization in stroke.
Good morning. I'd like to thank Praveen for organizing such an event. But before I present, I just want to ask questions, because after surgery nobody will ask questions, so I start with the question. Can any of you tell what is the role of surgery in acute stroke? Or chronic stroke, both acute and chronic, is there a role? Because we discussed on medical management, Praveen told about intravenous thrombolysis, mechanical thrombectomy. Now Anantram also will tell on stenting, and he told in intravenous stenosis, stenting, antiplatelet fails, he goes for stenting. Nobody discussed on surgery. I just want to know comments of, is there a role or there is no role of surgery in acute and chronic stroke? Yes.
A large MCS stroke with raised ICD.
Yeah, so that you'll do a decompressive craniotomy. That is if the patient has not come in time. He comes late, then when medical management or mechanical thrombectomy or thrombolysis cannot be done. Anything else?
I think there's a very important point to say.
Yes, sir.
Manas is standing on the podium. There's a role for stroke. For role for surgery in stroke. Only thing is, when, what, I think we are willing to listen to you.
Yes, sir. Huh?
Which case? Every case doesn't require. Very few cases selected.
Yeah, so that selected cases is amounting to 10 to 15% of the stroke needs some kind of surgical intervention, and 10 to 15% is a good number of patients which needs. So the aim of including surgical topic is because 10 to 15% needs some form of intervention. So what I'll be talking in this 15 minutes is the indication in those 10 to 15. Means already Praveen has discussed about the penumbra and the core infarct. Now the aim is to save whatever is in the penumbra area. Now the whole algorithm, what is promoted, if you see in all textbook, it starts with medical management and then thrombolysis, thrombectomy. But they ignore the 10 to 15 or 20% of patients who fail this management where surgery is an intervention. So that is why that this topic is included, that when a surgeon's opinion has to be sought for. When you have a thrombus in a large vessel, one can mechanically remove this with an endovascular means. But if you look at history, people were opening the skull and doing direct thrombectomy, opening the vessel and taking out the thrombus and doing it suturing. But then that was not very popular because not many surgeons were available to do this technique, and so it went into disrepute. But now when everywhere thrombectomy has become the SOP, people have started doing that. When 20% of the patient where thrombectomy fails, they do surgical thrombectomy. Take the patient, if the patient has come within 24 hours, when a surgery they have extended to 3 to 7 days, and if thrombectomy fails, they can do surgery, open, take out the, open the artery, take out the thrombus and do anastomosis and re-perfuse the vessel. In addition to that, one can also augment the supply by doing a bypass also. There was a trial done bypass long ago where they said that the bypass was not effective. But then with the emergence of thrombectomy, bypass also is coming back. So that is the reason why there is a role of bypass in acute and chronic ischemia. Fortunately, all the trials, whenever it is related to neuroscience, there is a trial before we follow it. As Dr. Kaul was telling that they stop antiplatelets in 1 month and 3 months. Unlike cardiac, every month we get at least 2 to 4 cases of antiplatelet-induced intracranial bleed from cardiac. We don't get it from neurology because all are evidence-based and they stop it. But from cardiac, they keep on continuing. That's why many patients of intracranial bleed, because of cardiac, we have to treat as an emergency. Now, the effectiveness of doing thrombectomy, mechanical or IV thrombolysis, not only depends on the acuteness, but also the presence of collaterals. Naturally, there are some collaterals. If the collaterals are good, then if one does either mechanical or chemical thrombolysis, then the results are better. But if the patient inherently doesn't have the natural collaterals, then the effectiveness, they fail. Naturally, there are a lot of anastomosis between that picture I'll show you later. Naturally, between the anterior circulation and posterior circulation, there are a lot of communications, which over age it disappears, and 20% to 25% do not have the natural collaterals. Hence, if the effectiveness of thrombectomy many times fails, and that can be surgically created by doing an ECIC bypass. Now, so this a paper came in 2023, just 2 years ago, where they published on incidence of failed thrombectomy, and this is again another paper in 25 on incidence of failed mechanical thrombectomy. And if you see the meta-analysis, it's almost from 10 to 20%, that 26% when you do a treatment in acute setup, they fail. And what do you do for these cases, these kind of cases? And the failure is not because of only an absence of anastomosis, but it can be difficulty in cannulating. If you have a tortuous artery, then they cannot do a thrombectomy. Or in a hospital setup, when the patient has a thrombectomy, patient like a lot of elderly people with fractured neck of femur, or they have surgery for any other disease, and they post-operative period in the first 24 hours, they develop a stroke, then one cannot give double antiplatelets, or they cannot do mechanical thrombectomy, give so much of antiplatelets or thrombolysis. And those cases, one cannot leave, because you have detected them within 4 hours or 6 hours, they can be offered a surgical treatment. It's not that we leave them, nothing can be done, because they have had immediate surgery, thrombolysis cannot be done, thrombectomy cannot be done, but surgery can be done if they are detected in the hospital setup. So there is a role of emergency mechanical thrombectomy. Also, when you have multiple stenosis, you have a carotid stenosis and intracranial stenosis, what can be done surgically in a emergency setup. So if you have inadequate collateral, there is a role for emergency STMC bypass. And when people have done, they did a trial of people who have failed thrombectomy, those 20% of patients, they followed up with continued medical management, and people who had a ECIC, the thrombectomy and ECIC bypass. And the group who had surgery, 60% of them had a better outcome than patients who did not have. That paper has come in 2025. So it is, you can see here, so it's always better to at least offer if the patient accepts. It's not that people have have a negative effect on surgery. They think surgery means it leads to death or it leads to more morbidity, but it's not true. 60% of them have a better outcome than medical management. So these are the different papers. Again, this paper 22, this is the flow augmentation in acute stroke, and it's as an urgent bypass in an acute setting. I'll not be discussing in detail of how to decide, because that's more topic for the neurophysician, but my job is to to make you aware that there is a role of an acute bypass. So what we do in a bypass is we harvest the superficial temporal artery, like here, where I'm harvesting the superficial temporal artery, and then we identify a middle cerebral artery branch, cortical branch here, and so this is middle cerebral artery coming out from the sylvian fissure, and then anastomose the superficial temporal artery. This is superficial temporal artery to the middle cerebral artery. Now, if you have a thrombus like this, we can do an opening on the middle cerebral artery, take out the thrombus, and re-establish flow, and do on the bypass also. So it's like a double hit. You re-establish the primary flow, as well as have an additional augment the flow by doing a bypass. And during surgery, after we finish the bypass, we confirm by doing an intraoperative angiogram. You can see here that the flow is patent. So this is the green color dye which is given to confirm that the patency of the vessel. Yeah, so this is confirming that the bypass is working. So this is again another way of confirming is on the bypass. If you have an intracranial artery stenosis in a chronic setup, this is what we do bypass. And after doing the bypass, we confirm the patency of the flow. So this, as I told, the thrombectomy and bypass has been published long ago in 1952, but because that time number of surgeons who were doing were less, facility was less, and so it went into disrepute. But now with the re-emergence of facility at many places, this is again coming back that 20% who have failed medical and intervention treatment can go for surgical treatment. The other indication for surgery is, as explained, the large MC infarct. Now, if the patient comes late and has a large infarct like this, and this is not uncommon. If you leave, 70% of them die, and or 80% of them will die in 1 week. But then if you do one does a decompression, at least it reduces to 30% mortality. And this is not uncommon. Of all the infarcts who come to emergency, at least 5 to 10% of the stroke, they can worsen because of increase in the infarct. Because if the patient doesn't have adequate collaterals, they can progress to increase in size of the infarct and they worsen. So as I told, 10 to 20% do not have adequate collaterals, and those patients can worsen. And it's difficult to predict during the admission that this particular patient has a collateral or not. And so if the patient has a progressive worsening, one can do a prophylactic decompression or a therapeutic decompression. Now this decompression technique is not very old. It was first described it's 125 years old, 1901, but then it was not popular till recently, till we had a lot of trials proving that decompressive craniotomy helps. In a decompressive craniotomy, one has to do at least 12 to 15 centimeter size of opening so that the ICP will come down. So this is what we do. We make as an emergency, if the patient has worsening, we do a large craniotomy and open the dura and have a decompression. And this is what at least 12 to 15 centimeter size of the bone has to be removed so that the ICP comes down. And this is the post-op scans of the patients who had decompression, and the bone again is replaced back after 2 to 3 months. Now these are the trials which were done, which showed that when patient who had conservative medical management, as I told, they had 80% mortality. By doing a decompressive craniotomy, it reduced the mortality to 22%. And hence whatever neurology is done is evidence-based that if the patient has come late and if the patient worsens, decompressive craniotomy helps. And in acute setup, one can do bypass surgery and thrombectomy. And in the chronic state also, when there is intracranial stenosis, if double antiplatelet fails, there are 2 ways of managing: doing intracranial stenting or doing a bypass surgery. But each one has its pros and cons. I'll not be discussing, but bypass surgery, the advantage is the complications are less, and one need not keep the patients on double antiplatelets for lifelong. So in conclusion, there's a definite role of bypass surgery in a failed mechanical thrombectomy. When you have inadequate access to do thrombectomy, and cases which are not fit for thrombectomy, like a patient, as I told, immediate post-surgery who have developed strokes. And in addition to bypass, one can do a thrombectomy also to reperfuse the flow. And when the window period patient has come beyond 24 hours, in surgery one can extend the period till 72 hours, and some people have done till 1 week also. So there can be a lot of future trials to confirm that surgery has a definite role. Thank you for your attention.
Thank you very much. I think you very nicely summarized the whole thing. And one of the new indications, new to me, is that we can sometimes do even this STIC bypass after a stenting has been done, if the pressure is not adequate to maintain. Dr. Anantram knows about similar cases that where on top of stenting we can do STIC bypass. So for instance, if we have done a tight MCA, we have done a stenting, but in spite of that patient is getting events in the same distribution, then superimposed on that we can even do STMC bypass.
Yeah, that is what is my objection.
Why do you do stenting in the first place, right?
Yeah. Yes, means if you look at literature, surgery has a lesser complications than stenting when there's a failed medical management. But we don't offer that.
Because people like stenting more than surgery. That is the people's...
Yeah, because a lot of literature is backed by means by the stent companies. There are no literature to support a surgeon to promote that this is better.
Role of surgery in hemorrhagic stroke other than the cerebellar hematoma, any other indications? Cerebellar hemorrhage.
In cerebellar in hematomas you're telling, or hemorrhagic? Hematomas, in cerebellar hematomas, if they are more than 20 ml or if there is associated hydrocephalus, then they need hematoma evacuation and treatment of the hydrocephalus. And if the infarct volume also is more than 30 and causing mass effect, they need a decompression in cerebellar infarcts also. And in hemorrhagic also, if there is a raised ICP, decompression has to be done. I did not specifically talk about carotid artery endarterectomy because stenosis endarterectomy, that is a different thing. So I just confined myself to the intracranial disease.
60% which improves, does they improve completely from the stroke? Means clinically, whatever their paralysis or power, everything they regain, everything, or is it? No.
No, the improvement is similar to what happens with mechanical thrombectomy or thrombolysis. When you do thrombolysis or thrombectomy, all of them do not improve totally. It's only 60% of them have full recovery, 40% have.
The 60% has a full recovery.
Yeah, it is similar to that recovery. They recover.
So once the failed medical treatment, we should either consult you or Dr. Anantram, not both.
No, you should first consult the neurophysician. So, yeah.
No, but then
it's
the
not
patient.
That the decision to do stenting surgery or medical management is decided by the neurophysician. It is neither decided by intervention or the surgeon, person or the surgeon.
Yeah, but that's correct. But then the patient who are referred by us will be asking us again and again that should we follow the neurophysician saying stenting or this. So that's a confusion for us also. How to advise them, the patient? Some points which can differentiate us that or the advice to be given to the patient, does it require interventional radiology or does it require surgery?
Yeah, means...
though neurophysician may be telling us, but then what is your opinion about that?
No, means if you want an unbiased opinion, because if you send to a surgeon, he'll always tell surgery. If you send to intervention, he'll tell intervention is better. So if you want to have a second opinion of an unbiased opinion, better send to a neurophysician, so that you'll have an unbiased opinion what is better, and then the patient goes to the particular treatment. Otherwise, if he comes to surgery, he goes for surgery, he goes to intervention.
No, I think this is, no need to make it dissect the whole thing out. The reason is, once the patient comes, invariably, of course, he'll come to the neurophysician. We think it involves everyone, but if it is going beyond medical management, just routine, then we invariably will involve the interventionist, also the surgeon, which one would be a better choice. It should be discussed and looked at which is the best option. For every patient, it is not cut and dry. For every patient, it changes a little. And so based on what your experience is, what is the experience in the institution, what is the experience of the surgeon, what is the experience of the interventionist, all these factors play a role. As I think Dr. Manas put it very well earlier, that previously they used to see, I think I remember in 1976, huge furor over SCA, MTA, this middle cerebral artery bypass, STA, MCA. They said it has come to revolutionize, and then just it went off, disappeared. But it is slowly making a ground. But then you must have the expertise to do it. It's just not because the surgeon is there, every surgeon can't do it. So every interventionist can't do it. And so I think everybody weighs all these options, and each center will evolve. So if you send to your center, I think a neurophysician is going to be the key figure who is going to discuss both with the interventionist, the surgeon, and they feel this is the best option. That's how it goes. There's no cut and dry. You can't tell the patient, this is what I'm going to do every time. And so I don't think you need to worry about it. That once you've gone there, that's how most of it is looked at. Thanks. Yeah. Thank you.
Yeah, even if now a patient comes for a bypass surgery for your opinion to me, I send the patient back to Dr. Kaul, whether he wants to, means in addition to Dharmendra and Amitabh, he wants to try Shah Rukh Khan or not. If he tells he doesn't want, then I go for surgery.
The point regarding the recovery part, sir, the thing is that by the patient comes to hospital, already the core is there. Therefore, that part of injury is already there. Therefore, what we are looking is that to save the penumbra. That's the whole point.
But that may recover naturally.
Yes, that's why
Anantram, you have a point to make on stenting? That's next talk.
Yeah. I request Anantram sir to start for the time being. Yes. Very important topic. Anantram sir is our interventional radiologist, and we hope to have a nice talk.
So, good morning, everyone. So, for a change, I am not in the center of the discussion. So, this will be more or less a imaging talk for the concerned physicians and how we make a report and how to make something out of our report. So if you start seeing most of the times from the MRI point of view, we describe in case of an signal intensity. So signal intensity, whether most of the times we report it is iso-intense to the cortex or hypo-intense or hyper-intense. So whether it is dark, same signal intensity, or whether it is very bright. And most of the times we tend to acquire in 3 standard planes. The first one axial, then the sagittal and the coronal. So most of the times the sagittal is for the midline structures and little bit this way and that way. When we see the coronal sections, they are more for the cerebellum, temporal and parietal lobes. The axials, whenever our area of interest is in the Sylvian Fisher brainstem or in the frontal and the occipital lobes. So these are the 3 planes and how we tend to use them for the image interpretation. And also to study the lobar anatomy. So whenever we want to study from the lesion, from where it is exactly arising and how to identify it, and these are the things we tend to use the different planes. So coming to the very basics, how we identify a sequence. So first of all, we have a look at the CSF. So whether it is completely dark or bright. So whenever we are seeing a bright CSF in the ventricles, then we think it is a T2 weighted sequence. Same if we are seeing a dark signal in the ventricular system, then we see what is happening to the white matter. So if the white matter is dark, we tend to think it is a flare sequence. If the white matter is bright, we tend to think it is a T1 weighted sequence. So here this is a T1 because CSF is dark, white matter is white. So that is how we label it as a T1 weighted sequence. T2, as we already have seen, if the CSF is bright, we take it as a T2 weighted sequence. Same comparing T2 versus flare. So flare, most of the times we want to suppress the normal signal from the ventricles, sulcal spaces, cisternal spaces, we want to suppress. Again, identification is that white matter is dark. So T1, white matter is white. T2, we see at the signal intensity of the ventricular system, which is very bright. In flare, it is dark, and also the white matter is dark. So we have seen the routine 3 sequences, how we identify them: T1, T2, flare. Then other sequence, what we call usually a gradient sequence, or SWI, is nothing but a 3D gradient sequence. So what it will detect us is, it will help us detect the blood products or calcium. So it is very sensitive to the small changes in the magnetic field. So that's why we call it as susceptible. So it is susceptible to the very small changes. So SWI sequence will tend to pick up those things. So if you start seeing here an MR angiogram, so we see a complete cutoff of the MCA. But then if we see here, the thrombus itself is blooming on the SWI sequence. So that is how we picked up the thrombus, and we are trying to say it is a thrombotic occlusion. Then this patient, wherever we are seeing dark and blooming, what we call, we are seeing a hemorrhage. Then we go cut little above, we see a curvilinear structure which is again blooming, which is not there. Compare it always when you have an issue, compare it with the contralateral side. This side, that black structure is very small in caliber. Here it is very much big in caliber. So it becomes a thrombus with secondary CSVT. So that is how we have identified the cortical vein thrombus and also the adjacent parenchymal bleed. So depending on the location of the bleed, we again tend to change our diagnosis. If it is in the subarachnoid space, the diagnosis becomes aneurysmal bleed, basal ganglia, it is more hypertensive. When it is confined to the lobe, then we have a differential diagnosis. So that is how the differential diagnosis will change based on the sequence location. Then how to identify a diffusion weighted sequence? Again, we see the gradation. Gray matter is gray, then white matter will be dark, and finally CSF will be completely black. So outside it will be little gray, then intermediate gray or dark, then completely CSF will be dark. Whenever we see a diffusion, we get three sets of images. One we call B0, second ADC, third is the diffusion. So this is how we get most of the times. The third set of B0 is not given in the filming. So CT scan, flare, diffusion, I told you, again you see the gradation. This will be more bright, intermediate bright, then dark. So this is how you identify the diffusion. And this is the ADC sequence where we want to take off all the T2 effects. And we want to see whether the diffusion, whatever we are seeing, it is a true diffusion or not. And this will be like an inverted image of the DWI sequence. So CSF becomes bright here, then wherever it is there. So the gradation of the diffusion and ADC will change. So whenever we are talking of a diffusion weighted sequence, we want to pick up whether there is any acute pathology like a ischemic stroke is there, or abscess is there, or when coming to the tumors per se, whether it is an hypercellular tumor. So that is what we want to make an inference by seeing a diffusion weighted sequence. Most of the time that will be the first sequence in any MRI to be performed on the patient, so that we don't want to miss any acute pathology. So that is how the diffusion will come. Then coming to the vascular imaging, so MRI, whatever we see, MRA and MRV, they are, for a routine MRI brain, they are performed without giving any contrast. So they are based on different principles how to identify them. For veno, we usually use something like a phase contrast venography. For arteriography, we use time of flight. So we want to suppress the signal from the adjacent structures, and then based on the direction we want to pick up the flow. So if you are seeing like this, the arterial flow goes in, the venous flow comes out. So if you see a blue color, there will be a suppression band to suppress the signal which is coming from above to down. So we are trying to pick up only the signal which is going from down to superior. So that is how we pick up the signal on the MR angiogram without any signal from the venous structures. So we are picking a signal from the arteries without picking a signal from any venous structures. The same thing it happens in case of a venography. We tend to pick up only the venous signal without picking up the arterial signal. So here we are seeing superior sagittal, transverse sigmoid and internal jugular vein. So we are trying to pick up only signal from our area of the interest. So that is one thing. So this is how most of the times we tend to have a routine normal report. So we tend to mention about the ventricular system, parenchyma, then what is happening to the CSF spaces, whether there are any extra-axial fluid collections, then the central structure, cella, paracellular, posterior fossa. Then you start seeing, these are the additional sequences, what we call FISTA is something like a high-resolution imaging where we want to see a very small structures, like in case of a nerves or something. Then CSF flow study, this is an additional sequence to see that how is the flow in the CSF system. Then how is the venogram. So this is how a normal report will be there, and somebody wants to read the report and how we interpret it is something what we go is two types of approaches. One is a pattern analysis. You know how the pattern is already there. So a lesion which is involving cortex and the white matter, wedge-shaped and in an arterial distribution, you know that most of the times there is a diffusion restriction. We are dealing with an infarct. So that we know by seeing the pattern. Then the second pattern what we tend to do is, whatever I have mentioned in the previous report, we tend to aggregate all the findings in the report. So we see small vessel ischemic changes here, then we see multiple infarcts, then we see microbleeds, how they are distributed. If they are distributed in the previous slide, as I shown, more in the basal ganglia. You combine the three imaging features and then make your impression that we are dealing with a chronic hypertensive changes. Then again, most of the times it goes back to the basics. Where is the location? If we are seeing an enhancement which is confined to the gray matter cortex, then we tend to see whether it is we are seeing a ischemia in the subacute phase, postictal phase, or in the meningoencephalitis. The same thing, if you are seeing a ring enhancement within the white matter, we tend to think that whether we are dealing with an abscess or a neoplasm. So yesterday I was going through a report where it has been reported somewhere else. So final impression whatever they have given was it could be a sequelae to gliosis 1. It could be a neoplastic lesion, second. And third, it could be a demyelinating lesion. So they have given 3 differential diagnoses in the impression. So if sometimes we give all the differential diagnosis, means then we are not concluding anything. So impression is there to conclude something which will be the first in the order. So going by the basic routine analogy also, so though it was a cortical based lesion. So cortical based lesion, if we are seeing exerting mass affect something like in gyral expansion which is happening, then we tend to place the neoplasm in the first point. Then if you are seeing a significant amount of gliosis which has happened around the lesion, then we tend to put as, we are thinking it is a sequelae to the old insult. But if we are having a lesion which doesn't have that much mass effect, that is what we call volume neutral, then we tend to think that whether we are dealing with an demyelinating pathology. So this is what a basic idea we should tend to make from whatever the findings we are trying to have in the images. Then coming to the number of lesions. So if you are seeing a solitary lesion, we tend to see whether it is a neoplasm versus hematoma, abscess versus an infarct. So the advanced sequences will tell us further defining these 4 differential diagnoses. Multiple lesions, we tend to make it a different way. But remember that most of the times whenever we see metastasis, we think multiple lesions metastasis, but most of the times the initial presentation will be around 60% will have a single lesion before it becoming multiple lesions. So solitary lesion, always metastasis also will come into a list of differential diagnosis. Whenever we are seeing calcification, we tend to pick it up with an SWI or gradient sequence. We tend to think the differential diagnosis more or less whether we are seeing some sequelae to infections or vascular etiology. neoplastic etiology, calcifications, there is very few differential diagnoses. Once we are picking it up, we make a diagnosis of whether we are thinking with oligodendroglioma, meningioma, or craniopharyngioma, the common neoplasms. Otherwise, we tend to incline towards a different set of differential diagnosis. Hematoma versus a neoplastic lesion. So, if you start seeing a acute hematoma, it will have a different signal intensity. Again, this is what sequence from the audience. So T1. So why? Because the CSF signal intensity is dark, white matter is white. Then this is what sequence? T2. Again, we have seen by going by simple analogy that CSF is very bright. This is the hematoma, whatever we are seeing in an acute phase, where it is T1 almost similar signal intensity to the cortex, T2 it is dark. And then we are confirming it by, this is what the SWI sequence, there is blooming. So as the hematoma evolves, the signal intensity also will change. So the same hematoma, if it is there in the subacute phase, it will be very bright on T1 and T2. So signal intensity on both combining T1, T2, then we tend to make a diagnosis of whether we are dealing with an hematoma or not. That is one thing. And what stage it is there also, you need to grade it. And as I shown the normal report, flow voids are the things what we usually tend to see in case of a T2 weighted sequence. If you start seeing, this is the MCA where we tend to see a lot of flow void. But in addition to that, on SWI, we are seeing multiple dark and then tortuous structures which are there. So normal flow voids is one thing, whether they are there, whether they are absent, also we have to make a conclusion. Previously, it was the arterial aspect where we have picked up so many flow voids. This raised the suspicion of a dural AV fistula, that is one thing. And this one, a hematoma in the basitemporal lobe, which has raised the suspicion of an thrombosis within the sinuses. So this is what we are seeing. Loss of normal flow void means which should be a darker. When we miss it, then we tend to make a diagnosis of it. Then wherever we are trying to use a high resolution imaging, this depends on our whatever the clinical request, how it comes, whether we are trying to pick it up some lesion near the cranial nerves, or whether we are trying to pick up very small lesions, or whether we are trying to pick up any lesion which is causing a neural and vascular conflict. Different vendors, they have different names, but this is how it will happen. So here if we tend to see, wherever we are seeing a vessel is there in close contact with the trigeminal nerve. So this is what we tend to call it as an neurovascular conflict. So if you want to see it, you need a very high resolution. Usually whatever the MR sections which are done, T1, T2 and FLAIR, they are at least around 4 mm sections. But 4 mm, if we lose in those sections, we tend to lose the cranial nerve itself only. So you need a high resolution, that is 1 mm sections, and which are 3D. You can reconstruct them into the previously mentioned axial, coronal and sagittal planes. Here we have reconstructed the axial images into a coronal, and then we are showing clearly where the nerve is getting impinged by the artery. It is getting impinged on the superior and medial aspect. Then coming to the picking up of very small lesions like a neurocysticercosis, we are seeing edema, we are seeing a lesion on T1 hypo, and we are seeing contrast enhancement. But until we do the high resolution imaging and show this speck of scolex which blooms on the SWI, then we have concluded the diagnosis more or less whatever we are seeing a ring enhancing cystic lesion, it is a neurocysticercosis, whatever we are dealing with. Then coming to the diffusion, we have discussed previously. So if you are seeing a central diffusion restriction, two things we usually tend to make is whether we are seeing a necrotic tumor itself or an abscess per se. So if the entire lesion is showing diffusion restriction, then sometimes we tend to make a diagnosis of lymphoma. Cysts, to make a differential diagnosis, if we are seeing a diffusion restriction within the cyst, we tend to make a common diagnosis of epidermoid cyst. That is how. So if you start seeing this lesion per se, this is again on T1 hypointense, T2 hyperintense. But if you start seeing the rest of the findings also, T2, it has got a very thin and also a hypointense rim. So it is not a very thick rim around the lesion and which is irregular. So it is a thin hypointense rim around the periphery of the lesion. And then if it is showing these lobulations like this, again this is a diffusion weighted sequence where we are seeing bright diffusion restriction corresponding with an ADC. Then we are very sure that we are dealing with an abscess, not with an something like a necrotic lesion per se. Again, we are seeing a cyst within the CP angle region where we are seeing T2 very bright, T1 hypo. We are not able to make a diagnosis, but if you are seeing a diffusion restriction within the cyst, here we are very bright on DWA, dark on ADC. Again, with confidence, we can tend to make, we are dealing with an epidermoid cyst rather than arachnoid cyst or something else. Then coming to the contrast per se, if you start seeing the enhancement pattern, we classify whether the dura is enhancing, that we call pachymeningeal enhancement, or the pia and subarachnoid enhancement. Again, we see how is the enhancement. If you start seeing here, it is very thin and linear. White color is the enhancement, whatever we are seeing, thin and linear. Whether we are seeing bilateral, this is we are seeing bilateral, then we are seeing unilateral. Unilateral will have a different set of differential diagnosis, bilateral will have a different set of differential diagnosis, and again a thick and nodular enhancement will have a different set of differential diagnosis. So this is how not only the enhancement, what we tend to see, how to classify this enhancement. Enhancement, as I told, you have to take into account when comparing all the sequences. You have to put T1, T2, flare, and then enhancement. So T1, T2, and flare, we are seeing ventricular dilatation with some amount of transependymal seepage, and then we are seeing this nodular lesions, perilesional edema. Then we see the enhancement like this. Enhancement along the basal cisterns, then along the sulcal spaces, then small ring enhancing lesions, and then the enhancement along the surface of the brainstem. Then we are trying to make that more or less we are dealing with the tuberculomas with the TB meningitis. So put T1, T2, flare, everything, and then we make a diagnosis. The other part we tend to look is from where the lesion per se it is arising, whether it is arising from outside the brain, that is extraaxial, or within this parenchyma, that is the intraaxial system. So again, we tend to see most of the times we go back to the location, size, and distribution, and then we tend to make a diagnosis. If it is confined to the cortex diffusion restriction, we think of a different diagnosis. If it is in the white matter, we think of a different diagnosis per se. Extraaxial, wherever we are talking is, we tend to see that whether the lesion is arising from the meninges or along the nerves which are passing. Most of the times we take it as a rule that all the extraaxial lesions and non-glial lesions will show contrast enhancement. So that is coming to the basic contrast enhancement, that is how. But to differentiate whether it is completely arising outside the brain parenchyma or within, we tend to see a lesion, how it is on the outside, how it is on the margins, how it is in the middle, how it is towards the inner aspect. So if you see the outside of the lesion, taking meningioma as the one classical lesion, so it will have an outside vascular supply. Inside it will displace the pial vessels. At the margins we see the widening of the subarachnoid spaces. So extraaxial will have a broad base towards the dura. They will have a dural tail. Then at the margins there will be widening of the CSF spaces. Then in between we will have this red one is the CSF and pial vessels. Then inner will be the cortex, which will be compressed, and it will be compressed in this shape of every gyre will come close on in skin. So again, this is what sequence? T2 CSF is bright, but if you see the lesion, which is broad based towards the dura. Margin CSF is widened. The small things, whatever we are seeing the vasculature with bony changes. Then we are seeing the CSF here along with the displaced blood vessels we are trying to see. That is which will happen in case of large lesions. Very small lesions, sometimes depending on the location, it will tell us from where it is occurring. This is a very small lesion without no mass effect on the adjacent parenchyma. Very large lesions can have a very ill-defined interface with the adjacent parenchyma per se. Third point, whatever we are trying to mention in this is whether there are any extra-axial fluid collections. Most of the times we tend to see the flare is the best sequence where we tend to see the extra-axial fluid collections, whether it is the meningitis or the subarachnoid hemorrhage. We tend to look it and tend to identify. So if you start seeing this is the flare sequence, we see a well-defined bright lesion on flare sequence trying to compress the dura insides. Then gradient sequence, this is black and blooming. So this is how we tend to identify T2. It can have a varied signal intensity, but if you want to say whether there is any extra-axial fluid collection or not, we tend to see the flare sequence. Same here, we are seeing along the left sylvian fissure, very bright signal extending into the adjacent sulcal spaces. Angiogram showing a MCA bifurcation aneurysm. So flare is the one which will tell us whether there is any extra-axial collection is there or not. Then just to summarize whether we are dealing with most of the times whatever report we mention in most of the frequently whatever we tend to see is whether we are dealing with a small vessel ischemic changes or anything something with the demyelination. Everything looks bright on a flare sequence. Again, the classical points which will go will be the location, the distribution, and again size and shape. So if you start seeing here, at least in the sagittal sequence, the lesions are perpendicular to the ventricular margins. So orientation is a bit different. The same lesions, if you tend to see more often frontal and parietal lobe lesions which are very prominent, then we tend to see more or less it is more we are dealing with ischemic lesions. But if you see temporal lobe lesions more, then we tend to think whether we are dealing with an demyelination. Within the same area, how they are distributed. If there are predominantly central changes, we think in the pons, we think more often ischemic changes. But they are there within the periphery and oriented like this, we tend to think whether we are dealing with an demyelination. So supratentorial distribution, more of a vascular pattern. Infratentorial with a peripheral distribution, we think of a more of a demyelination pattern. That is how we tend to see the hyperintense foci wherever they are distributed on the flare sequence and then make some conclusion. Whenever we are seeing a fusiform lesion, we tend to think these are more or less a perivascular pattern and more in favor of a demyelination. So that is how we tend to see out of all the shape of the lesions, if we see a fusiform or ovoid pattern, we tend to think more of an demyelination. That is one thing. And as I told you, you have to combine all the findings and then make a diagnosis. So if you are seeing white matter changes, small infarcts and deep microbleeds, we tend to make more or less chronic hypertensive encephalopathy changes. If these above findings are not there with a predominantly peripheral microbleeds, then we tend to make a diagnosis of amyloid angiopathy. That is one thing. And to see the longitudinal distribution of the lesions, whether they are all in contiguous, if they are there, everything in contiguous, there will be one different set of diagnosis. If they are longitudinal, multiple lesions scattered, they will be different. So if they are contiguous in the brainstem, we tend to make a diagnosis of neurobichids or tumors. Spinal cord, it is again different set of differential diagnosis. You tend to make whether it can be vascular, whether it can be autoimmune, or whether it can be a demyelination or neoplastic. But if they are there longitudinally, extensive spinal cord lesions, here we are not able to differentiate between all the three. But if you break them up into, there are scattered lesions, brain, spinal cord, optic nerve, then you are dealing with a demyelination. Within the demyelination, you have to break between whether you are dealing with NMO MOG or multiple sclerosis. So scattered lesions in 3 different portions will make a different set of differential diagnosis. Spinal cord, if they are there on one side, short length, we tend to make multiple sclerosis as a diagnosis. That is one thing. Even in case of an optic nerve, if the involvement is there, if they are more periventricular lesions, then we tend to make NMO. If they are predominantly within the basal ganglia, thalamus, and in the brainstem, we tend to make a different set of diagnosis. So this is what unilateral small multiple sclerosis, more of an anterior involvement of optic nerves, it MOG. Around the chiasm, it is NMO. Again, in the spinal cord, whether we are seeing caudal involvement goes more in favor of a MOG. Then NMO is more cervical and also upper thoracic. Scattered lesions go in favor of a multiple sclerosis. Coming to the brain, if they are predominantly around the margins of the ventricle, we tend to think more of a NMO. MOG is more or less, as we told, a posterior fossa involvement if you are seeing. Then ovoid lesions in the supratentorial compartment, we tend to think of a multiple sclerosis. So this is how that overall how to we break up the lesions, how to read the report, how to interpret the findings, and how to come to a conclusion. So with this, I want to end my talk, and I would like to thank the organizing committee for giving me this talk. Thank you.
Thank you, sir. We will have an inauguration now. The questions for this session we will take after inauguration. I request Bhaskar Rao sir, Mohandas sir, Manas sir, Kaul sir, Sita madam to come for the lamp lighting ceremony. Madam, please. Varalakshmi madam. Yesh madam. Please, please. Randi madam. Madam, please. Yeah. I request Mohandas sir, neurologist to please come and talk about it.
Good morning, everyone. Thank you, Praveen. It always gives an opportunity of how things have changed. To think back on how we started, when we started neurology, it was purely clinical neurology. I think now a lot of people are forgetting clinical neurology. But I think it's still very much a valid, most important part of neurology, that you do know how to examine a patient, how to talk to a patient, how to take history from a patient. History and examination alone can fetch you the diagnosis significant number of times. Then you have to confirm at that point of time with the investigation which is available, and then you have to take a call on which investigation you do. Now, when I was working as a lecturer at All India Institute after my post-graduation, the new first CT scan, which was for patient use, came to India. That was in 1978. And that was April. And when we saw those very, very, what do you call, dirty sort of pictures, actually it was is very low intensity, it was, the pictures were, but you could see the brain. I mean, it itself was a wonder. We thought, we used to see only sections of the brain in autopsy. When the CT scan came, we started seeing the brain alive. And then, so it gave us a big jump. And but when MRI came, and I was lucky again that I was there in the institution, and one of the earliest MRIs came to KIMS in '89. That was a 0.3 Tesla MR, but it showed a change. And that's when I predicted that MRI will outscore CT in most of the instances. CT has its role, there's no doubt, nobody should deny that. But MRI has its great propensity for permutations and combinations. And these permutations, combinations make what Anantaram told us today sounded very simple, but they're not that simple. They're not that simple. You have to know the exact sequence with which we are dealing with. The same thing will totally look different in these sequences with that. And so you will tend to confuse it unless you have a background of it. And to keep pace with it, for every neurologist who is working in practice or who is working even in an institution like this, even me, I'm finding it difficult now to keep pace with what developments have really happened, and they've really gone way ahead. And so I think, few years ago, I stopped really seriously looking at an MRI because I pick up and ring up 6154. Anant, please tell me, what are we dealing with? Because I'm thinking this. But one good thing is, when I think this clinical diagnosis is this, and Anand says, yes, sir, that is what exactly is there. Most of the time, I'm not saying always, but most of the time he says, yes, I agree with you that that's what is seen very clearly. Because, in the sense that I have sort of left that responsibility of again spending so much time sitting together in front, straining your neck, especially with my spondylitis. So I don't do that. I look at my patient, I make a diagnosis, I ask my colleague. And if I think this is a surgical, I ask my colleague. I said, please go meet this gentleman, think they agree with me, then they'll operate. If they don't agree with me, they won't. And I think that is the key of working in an institution. And that means you have people who will help us make a better decision, and for that is ultimately it is going to count to the patient. It's going to cost less, come out easier, and then live a much better life, and which is what we are all looking for. I think patient is the ultimate. He is our customer. He is our God. And I think that's, people remember, I think they will do the right thing by everybody. I congratulate Subhash and Praveen for organizing this, and I think more and more of such interactions will be very helpful. Thank you very much.
Thank you, sir. Thank you, Bhaskar, sir. Sir has a meeting, one more meeting. You could make out time for us. Thank you. In fact, this was a brainchild of Sita Madam and Kaul sir, especially, and also Mohan Das sir, who told that we should have an update. And this was ably supported by Pantosit division of Sun Pharma. This was a recent. This was the reason. And one thing is that MRI. Any questions are there? If you will take now. After that, we will have a 15 minutes tea break. Any questions?
Or we can have a tea time also.
Yeah, sure. If no questions, we will break for tea. Within next 15 minutes, we will join for next good session on seizures and encephalitis.
Hyper generalized onset can be also motor or non-motor. Non-motor generalized means absences we have. And we can have an unknown onset. And last we can have a focal to bilateral tonic-clonic. So simply defining a seizure. How we classify epilepsy per se? Epilepsy, it can also be focal, generalized epilepsy, combined generalized and focal, or an unknown. And we have different epilepsy syndromes. So this was just a brief introduction about this. Now coming to the main topic, principles in the management. How we manage epilepsy. So first step in the management is we have to identify the correct diagnosis. It's very important to actually rule out the mimics of seizures like a vasovagal syncope, cardiac arrhythmia, non-epileptic attacks or psychiatric comorbidities which frequently mimic seizure. In step 2, we classify the epilepsy types. First of all, we have to syndromically classify each patient's epilepsy, whether it's a focal, generalized, focal to bilateral tonic-clonic, because the commonest cause of a treatment failure or even the seizure aggravation is incorrect classification of syndrome or a seizure type. For example, a patient with an unrecognized JME, if we didn't recognize the JME, he could have been devoid of treatment with valproate. Similarly, a patient with absence and myoclonic seizures, if he is not diagnosed properly, he could have given sodium channel blockers that could have worsened his phenotype, that could have worsened his seizures. Coming to step 3, we have to choose an anti-seizure medication with the optimum drug dosage and optimum compliance. Because unless the optimum dose is prescribed, anti-seizure medication is failed to control the seizure satisfactorily. Also, on part of the patient, there has to be a good compliance to take that anti-seizure medications. Then there comes the lifestyle modifications. Why it is important? Because there are notable triggers that can aggravate the seizures like emotional stress, sleep deprivation, alcohol usage, some sensory stimuli in case of generalized epilepsies. Attempt should be made to identify these triggers and correct them whenever possible. So after these 4 steps of management comes the use of anti-seizure medication. So there is an important dictum in anti-seizure medication that the drug should be used as per the 3 important points. What are those? Type of epilepsy, as I told previously. Dosage should be adequate, as I told, and duration should be adequate. So in these 3 important points, anti-seizure medication should be given. So once we have chosen the anti-seizure medication, based on these 3 important points, then we give an adequate trial of anti-seizure medication. That means we have to systematically increase the dosage and plasma drug levels until seizures are controlled or intolerable adverse effects appear. Now, what happens when we have given the anti-seizure medication with appropriate dosage, appropriate duration, appropriate type of epilepsy? Then what happens? If there is a failure of first anti-seizure medication monotherapy, there are two options to consider. One could be lack of efficacy, other could be poor tolerability. But before labeling as lack of efficacy, we have to exclude four important things. What are those? Whether the anti-seizure medication was appropriate for the type of seizure or epilepsy, whether the treatment adherence was okay, whether there are any drug interactions, or whether the dosage was very low. So once we have ruled out these 4 points and we label, okay, there is a lack of efficacy, then comes the second option of dual therapy. That is, with the monotherapy, we can combine another anti-seizure medication. Second point could be of failure of first ASM monotherapy could be poor tolerability. Poor tolerability could be because of any idiosyncratic reaction, or it can be because of dosage related adverse effects. In that case, we have to alternate the monotherapy. We have to shift the monotherapy. So after touching the brief points about how to select, how to get upon that anti-seizure medication point, now I'll be talking about how we have to choose the anti-seizure medication based upon type of epilepsies. Number 1 comes the generalized tonic-clonic seizures. Now, first ASM monotherapy in case of a male or a female who is not planning pregnancy, valproate we choose. In case of female with childbearing age, options are lamotrigine or levetiracetam. And when this first line monotherapy with valproate fails in case of males and females not planning pregnancy, then option is lamotrigine or levetiracetam. That is the first line. Now what happens if this first line monotherapy fails? Then we have to consider add-on options. What are the add-on options? In the first line add-on, we'll consider clobazam, perampanel, brivaracetam and topiramate in case of a generalized tonic-clonic seizures. And what are the second line add-ons? That are the lacosamide, zonisamide and phenobarbital. Coming to our next epilepsy type, focal seizures. In focal seizure, ASM monotherapy options, first line monotherapy, if the patient is a child, then oxcarbazepine we have to choose. And if he is an adult, then carbamazepine we have to choose as a ASM monotherapy for focal seizures. What are the second line monotherapies? Valproate, lamotrigine and levetiracetam. What are the add-on options we have to consider if this first line monotherapy fails? Then first line add-on therapy are, in case of focal seizures, phenytoin, phenobarbital, lacosamide and perampanel. What are the second line add-on therapy? If this first line also fails, then we can think of adding a carbonic anhydrase inhibitors like topiramate, zonisamide or vigabatrin or tiagabine. Coming to our third epilepsy type, absence seizures. In absence, the monotherapy first line gold standard ethosuximide. Add-on therapy with the synergistic effect, valproate. If this third line monotherapy, if both of these therapies also fail, then what are the add-ons to consider? That are levetiracetam and lamotrigine in case of a absence seizure. Now, when the absence seizure combines with other epilepsy phenotypes also, when alone absence is not there, other seizure also they are overlapping. In that case, the first line monotherapy, if a patient is a male or a female not planning pregnancy, we have to consider valproate. And if there is a female of childbearing age with epilepsy absence plus other phenotypes are there, then we have to consider lamotrigine or levetiracetam. And what are the second line to consider in this case is ethosuximide, if absence with other seizure types are there. Now this is a very important slide. What are the drugs that are contraindicated in absence seizures? They are the notable sodium channel blockers that have a property to exacerbate the absence seizures, like carbamazepine, oxcarbazepine, phenytoin, phenobarbital, gabapentin, pregabalin, vigabatrin. So these are to be avoided in case of a absence seizure. Coming to our fourth seizure type, myoclonic seizures. Now in myoclonic seizures, what are the first line monotherapy? If a patient is a male or a female not planning pregnancy, valproate we have to consider in myoclonic seizures. If the patient is a female of childbearing age, levetiracetam we have to consider. And in the first cohort, if valproate fails, then also levetiracetam we have to consider. What are the add-on options? If the myoclonus is not being controlled with the first line therapy, add-on to be considered are clobazam, clonazepam, lamotrigine, topiramate and zonisamide. As like abscenses, there are drugs which can worsen the myoclonus also. Like we have carbamazepine, oxcarbazepine, phenytoin, pregabalin, gabapentin, vigabatrin. So we have to take a note of these drugs that they can worsen the myoclonus. In case of idiopathic generalized epilepsies, which are called genetic generalized epilepsies, what are the options we have? First line monotherapies are, in case of a male or a female of childbearing or female not planning pregnancy, valproate we have to choose. And if valproate the seizures are not being controlled with valproate, option are lamotrigine or levetiracetam. And these both the drugs are safe in female of childbearing age, because in that case valproate we cannot use. What are the second line add-on we have to consider? If these first line fails, we have options like perampanel and topiramate in case of idiopathic generalized epilepsies. So, in all the 6 epilepsy types, as I told, we start with the monotherapy. If the seizures are not controlled, we build upon with the add-on therapy. We consider the second line monotherapies, and we further consider the add-on therapies. So what it infers here is monotherapies are preferable, but reality is polytherapy. From this polytherapy, there comes a concept of rational polytherapy. What is rational polytherapy? It refers to intentionally we are choosing a second anti-epileptic drug to enhance the seizure control. But we have to think upon important dictum here is that 2 anti-epileptic drugs should be chosen with a different mechanism of actions. Then only synergistic effect can be obtained. But if we'll choose the drugs with the same mechanism of action, then adverse effects will increase, duration will be limited then. So what is the evidence of rational polytherapy? The best evidence comes from the network meta-analysis and real world experience studies. Though there are not any direct RCTs are there corroborating the rational polytherapy, the best evidence is from the network meta-analysis studies. So now comes the second question. If rational polytherapy is the rule, how we have to combine the anti-seizure medications? So here comes the basic principle. We have to combine the drugs with a different mechanism of actions. Like we can give a sodium channel blocker like a lacosamide or lamotrigine, and we have to combine with a non-sodium channel blocker like valproate or levetiracetam. Then we have to use, there are some RCTs, there are some experience-based studies that gives us the better efficacy drugs. Combination regimens they give, like combination of carbamazepine with levetiracetam in partial epilepsies. From our they give a better efficacy. Favorable, we have to choose a drug with the favorable pharmacokinetic interactions, like levetiracetam, lamotrigine, lacosamide. They have a favorable pharmacokinetics. We have to avoid the combinations with a similar mechanism of actions, like combining phenytoin with carbamazepine, or combining carbamazepine with lamotrigine. So they have a similar mechanism of action. So that is here has to be avoided. So this is a study being published in the JAMA Neurology. So what they told is, their inference was that combining the drugs with the same mechanism of action can lead to shortest persistence, can lead to greater hazard of discontinuation. So here we can see that when we are combining a GABA analog with a GABA analog, the duration of therapy is most minimal actually, because both the drugs we are combining of the same mechanism of action. But when we are combining SC with SV2, means sodium channel blocker with a SV2, like a levetiracetam we are combining with, then the duration of therapy also increases. The risk of shortening the therapy also decreases. So longer therapy we can give here. So the dictum is we have to combine the drugs with the different mechanistic actions. So as I told that there are some network meta-analysis studies, there are real world experience. So that actually has given us some duo therapies which are very optimum and which have given a good result. What are those? Like a combination combining valproate with lamotrigine is a very best duo therapy regimen with synergistic action. Combining carbamazepine with valproate, again a synergistic action. Levetiracetam with lamotrigine, levetiracetam with valproate, lamotrigine with topiramate. So these are some notable duo therapies from the meta-analysis that have given a best combination regimens. Similarly, there are some triple regimens also. What are those? Like combining valproate, lamotrigine with topiramate, triple regimens. combining valproate, lamotrigine and levetiracetam. Combining lamotrigine, levetiracetam with a carbamazepine. So here we have different mechanism of action drugs which we are combining to give a triple regimen with the best optimum outcome. This table I have put to just make us aware about what are the common dosages, how we have to maintain the dosage, and what are the maximum dosage we can go on. So these are some notable drugs, like for example phenobarbital. Phenobarbital starting dose what we have to keep is 30 milligram. We have to maintain the patient on 60 to 90 milligram, and maximum 180 milligram per day is the dosage. Similarly, phenytoin. Phenytoin dosage starting is 150 to 300 milligram. We have to maintain the patient on 300 milligram and maximum 500 mg per day in divided dosage we can reach. Similarly, carbamazepine. Carbamazepine 100 starting doses, 100 to 200 mg BD we can give, and then maintain up to 200 to 400 mg. Oxcarbazepine starting dose 150 mg BD, maintenance 300 mg BD, up to 600 we can go, and 1200 mg BD is the maximum dose. Lamotrigine. Lamotrigine has a risk of Stevens-Johnson syndrome, reactions it can cause. That's why slow we have to go. 25 mg tablet, 1/4 we give, escalating to half and half, then full and full, and then gradually we can build up the dose slowly, and maximum will be right around 300 mg BD we can go. So this is just a note, most of the common dosages I have given for the common anti-seizure medications. Levetiracetam, starting we can go for 500 mg BD. We'll maintain 500 mg BD, and then maximum 2000 mg BD we can go. Then this table I have put for what we should know about what are the common adverse events, what are the common adverse effects of a notable anti-seizure medications that as a physician we should know. What are those? Like phenobarbital. Phenobarbital notable side effects we have are sedation, depression. Phenytoin, very important notable side effects to remember are the nystagmus. It can cause ataxia, diplopia at high doses. It can cause the ataxia, diplopia. Gingival hyperplasia it can cause, hirsutism, hepatotoxicity. Then carbamazepine, notable side effect rash. It can cause hyponatremia, particularly in the elderly population. Oxcarbazepine, again hyponatremia it can cause. High doses can cause ataxia also. Rash is a risk for carbamazepine, oxcarbazepine. Lamotrigine, as I told, we have to start the dosage of lamotrigine very slowly, and slowly we will escalate. Why? Because a notable risk of Stevens-Johnson syndrome, hypersensitivity rash. Topiramate. Topiramate at high dose, some patients they'll present to us with language or cognitive dysfunctions. They can cause circumoral paresthesias, very notable side effect. Weight loss, renal calculi. So a patient we are putting on topiramate, we have to advise a ultrasound for checking the renal stones. Similarly, glaucoma. Glaucoma exacerbation can be caused by topiramate. So eye checkup we have to advise. And patient with existing renal stones and glaucoma, topiramate is not the drug we have to put. Similarly, zonisamide, also a carbonic anhydrase inhibitor, renal calculi is a risk. Levetiracetam, very important, behavioral problems, psychosis exacerbation it can cause. Lacosamide, high dosage, sometimes the patient comes to us with dizziness and nausea. They don't tolerate the acute side effects. So lacosamide can cause dizziness, nausea. Parampanel also, severe mood and behavioral disturbances it can cause. So these are the notable side effects which we have to keep in mind before prescribing these drugs. So now I have told about monotherapy, I have told about how we'll bridge, what are the add-ons to consider. Rational polytherapy is the key, preferable thing. Now what happens if the polytherapy also fails? In that case, we have to refer the patient to a tertiary epilepsy care center where the patient has to undergo a pre-surgical evaluation, and we'll consider that, based upon that we'll consider whether a surgical option can be given to the patient, or we have to choose a non-pharmacological measure like a vagus nerve stimulation, DBS, like these kind of things. So there comes the option if the polytherapy also fails. Now I am just listing about some special scenarios which we have to keep in mind of prescribing our anti-seizure medications. How we choose anti-seizure medication in a woman? See, in a woman of a childbearing age, the major risk of anti-seizure medication which it can cause are the congenital malformations. So we have a high risk of congenital malformation drugs, we have an intermediate risk, and we have a low risk. High risk are the valproate with a risk of congenital malformation up to 10.3%. Intermediate risk drugs we have phenobarbital, phenytoin and topiramate with the risk ranging from 5.5 to 6.5%. What are the low risk drugs we have? The top list is levetiracetam, risk potential 2.8%, lamotrigine 2.9% and carbamazepine 3%. See, this is in the recent Continuum Epilepsy 2024 edition, this table was there where they have actually in the x-axis we have anti-epileptic drugs and their dosage relation, and on the y-axis we have the odds ratio of congenital malformation, how much it is. Here they have chosen lamotrigine at 325 milligram dose as a reference point. Lamotrigine, that is chosen as a reference, and all the other drugs have been compared with the lamotrigine, how their dosages can cause the congenital malformation. So here we can see that valproate at a very high dose odds ratio is highest in causing the congenital malformation, followed by phenobarbital at a high dosage. Other than that, the drugs like phenytoin, topiramate, they are also having a higher odds ratio. Even carbamazepine at more than 700 milligram, valproate at 650 are also having a moderate to high risk in causing the congenital malformations. But the drugs like levetiracetam, oxcarbazepine, lamotrigine, they have their odds ratio very close to 1, very close to our lamotrigine reference point. So they are considered to be the safe with the non-significant risk for the congenital malformations in comparison to the drugs with the high dosages. Very important dictum to follow in case of a female with childbearing age is, when we are giving anti-seizure medication, we have to give, if the patient is sexually active, we have to give a folic acid supplementation at 0.4 milligram to 4 milligram per day. It's recommended. Even if the patient is not seeking pregnancy at this time, folic acid supplementation is the key. Coming to our second scenario, how we choose anti-seizure medication in elderly age group. In elderly age group, in the elders actually there are notable drug-to-drug interactions. In the elderly age group, the anti-seizure medications which are inducers and inhibitors, they are also have a notable interactions, and they have multiple comorbidities on the baseline. So choosing the anti-seizure medication is very difficult. But the dictum is, in older adults, we have to start low, go slow and stay low in the elderly age group. Important notable etiologies to be considered in the elderly age group are stroke, neuroinfection, trauma. But still 50% cases etiologies are not found. Even neurodegenerations also contribute to a significant proportion of epilepsy. But in elderly age group, focal seizures are the most common type. Now, what are the drugs to be anti-seizure medication to be considered in the elderly? See, in the focal onset, as I told, in elderly age group, focal seizures are the predominant subtype. So there are some guidelines according to ILAE, American Academy of Neurology. They have given lamotrigine as level A drug to consider in the elderly age group, followed by carbamazepine. And the drugs like levetiracetam, phenytoin, pregabalin, they are the level E drugs. But other seizure types like generalized tonic-clonic, myoclonic, they have no major data found, and they are also not very predominant subtype in the elderly age group. But whatsoever, newer anti-seizure medications are actually preferable over the older ones in the elderly age group. Coming to a scenario, a patient comes to us with a pre-existing liver disease. What anti-seizure medications we should think of? Newer anti-seizure medications with the very minimal hepatic metabolism are levetiracetam, lacosamide, topiramate, gabapentin and pregabalin. These 5 drugs are metabolized by renal excretion, so they can be chosen in case of a patient with hepatic encephalopathy or a coexisting liver disease. Even for status also, levetiracetam and lacosamide in a pre-existing liver disease comorbidity, they can be considered after the first line benzodiazepines fails. And what are the drugs to be avoided in patient with liver disease? Valproate, phenytoin and falbamate. In coming to patient with a renal disease, CKD patient or a renal disease patient, there is a high chance of nephrolithiasis can be seen, as I told previously, topiramate, acetazolamide, zonisamide. These are carbonic anhydrase inhibitors. They can cause a high chance of kidney stone formation. Even valproate can cause Fanconi syndrome rarely, and so renal dose adjustment we have to do in the drugs which are renally excreted. What are those drugs? Notably levetiracetam, lacosamide. These are renal excreted drugs, so dosage modification has to be done in a patient with the pre-existing CKD. In cardiac diseases, what we have to think of? cardiac disease, there are some drugs which have the hyperlipidemia, or they increase the production of inflammatory molecules. They cause weight gain, like valproate. Weight gain is there. Clobazam also, oxcarbazepine. So weight gain and metabolic syndrome it can cause. So in these patients with the pre-existing cardiac morbidities, we have to think with caution. And also sodium channel blockers like lacosamide, they can cause actually in the patient with a pre-existing PR prolongation. In these cases, or a patient with the coexisting cardiac morbidities, sodium channel blockers can sometimes cause an increased risk of sudden cardiac death also. At the end, I want to conclude with a concept called a pharmacogenomics. What is pharmacogenomics? It means that we have to focus on the underlying genetic etiology, and then we have to precise our anti-seizure medication choice, because that underlying genetic etiology can sometimes can actually put a dictum on choosing what we have to choose as anti-seizure medication. So there are some genetic variations that can influence the response to these anti-seizure medication treatment through various effector processes. Like we have various HLA polymorphisms, various CYP polymorphisms that actually have an increased risk of idiosyncratic reactions causing a failure of our ASM monotherapy. So here I have just mentioned about the notable variations which can actually change our decision based on the pharmacogenomics. Like variation in CYP2C9, it can actually cause increased neurotoxicity from phenytoin. If a patient has a variation in 2C19, it can cause clobazam concentration can increase and side effect profile can increase. Similarly, 2C19 variations can cause increased side effect profile with phenobarbital. Similarly, variation in sodium channel mutations like SCN1A, that can cause again oxcarbazepine maintenance dose, they can have an increased side effect profile. So finally, I am ending my talk with a few important take-home messages. Failure of the first ASM, failure of the first line anti-seizure medication doesn't corroborate with the drug resistance. We have to re-evaluate our diagnosis, we have to check the compliance of the patient, and we have to classify the seizure, and then we have to think that whether our medication which we are giving is appropriate to the epilepsy type or not. Choose the next anti-seizure medication with a different mechanism of action and a better tolerability profile. Always ensure that whether we have given an adequate dose and adequate duration trial before labeling it as a failure. Rational polytherapy means complementary mechanism of action. We have drugs we have to choose, and when there are failure of two adequate chosen ASM trials we have given and still the failure happens, then drug resistant epilepsy is there, and then we have to refer the case to a tertiary epilepsy care center for further evaluation. And in that case, epilepsy surgery can be considered, or there are some other non-pharmacological interventions also, like neurostimulation or a dietary therapy we can control. The major key is that we have to be individualized in management of the epilepsy. Mechanism based and proactive management is the key rule. Thank you.
I'm sure there will be many questions.
Deepak, thank you very much. I think it was very comprehensive, lucid, and understandable lecture. Thanks a lot. In the combination which you have shown, I did not see levetiracetam and lacosamide. That is the one which we use most commonly.
Yes.
So, any comments?
Like in our center, sir, like we use them. Actually, that I have taken some from meta network analysis. Actually, which their mentioned combinations were there, sir. So they have given actually around some 30 combinations, sir, which are very favorable. And the notable mentions with the good predictions were there, sir. That I have mentioned, sir. So
we have to change our practice.
Yeah, but the cost of lacosamide, 10 tablets is 440 rupees. The cost of carbamazepine, 10 tablets is 44 rupees. So whenever we are giving these medicines, we should look at the patient profile, especially the pharmacoeconomics, because they need to use the drugs for years if required lifelong. So that's important.
Problem why we don't use carbamazepine and lamotrigine, because always we have the worry of the Steven Johnson.
Yes, sir.
Therefore, how should we as a physician,
sir, like
decrease our worry.
Here in our center, sir, we are basically starting the dose with a very low profile, sir. Like we are, like for example, in carbamazepine, we are starting like half tablet, 200 mg, half tablet we'll start, and gradually we'll build up the dose. And similarly in lamotrigine also, 25 mg tablet, we are starting with 1/4 tablet, sir. So 1/4, then half, then full tablet, then we are combining 25 mg increment we are doing every 5 days, sir. And the best thing is that we can go for a HLA-B1502 polymorphism, sir. So in our center we have a allele profile where we check the HLA-B1502, and if the patient is positive, then we have a caution that we cannot start the this thing, sir. So that report comes in within a week. So one way is that we can do a HLA-B1502 polymorphism, and then based upon result we see. Other is you start slow. The rash development period is within 2 weeks to maximum 2 month period, a rash can develop, a generalized rash. So based upon that we can think of stopping the drug, sir. Like, so we have to go slow, and eventually we have to build up the dose, sir.
Yeah. Possibly, how frequently HLAs should we do? For example, focal seizures. We know carbamazepine is good. Should we do the HLA? What should be?
Like the cost, like it's around some 7,000 it costs.
Yeah, so, Praveen. See, working in epilepsy for so many years, no, I always when many people are resistant, levetiracetam is not a very effective drug, but it is the queen of anti-epileptic drugs. Everybody writes levetiracetam, and the response is not great. So when they come to us, we just start carbamazepine in incremental dose and titrate it over 2 weeks. Always take a signature. Don't worry about side effects. As long as we are informing the patient, taking the signature in the OP card itself.
Yeah.
Because it saves the cost for the patient.
Yes.
Still in India, we have Indian guidelines. We should use carbamazepine in adults above 18 years, oxcarbazepine in children for focal epilepsy.
Okay.
For generalized epilepsy, it is sodium valproate in non-childbearing age as well as men. In others, it is levetiracetam.
Yeah, that's
so taking a signature is enough. No need to do HLA. We write HLA-B1205 advised, patient not willing. We also tell the patient it costs you 7,000. Do you want to still? Because even if HLA is negative, you can develop the rash.
Yes.
So some elite people will require, but most of them don't get it done. And the risk of rash is very less, which is around 5%.
Yeah.
So when you are prescribing 100 people.
Yeah. Why one more? Carbamazepine is a wonderful drug for many facial pains, trigeminal neuralgia. That is wonderful. They won't need anything. Therefore, I think so. We do the same and take it. Yeah. Any questions,
Madam?
Yeah.
Is Brevipil more effective than see more prescriptions about Brevipil?
So Brevipil as such, it also acts via SV2A receptors only, with the affinity is more, sir. 50 times it is more, affinity is more in regards to the Levipil per se, sir. But the behavioral disturbances are like almost like a slight minimal to lesser than the Levipil per se, sir. So affinity is more, and side effect profile is also slightly less, sir.
Sir, one thing, if a patient comes with around 2 to 3 episodes of seizures within short duration, 24 hours, not suggestive of any infective pathology on imaging or with regards to history. Now, how do we say that you have given a loading dose in an inpatient setting, and the patient again throws the seizures after 3 to 4 days, and the patient is already on 2 anti-epileptics? Do we tend to continue, or if you want to add a third anti-epileptic, would you withdraw the one which has been given as loading dose, or you give a second loading dose, or how do you go about this loading doses and withdrawal and adding with regards to a patient who's in hospital?
Sir, basically, like first thing is that if the patient is getting the seizure, sir, here comes the option of a combination polytherapy. So like how we are combining the drugs also play a role, sir. Like the combinations which we are giving, as I told, sir, whether they are the rational combinations, because that alone actually helps to cover down the status, like cover down the risk of the seizure per se. So first thing is a rational polytherapy combination which we are giving, sir. Second is, sir, like the seizure which he is getting is consecutively, or like how? Like normal.
First one day, the patient had around 3 to 4 episodes of seizure-free period of around 48 to 72 hours.
Yes, sir.
72 hours, the patient again gets a similar seizure. Semiology is similar to the first episodes. Now, you give the second loading, and and wait, or do you tend to taper after the second loading is not working?
We'll give the second loading, sir.
Second loading. Okay.
We'll give the second loading because in that time the patient is seizing actively. So we'll give the second loading. We'll build up. We'll hit hard first, sir. So we have to hit hard first. Then we have to ensure the optimum control. And then when the patient is controlled, then we'll think of taking out the drug, sir. So initial point is you have to hit hard with the combination, with good combination, so that you achieve optimum seizure freedom. And then in the follow-up, we have to take it out, sir. How we down titrating of the old one or building up of the new one. But first thing is you have to hit hard with the loading and combination therapies.
Okay, and one more thing with regards, already one audience had asked, is it only trying to tell that we are more familiar with the newer drugs, that majority of the neurophysicians or physicians are trying to switch over to brevaracetam rather than levetiracetam, or does it really have some great advantage? That does does brevaracetam have some very great or superior advantage with regards to when compared with levetiracetam?
Yeah. No, I'll tell you, carbamazepine is the best drug till now, working with refractory epilepsy patients.
Okay.
Physicians are scared to start carbamazepine because of the risk of rash. But the problem with carbamazepine is any drug takes 5 half-lives to work. If you give brevaracetam, it works in 2 minutes. So in the ER, it is easy, it builds up. So your seizures are suppressed. Levetiracetam takes 20 minutes. Phenytoin takes 1 hour. So during that time, the seizures will continue, especially it may go into status. So in ER, you can give levetiracetam. But what we do is later, if it is clear-cut focal seizures, you can overlap with carbamazepine and then slowly take off levetiracetam. Otherwise, the patient will come back with significant behavioral issues, which may not be evident in the hospital. Okay, so any drug takes 5 half-lives. So the moment you give carbamazepine, the best effect, there is auto-induction also. The levels will come down after a week. So the best effect of carbamazepine is 2 weeks. So till then we just counsel the patient that you have to be patient. If you get seizures in between, use clobazam. You can give clobazam 10 mg once or twice and gradually down titrate later if the patient is seizure free for at least 3 or 6 months and continue one drug.
Okay. Thank you. Thank you.
Any role of high-fat diet causing ketosis? Ketogenic diet.
Ketogenic diet is one of these things, sir. Like we have Atkins diet, modified Atkins diet. Yes, sir. So, yes, sir. So basically in the myoclonic epilepsy spectra, sir, we have seen the good benefit with these kind of diets, sir. Where we'll decrease the carbs and increase the protein and fat proportion, sir.
One question, madam, regarding pharmacoeconomics, you're just mentioning, suppose if the patient is not economically, it doesn't cater to the high test, can we just start a carbamazepine or carbamazepine, and if he's not responding, maybe we can add to lacosamide or anything. Second thing is, I just wanted to share my experience regarding this, whatever Steven Johnson. Don't think just you should not wait till skin rash appears. Recently I had an experience, and madam also was helping me in this case. Patient after starting lamotrigine, when she got married, she wanted to switch over from sodium valproate to lamotrigine, and that lady started complaining of abdominal pain. Almost for 2 to 3 weeks, she was having abdominal pain. Initially, we were thinking that not me, but our gastroenterologist was thinking just it is a somatization, and it was ignored. And on one single day, she developed Steven Johnson, landed up in emergency. So it need not be just skin rash to start with. So any mucosal involvement also can be a part of Steven Johnson. So just make a note of it. Just don't wait till skin rash appears if any patient either to lamotrigine or some other anti-epileptic drug is being used.
Duration, sir, for a single unprovoked seizure, sir, there is no need to give a treatment per se. for a single unprovoked event, sir. Otherwise, for 2 or more events, we give for, like, if a notable epilepsy we are making, sir, and then in the children we are taking a cutoff of around 2 years. At least 2 years a seizure-free period should be there. If in that a failure occurs, then we have to wait for 4 years. In the adult spectra, 3 years is the minimum period of seizure freedom patient should have for a cut down of the medication. And if in that the failure happen, then 5 years we have to wait, sir.
Okay.
For cutting down.
Thank you. We can have a discussion later. Now, seizures. That means many patients, it can be a status epilepticus. The next topic is on status epilepticus. As I talk, time is brain in stroke, time is brain even in status epilepticus. Now we'll listen Sita madam talking about status epilepticus.
Yeah. Good morning. Yeah, thank you, Praveen, for this opportunity. So we'll be discussing about the approach to status epilepticus in the first 24 hours. So all of us know that seizures in the emergency, in the ER is a medical emergency, and outcome is largely dependent on the etiology. Early therapy is critical to reduce the morbidity, prevent permanent neurological damage. So the incidence is very high nowadays, especially with infections around, and it accounts for nearly 20% of the ICU admissions. And then the problem is when the patient comes with one seizure, you don't know whether it will evolve into status epilepticus, whether it will evolve into later refractory status epilepticus. So can we identify that in the ER so that we are more aggressive in the management? Why this is important? So we have stages of status epilepticus. The early phase is 5 to 10 minutes. That time the patient will be either at home or somewhere and they don't reach the ER. Stage 2 is established status epilepticus. That is by 30 minutes. And stage 3 is 30 to 60 minutes and stage 4 is more than 24 hours of continuous seizures or frequent seizures without regaining sensorium. So why this is important? The mortality is dependent on the stage of status when they come to you. Most of the time in our tertiary care, they come to us after 24 hours, where the mortality is more than 60%. So if the status epilepticus is more than 2 hours, the mortality is nearly 40%. More than 48 hours, it is 60%. So with this, what are the definitions of status epilepticus, why they are given? Status epilepticus is two or more than 2 seizures without regaining sensorium in between, or a single seizure lasting for more than 5 minutes is status epilepticus. What is refractory status epilepticus? If the status epilepticus is lasting more than 2 hours and not responding to first and second line anti-seizure medications. That is, you have given midazolam and you have given a loading dose of, most of the times it's levetiracetam in the emergency. What is super refractory status epilepticus? That's what we manage in our most of the tertiary care. Right now we have a patient who is having status for more than 183 days. And this is where in spite of IV anesthetic drugs given for more than 24 hours, somebody continues to have seizures. So how do you manage this? The most important is termination of the seizure, nothing else, when the patient comes to the ER. After that, you establish what is the etiology, and the aim is to prevent another seizure after the first seizure, and then prevent the complications of management, which determines the outcome also. So within first 0 to 5 minutes in the emergency, it is ABC. I will not go into the details, which all of us do regularly. But most important is secure the airway, keep the patient to one side, don't keep supine, make sure that oxygen is given, get IV access, draw one sample, later you can decide what you are doing, but immediately do a random blood sugar. Sodium is very important and all the electrolytes as shown. And in addition, briefly ask whether he has epilepsy in the past, because if somebody has epilepsy, you give levetiracetam, they immediately respond. Anybody who is coming for the first time, new onset seizures, evolving continuously, very difficult to control the epilepsy. And consider videoing it, because most of the time, non-epileptic seizures can occur. So you can ask some nurse to do the video, and meanwhile you manage the patient. And confirm that it is status epilepticus, and most importantly, rule out non-epileptic attacks. In our ER now, nearly 25% of the patients are non-epileptic attacks, where they are intubated, brought onto the ICU with ventilator, and only after connecting them for the EEG. So it's very important we try to differentiate. So, for example, we see this patient who is in the ER. So we know that he is intubated, he is jerking the right side, and even the left is jerking, but right is vigorously jerking. and you see the legs which are not jerking. So he was a medical student who was intubated for a possible status and referred to our center because he is not responding. So that was a difficult case. But this is a very clear case. You see this guy who is continuously seizing with arching of the back, jerking of the limbs. So these are non-epileptic attacks. Then once you confirm that it is a true status epilepticus, check if any treatment received outside. Most of the time they come with half loading, 1 gram of levetiracetam given. That's not correct. Always that will come to the management. And if he takes alcohol regularly, which can cause seizures, replace the glucose if there is hypoglycemia or hyperglycemia, correct it, and meanwhile prepare the benzodiazepines. But most importantly, in the ER, check the sugar. This is one of the patients who continuously having a focal epilepsy partialis continuous because of hyperglycemia with a sugar of around 600. So in this, there is no need to be very aggressive. You just control the hyperglycemia, the seizures will get controlled. Even if you are given a loading dose of levetiracetam, there is no need to maintain in these cases. So does speed really matter in the ER? Yes. If the seizures are controlled within the first 2 hours of onset, it is a major determinant of favorable outcome for cessation of the seizures. And we are treating, you should treat early. That is the moment the patient comes, anti-seizure medication should be given within 5 to 10 minutes to prevent status epilepticus. So which anti-epileptic drug will you choose? How you manage? So always hit hard and hit very early. So how do you do that? So first you should give a first line drug because by the time you prepare the second line drug, it takes time. Nowadays you get ready to use levetiracetam. But first you give, most of the time we use midazolam in the ER. The dose for a 50 kg individual should be at least 5 milligrams. Don't give minuscule doses of 1 milligram, 2 milligram, which will not abort the seizure. Don't worry about, because he is in the ER, if required, intubation can be done early. And in the hospital setting, there is no role for intranasal midazolam. Then intubate the patient if required, but never intubate during a seizure. And if the patient has chronic alcoholism, give thiamine 200 milligrams followed by maintenance. So in the early status, you can give one loading, first benzodiazepine 5 milligrams you have given, but patient is seizing, you can give another 5 milligrams very easily. Meanwhile, prepare and give your the second line drugs. That is called established status epilepticus, in which you consider intubation, give second line anti-seizure medications. So whenever you give an anti-seizure medication, it takes minimum 20 to 30 minutes before it starts working. So don't be in a hurry again to pump another dose of valparin, another dose of breviracetam or lacosamide. So most of the times, phenytoin is also equally good drug, especially in young people. Better to avoid only in elderly because we are worried about the cardiac arrhythmias or sudden cardiac arrest if you give very fast. Phenytoin is still good a choice, but most of the time levetiracetam, that is what goes in the ER. So what is the efficacy? Does choosing the drug change any practice? Levetiracetam is effective in 70%. Actually valproate is more effective than levetiracetam. Phenobarbital is also equally effective, but nowadays IV is not available, and phenytoin in 50%. So again, we should use levetiracetam in most of the cases because it's effective in 70% of the cases to abort the seizures in the ER. So whenever we are using these drugs, we should know that phenytoin, fosphenytoin, both are equally effective. Prolonged anti-seizure efficacy is present, and always be careful with phenytoin for any cardiac issues. Hypotension is one of the another side effects of phenytoin. And then infusion related side effects like phlebitis and soft tissue damage are common. Valproate is an excellent drug. I use mostly in people who have comorbidities, which is as good as levetiracetam. And we use levetiracetam because of ease of use, reaching the therapeutic levels faster than phenytoin, and it can be infused rapidly. There is no need to give slow infusion. And nowadays we have other drugs like lacosamide and breviracetam. So breviracetam acts through SV2 receptors, whereas lacosamide is a slow sodium channel blocker. And the advantage of breviracetam is it is the fastest IV drug which is available as on today because it works in 2 minutes and it is lipophilic and crosses the blood-brain barrier. So which drug do we use? So all the drugs are equally effective. You should know how to use and what are the side effects. And then how many anti-seizure medications one can give. Because in the ER you have given levetiracetam. When you are giving, you should give the full loading dose, 40 milligrams per kg. Means for a 50 kg percent, give 2 grams. Most of the time we get people around 80 or 100 kgs. Then you give double the dose, 3 grams or 4 grams. So that is, you should not give underdosing so that seizures should be well controlled. And it is shown that in the Western literature, they suggest only one anti-seizure medication to be tried after the first line drug as a second line drug. But if it doesn't work, directly go for IV anesthetic drugs. But in our setting, because of intubation, all that costs in the ICU, we go for second and third drugs also. That is, once you have given levetiracetam, if there is no response, you go for either valparin or different mechanism of drugs like lacosamide, which can be given. So once you have given this, stage 2 is over. So after stage 2, you are waiting for another 30 minutes, during which time 30 to 1 hour before you start IV anesthetic drugs. Identify the etiology and manage. It can be a stroke. When you examine, you will identify. It can be any infection, so see for meningeal signs. Any history of trauma is there, any anoxic brain injury, especially if you get a call from cardiac ICUs, any SOLs or metabolic. It is one of the common causes in the elderly where you can have a hyponatremia, hypoglycemia, hyperglycemia. So look for this and start collecting them immediately. And then if you look at the etiology across various continents, in India still infections is one of the major cause for status epilepticus, whereas in other countries it's vascular, metabolic and anoxic. So, but most important is new onset refractory status epilepticus. So what is this? Nowadays we call it as NOS, which is one of the most difficult condition, which is seen in nearly 30% of the status epilepticus. It is the presentation where the patient doesn't have any past history of epilepsy, suddenly comes to the ER with cluster of seizures, either preceded by fever, but when you examine there is no meningeal signs or anything, and the cause cannot be identified in 72 hours. And most commonly the cause for new onset refractory status epilepticus is autoimmune encephalitis, with or without associated with any malignancy, paraneoplastic autoimmune encephalitis, infections especially HSV encephalitis, genetic conditions like mitochondrial cytopathies. So why status epilepticus becomes refractory over the time, when in spite of being treatment? So once status sets in, we know that it is imbalance between the NMDA and the GABA, which are excitatory and inhibitory neurotransmitters. So normally the GABA will increase to control the excitatory neurotransmitter. But over the time the GABA also becomes excitatory, and this leads to increase in the glutamatergic and GABA acting as even excitotoxic, causing mitochondrial failure with opening of the blood-brain barrier, and the cycle continues. In addition, there is receptor trafficking which intensifies during the status epilepticus with increase in the NMDA receptor density, increase in the intracellular calcium, thus causing neuronal damage. So status epilepticus will cause significant cognitive impairment in people who survive, either because of continuous seizures and also because of underlying etiology. So what do you then? You try to do an imaging once you have intubated the patient. Imaging may show bilateral hippocampal hyperintensities or peri-insular hyperintensities, or in the initial phases the MRI can be normal. Then the seizures are continuing. So we are within first 24 hours, but 5 hours are over, patient continues to have seizures. That is called stage 3 refractory status epilepticus, that you have given your midazolam as well as anti-seizure medications. Now it is time to intubate the patient, shift to the ICU, and then give intravenous anesthetic drugs. The commonest intravenous anesthetic drug used is midazolam, and the other drugs which can be used are propofol, thiopental, ketamine. So nowadays what is the practice? So you start midazolam, initially give a loading dose of 2 milligrams per kg, followed by you maintain a midazolam infusion which can be from 0.2 milligrams per kg to 2 milligrams per kg per hour. That means we use midazolam starting with 5 ml per hour, and we gradually increase to 25 and sometimes even up to 40 milligrams per hour. And most of the time this helps because the patient, most of them are intubated, so we are not worried about respiratory depression. Sometimes in convulsive status epilepticus, midazolam will not stop the seizures. So thiopental is a better option in convulsive status epilepticus, especially which occurs secondary to HSV encephalitis. Then in spite of midazolam, the patient continues to have seizures. What we do is, most of the time we combine midazolam with ketamine. Why? Because midazolam will cause significant hypotension, whereas ketamine will cause hypertension. Combining both will cause maintenance of the hemodynamics properly. In addition, midazolam is GABA inhibitory, whereas ketamine is inhibitory of NMDA. So you are combining drugs with two different mechanisms of action so that your control of the seizures can be achieved well. So what are the recommendations for using these? So all over the world, the recommended drug first is still midazolam, which should be given in an adequate dose, and if it is convulsive, thiopental can be used. And when you use midazolam for a longer period, that is for weeks and months, still the mortality is less when compared to people use thiopental. The risk of arrhythmias, the risk of paralytic ileus are high, which can lead to increase the risk of mortality. And then what is the role of EEG when you are doing the managing these patients? EEG plays an essential role from stage 3 onwards. It is important to distinguish the seizures from non-epileptic events, identify the non-convulsive status, because after the seizures are controlled, patient is not waking up. That is because there are subclinical seizures or so-called non-convulsive seizures which are continuing. And also we have to monitor how much drug midazolam to be given. So that can be done only with titrating the EEG. For example, if you see here, the red color is right and blue is left. So there are seizures coming from the right side, which evolves into a seizure. The patient is totally no seizures outside. But if you see here, there is continuous seizure activity which is going on. So this is the reason why he is not waking up. So you need to control that also by titrating your IV anesthetic drug. Immediately after the next minutes, he develops left-sided seizures. So this suggests that you have controlled the seizures by IV anesthetic drugs. Still the seizures are continuing. That is stage 4 of status epilepticus, which is known as super-refractory status epilepticus. So how do you manage this? You continue midazolam and possibly you add ketamine, and then you identify whether it is a new onset refractory status. If it is new onset refractory status epilepticus, if it is HSV, give acyclovir along with steroids. Otherwise, you have to think for immunotherapy in new onset status epilepticus. I will come to that in the next slide. Then you identified the cause, so you treat it. Usually hyponatremia, correct it. Hyponatremia usually does not go to stage 4 in most of the cases. If there is a clear-cut lesion, sometimes we get focal cortical dysplasias, even hippocampal sclerosis. Then there are cases where they were operated during the status epilepticus for the control. In addition to this management, there are outside the guidelines, there are novel therapies. So nowadays, lot of perampanel is available, which is a very good drug for control of the seizures. In adults, we give a loading dose of almost nearly 20 milligrams stat orally through the rice tube. After that, we maintain a dose of around 10 milligrams every day. Similarly, ketogenic diet is used in children, especially to control the status epilepticus. Nowadays, we get formulas of ketogenic diet, and then very rarely, meanwhile you do the workup for autoimmune status epilepticus. But still, even if autoimmune panel takes 48 hours to come, so even if it is negative, first always we start methylprednisolone. For a person who is new onset status, day 2 we start methylprednisolone, which is continued for 5 days. Meanwhile, we are evaluating for the underlying etiology by doing the autoimmune panel, FDG PET, and identifying any underlying malignancy. Steroids should be given within 72 hours of admission, or you can give IVIG if the patient is any contraindication for steroids. We know that steroids are much cheaper and IVIG is quite expensive. And after this, if the seizures are continuing, by 7 days we give second line immunotherapy. If there is antibody positive, we go for rituximab. If you don't identify anything, most of the times after steroids we go for tocilizumab. Then what are the complications during the management of status epilepticus? Status epilepticus related complications are hypo or hyperthermia, hypotension, hypoglycemia, metabolic acidosis. Most important is rhabdomyolysis. If the patient is continuously convulsing, most of the time you paralyze them if they are not responding to thiopental. And pulmonary edema, which is central in origin, raised ICT causing cerebral edema. And IV anesthetics are very, means they can cause complications if they are not managed properly. So because the IV anesthetics can cause cardiac arrhythmias, so you have to monitor very carefully with continuous monitoring. Severe ileus due to paralytic ileus, they can cause renal failure, and especially if you are using propofol, it can cause life-threatening propofol infusion syndrome. So what is the mortality and morbidity of status epilepticus? As I already said, the overall mortality of status epilepticus is 20%. If it becomes super-refractory, it's around 40% to 60%, and 35% of the survivors return to baseline. So after discharge, what happens to these people with status epilepticus? Only 30 to 40% return to baseline. That is, they go back to work, they go back to their jobs. And most of the people will have severe disability. So that's why it's our responsibility to manage status epilepticus aggressively to prevent the long-term, not only to decrease the mortality, but also to reduce the long-term morbidity. So this is the algorithm for the management of status epilepticus. So the stage 1 is manage ABC and give either lorazepam or midazolam in the ER. Stage 2, you give IV anti-seizure medications. Stage 3, you give IV anesthetic drugs. And then stage 4, you consider immunotherapy along with the management of the underlying etiology. So to conclude, the video of the seizures in the emergency department is vital so that you don't miss out non-epileptic status epilepticus. And seizure control within 1 to 2 hours improves the outcome in convulsive status epilepticus. After one first line and one second line anti-seizure medication fails, if the seizures continue, always intubate, start IV anesthetic drugs so that you aim to control the seizures early. And etiology is the one which determines the outcome rather than how long the seizures is continuing. So we have patients who had status in the hospital for 6 months and still got discharged with normal cognitive outcome because of the underlying etiologies. So it's important to identify the etiology and address the etiology at the earliest. Thank you.
Any questions?
There is no role of hypertonic saline in status epilepticus. If you can see, status epilepticus is inflammation. So it is not, inflammation may lead to cerebral edema, but it is not primarily cerebral edema. So you need anti-inflammation. So that is immunotherapy with either steroids, even rituximab is anti-inflammatory, though you are doing immunomodulation.
But few centers are using hypertonic saline.
Yeah, it's not evidence-based.
Okay. And the role of one thing about tocilizumab, and should we stick with only one dose of tocilizumab or can it be repeated? And some centers are using anakinra.
Agreed. So, yeah, I didn't go into much of the details of NORS because NORS, if it is occurring for the first time following fever in children, it's called FIRES, febrile infection related status epilepticus. So in FIRES, anakinra is used. Whereas in NORS, in adults, if there is an antibody identified that is autoimmune, you use rituximab. If it is not identified, we call it as cryptogenic NORS, where the tocilizumab is the drug of choice. So all these drugs are given for maintenance immunotherapy. If you are giving rituximab, you give it within 7 days and repeat it after 2 weeks, and then you repeat it after 6 months for a period of possibly 1 or 2 years as per the recovery of the patient. If you are giving tocilizumab, you have to give 2 doses at intervals of 1 week, followed by maintenance of once in a month for 6 months. So all the autoimmune diseases need a long-term maintenance management, in addition to along with the anti-seizure medications.
Thank you.
If there is no response to loading dose of IV levetiracetam, is there any role for phenytoin loading before going to IV anesthetic drugs?
Yeah, that's what the AIMS study has identified, that giving 3 anti-seizure medications after the first line drug. So these are given as second line drugs. They could prevent 30% of the patients going into the ventilators. So with a low socioeconomic group management, definitely we also try to do that. We give levetiracetam, no response. We use lacosamide rather than phenytoin. But phenytoin is also an excellent drug. So the usage has come down markedly, but still you can give. And if there is no response, go for valproate. All are 3 different mechanisms. And then you are not able to manage, then you intubate and give elective intubation and IV anesthetic drugs.
In your experience of so many years, how many percentage of patients received rituximab?
Yeah. Recently we just published our data on new onset refractory status epilepticus. Out of 72 patients, we gave rituximab to 25 patients. Because these are all the patients who presented with, they will have, the history is very dangerous. If somebody comes with fever, one seizure, and after 3-4 days they start developing status. So we have to tell everybody who comes with a fever related seizure, they need to be monitored. So most of the time we write admission also, because you don't know who will evolve like what. So these are the cases who need immunotherapy.
Do you ask them to have this frisium, that is the young children in the fever when they are getting seizures? Do you prescribe, ask them with because pediatricians they write?
That is febrile seizures.
Yeah, febrile.
Yeah. In that we give clobazam prophylaxis.
Yeah.
So, but in adults, because we deal most of the time with above age of 12 years.
And role of intranasal is, should we encourage that at household level? Patient
Because somebody has a history of epilepsy, everybody should keep intranasal midazolam at home. That's what we advise the patients. Because the idea is, the moment the seizure comes, you can give 2 puffs in each nostril, total 4 puffs at a time, which can be repeated as per the need, so that you try to abort the seizure by the time you are taking the patient to the hospital. That too, take to the hospital if the seizure is more than 5 minutes. But give intranasal midazolam the moment seizure starts. When the seizure starts, nobody knows whether it will be 15 minutes, 30 seconds, 1 minute. So don't wait for it to get prolonged, abort it immediately.
Thank you, madam.
Have you seen any first time seizures in sleep?
Yes.
Well, I had seen 2 cases, both expired, young children, about 20 years and 16 years boy, who had a seizures continuously in the sleep. His grandfather was sleeping next to him. He came to know after half an hour, 1 hour. By the time I could reach and make him go to the hospital, reaching the hospital, he was dead.
Yeah, that's very important, sir. What you said, nocturnal seizures are it's a separate entity also, common with frontal lobe seizures. But when it is happening for the first time, it's difficult because most times they go unnoticed till they get a major seizure. And that's why anybody who has seizures, they should be asked to sleep side. Nobody should be supine if they have epilepsy. We give all these instructions in the OPD. In supine posture, when you get a seizure, there is a risk of aspiration and sudden death. We call it as SUDEP. SUDEP has been reported in patients with nocturnal seizures. It occurs in 4% of the people with epilepsy, which is a high percentage. We need to talk to the people in the OPD if they are not compliant with the drugs. I tell them there is a risk you will die. Then only they will take the medication. Otherwise they are not scared about anything.
Now I request Varalakshmi madam to talk about the next important topic about pregnancy and seizures. We all have confusion, what to start, when to start, what not to do.
Good morning, everyone. I thank Dr. Praveen for giving me this opportunity. And I also feel proud to be associated with one of the best epilepsy unit in the country, I should say. The topic given to me is epilepsy in pregnancy. What are the things to What are the things to do and what are the things not to do in epilepsy in pregnancy? Actually, my previous speakers have already spoken certain things about this topic. Stuck. So, the objectives of my talk will be identifying the evidence-based do's and don'ts in the antepartum, partum, and postpartum phases of pregnancy. This is to exactly choose the anti-seizure medications which will affect the pregnancy outcome, and also the doses. This is basically to prevent maternal and fetal complications like neural tube defects, major congenital malformations, and the SUDEP. Just now, Madam was talking about the sudden unexpected death in epilepsy patients, and also the fetal hemorrhages. And this is exactly to plan the intrapartum and postpartum outcomes. So going on to the main topic, I would just like to enumerate the certain cases, the scenario of these cases, which will give us some insight into the present topic. This is a 24-year-old lady who was on oxcarbazepine for 7 years for temporal lobe epilepsy, was shifted to lamotrigine just 45 days before the marriage. She got engaged and the parents came to me for outcome once she's pregnant, what will happen to the child. So I have shifted her onto the lamotrigine, but she developed rash within 2 weeks. So I had to stop lamotrigine, and lacosamide was started. And after the marriage, she conceived, and nicely, she is now 5 months pregnant. This is another lady who is 35-year-old. She had past history of autoimmune encephalitis and being on long-term anti-epileptics, and got married. She was unable to produce ovum, and she was planned for donor ovum versus adoption. Suddenly, to pleasant surprise of everyone, she conceived, and now she's 6 weeks pregnant with a viable fetus. This is another lady who is 27-year-old, a history of catamenial seizures on oxcarbazepine, conceived twice, had delivery with healthy babies, and still continuing with oxcarbazepine. And this lady is 22 years old, and she's on Levipil for, the seizures were not categorized. She developed uncontrolled seizures in the 3rd trimester. Initially, there was a confusion of breakthrough seizures versus preeclamptic toxemia. So she underwent LSCS with a Maxelf treatment, Maxelf medication before. And this is a 32-year-old lady, again, who has been on sodium valproate. She conceived after marriage. She got aborted because of the blighted ovum. So she had to be shifted on levetiracetam and lacosamide, which is a nice combination about which till now all of the speakers have talked. So with this case scenario, I would move on to the present topic. The background is epilepsy. All of you know it affects 0.3 to 0.7%. Most of the outcome is good. And risks arising out of the seizures do not cause as such any problem, but the trauma, hypoxemia, and sudden death secondary to the seizures is the main risk, and also the teratogenicity arising from the anti-seizure medication. So our goal should be the patient should be seizure-free with the monotherapy and with the lowest effective dose. So what is the preconception? What are the things to do? So early counseling of the patient by a neurologist and as well as the obstetrician. Pre-pregnancy is very ideal. So what is the thing that we do? Review of the seizure type. So we have to choose a proper drug, as far as possible monotherapy, and should be stable within 6 to 12 months before the conception. So prefer, till now the two speakers have spoken, Sita Madam and our Deepak, about the lamotrigine and levetiracetam combination as appropriate. As far as possible, let the patient be on lamotrigine and levetiracetam and avoid valproate if alternate exists. So begin folic acid with a dose of 1 to 5 milligrams at the highest dose, and we have to discuss that the patient should be in the registry, and patient should be discussed with the teratogenetic counseling. So what are the first trimester priorities? As this is the first thing, prerequisite is confirm the pregnancy. And the baseline anti-seizure medications at the trough level, if monitored before the pre-pregnancy itself. So about the high-resolution ultrasound, as per the protocol, we should go on to monitoring the fetus as far as possible. And about the mother, please reinforce about the adherence to the seizure medication. As Sita Madam told, this is one of the important factors that will keep the pregnancy go on with a good outcome. The second one is sleep hygiene. Again, pregnancy itself will cause some amount of sleep irregularities. So try to counsel the patient by hook or crook. Patient should have a proper sleep, which gives a good outcome. Then try to avoid all the triggering factors. Avoid hypoglycemia because they'll be having some food taboos, but that should be overcome, and the patient should be counseled about this. Alcohol, some of the people may have consumed alcohol, that should be avoided. So coming to the pharmacokinetics about the lamotrigine and levetiracetam, the clearance rises substantially during pregnancy. So we have to increase the lamotrigine and levetiracetam pre-pregnancy level and reassess the dose every 4 to 6 weeks and reduce in the postpartum level as it comes to the baseline after the postpartum period. So about the medication choices, the practical rules, do's. Use monotherapy as much as possible at its lowest dose, and prefer lamotrigine and levetiracetam for most of the focal and generalized seizures. If carbamazepine is required, try to maintain it at the lowest dose possible. So give the detailed anomaly scan, consider the fetal echo, if at all, if any problems arise. Regarding don'ts, avoid polytherapy whenever possible. See, if you cannot go with a single therapy, use the proper combination as described by Dr. Deepak. So avoid valproate basically to avoid major congenital malformations and neural developmental defects. Avoid topiramate because it may cause oral clefts and other defects. Regarding the folic acid and vitamins that to be given during the pregnancy, the first one we should remember for do's is start folic acid in the preconception phase itself. If the patient is planning for pregnancy or as soon as the lady gets married and not worried about anything else, then itself it is better to start folic acid, the dosage which is already discussed, and ensure neonatal vitamin K 1 milligram, especially if the maternal enzyme-inducing anti-seizure medications are being used, that is phenytoin, phenobarbital, and other drugs. But neutral drugs, if they are being used, there's no need for giving this vitamin K. But coming to don'ts, do not routinely use maternal oral K, because oral vitamin K, because this is being practiced in some of the centers, because there is no sufficient evidence for this particular practice. Do not delay anti-seizure medications if the folate is not available, but both can be given together also. Coming to the antenatal care, what are the do's that should be practiced is continue anti-seizure medications if possible in split doses, because this will keep the therapeutic levels in a plain level. Again, monthly reviews, that is periodic reviews, that should be practiced. And safety counseling, that is bathing supervision, avoid heights, and driving, and even sleeping lonely also is not very good. As Madam described, SUDEP is one of the problem when sleeping alone. Coming to the don'ts, don't aim for a therapeutic ranges without individual baseline. This is very, very important to treat a patient at the target level. Don't ignore worsening auras. Suppose if the patient feels or complains of auras and clusters, start escalating or start newer antiepileptics as early as possible. Coming to the intrapartum, the dose that we should remember is, as far as possible, vaginal delivery should be encouraged. There's no need for cesarean section because epilepsy is there for that mother. Continue anti-seizure medications even during the labor. If seizures occurs, terminate promptly, that is with IV benzodiazepine as per the protocol, and continue fetal monitoring afterwards. Don't withhold benzodiazepines for the fear of fetal depression, because saving the mother is much important than the fetus. I'm not against saving the fetus here, but here the saving mother is prior to anything. And don't schedule early delivery just because seizures are there. Only exceptions are if the seizures are refractory or there is a prolonged seizure. And in the postpartum and breastfeeding phase, the reduced doses toward pre-pregnancy, what we have done, lamotrigine and levetiracetam, but again, as clearance normalizes, this should be brought to the baseline level. And breastfeeding is encouraged, and monitoring the infant, sedation or feeding where it is relevant. Support the sleep. Again here, because of the child needs continuous breastfeeding, there will be definitely sleep disturbances. So to minimize this, we have to plan accordingly. Don't abruptly keep pregnancy level high doses of postpartum risk toxicity. Don't discourage breastfeeding solely due to ASM exposure, because here the drugs are already chosen according to the needs, and already the dosage is also monitored. So these are the next special scenario: acute seizure, epilepsy versus eclampsia. Here everyone should know what is epilepsy and what is preeclamptic toxemia, because both the treatments differ and the outcome also is different. Here the differentiate eclampsia, which presents with hypertension, proteinuria, headache, and visual obscuration, and this should be separately diagnosed and dealt versus epilepsy. So we treat epileptic seizures with benzodiazepines as per the algorithm, and levetiracetam, etc. The eclampsia, it will respond to MAC-self only, because that is the treatment of choice, not for epileptic patients. Safety and SUDEP counseling. Emphasize adherence to the sleep and stress management, because we say in Telugu, matrutvamu rendo janma antaru. That means it's another life to the mother. So here we should counsel the patient as much as possible, because she's going through so much of, though we don't call it as pathology, but she's going through so much of stress. And next thing that we should see is bathroom safety, because again, if she falls down with a seizure, she may get affected with head trauma, etc. So avoid swimming. Again, I'm repeating it with caution. Co-sleeping if nocturnal seizures occur. And SUDEP should be told to the patient. And also, if the patient is very sensitive, the seizure control and supervision should be explained. Like special situations like status epilepticus in pregnancy, madam has already dealt, but follow standard protocols, protect the airway and early obstetric involvement. Because here again, the maternal safety is much more important than the fetus. Then regarding the enzyme-inducing ASMs, anticipate the interactions like with steroids, vitamin K metabolism. So the comorbidities like diabetes, hypertension, thyroid diseases should be dealt separately. Psychiatric health requirement, integrated care. Then this is one social issue that I am discussing. India and LMICs, that is the lower income countries, low middle income countries. So align with the national regulations like valproate usage and consent for women of childbearing potentials, use government supplied folate. This is for everyone that I'm talking. Neonatal vitamin K at birth. Enroll in national pregnancy registries whenever it is available. So coming to the end, key do's that we have to do: plan pregnancy, use safer anti-epileptic drugs, as far as possible stick to monotherapy, and start folate in the preconception area as early as possible. If at all patient is using lamotrigine, levetiracetam, level should be adjusted accordingly. And breastfeeding can be given. Give neonatal vitamin K. Treat intrapartum seizures as quickly as possible with benzodiazepine without any hesitance. Then allow vaginal delivery as far as possible. Sorry. The key don'ts: don't stop anti-epileptics abruptly. Don't newly add valproate or topiramate if it can be avoided. Don't neglect postpartum dose recommendations of lamotrigine and levetiracetam. Don't withhold benzodiazepines in acute seizures. So summarizing, pre-pregnancy levels, consult neurology and obstetrician combination, switch over to lamotrigine and levetiracetam if possible, and stabilize 6 to 12 months about the seizures before itself. Antenatal monthly review, then levetiracetam lamotrigine combination works early, and anomaly scans should be looked into as early as possible. Reinforce adherence to the drug and sleep hygiene should be made clear. Intrapartum, continue the anti-seizure medications, benzodiazepines, if at all, if should be used. And continuous CTG, that is cardiotocogram for the fetus, should be continued. Postpartum, downregulate levetiracetam and lamotrigine combination to the baseline level. Encourage breastfeeding and neonatal vitamin K. In fact, now I'll just go back to the case scenario that I have discussed. See, one patient I've started an oxcarbazepine. I had no choice because the lady came with conception, and I continued with it, a good outcome. But valproate, it is not, I think madam can throw some more light. It's definitely, as far as possible, we try to avoid valproate, and most of the times has discussed a lot of fetal malformations, and sometimes delivery, conception itself may be difficult. So try to avoid valproate. And levetiracetam lamotrigine combinations, both the drugs are useful. And with lamotrigine, what we should be seriously look into it is Steven Johnson, or at least drug rash. Actually, a small joke about that lady who developed lamotrigine, drug rash with lamotrigine. Actually, after starting lamotrigine in the premarital, some photo shoot is there. So there was this thing that they were getting a photo shoot under the sea with a lot of some application to the body. So initial, we thought whether that application over the body, whatever lotions they have applied, whether that was causing the rash. But after 3-4 days after removing that lotion also, rash was continuing, so that's why I had to stop the drug. And next thing is, if the patient is stabilized on one particular drug other than valproate and topiramate, better to continue the drug and see for the outcome. And this is the case note why I have discussed before the talk. So thank you. And our main interest in talking this, discussing this chapter is, discussing this topic is to have proper maternal safety during prepartum, partum and postpartum, and if possible, better fetal outcome. So maternal safety and fetal outcome are the main interest in this talk. Thank you, everyone.
Any questions? Yeah.
Testing of anti-epileptic drug levels, I think it's available for the older drugs, but not for the newer drugs. But is it we do it or not only in pregnant patients, but in any other patients?
Yeah, you are right. This is overall I have talked, not the Indian scenario. Madam, madam, levetiracetam. Not available. Not available.
I'm already someone like who is pregnant already. They come after 6 to 8 weeks. The patient, the lady is already on oxcarbazepine or valproate. What do you do? So continue this. Will you continue or do you have to asymptomatic, like there are no recurrence of seizures?
Recently, again, that scenario has come to me. One girl who was not able to conceive for 3 years. She came with a pleasant surprise again. 6 weeks of pregnancy. She's on oxcarbazepine. So, and one more thing is she got exposed to CT also for some health problem. Her periods were irregular, so she never anticipated that she has conceived. So I took the obstetrician opinion. What they have advised is to continue the pregnancy for 5 months. With the TFAR scan, if there are malformations, they said they can terminate it. That is the practice now. About valproate, I have no idea.
No, normally, normal women, 2% will have malformations. If you are using anti-seizure medications, the risk is 4%. So in practice, you say the risk is double. But 96% of the people still have normal pregnancies, because I working in a refractory care. I have patients who are on 3-4 anti-seizure medications conceiving and then coming to us, and we maintain the data, and it's even literature wise they have enough data. So if valproate is part of polytherapy, your risk is very high. If valproate as a single drug, more than 600 milligrams, your risk is high. We have enough patients who are on very low dose valproate with lamotrigine because they have refractory generalized epilepsies. So we give them 200-300 milligrams of valproate with lamotrigine. Then coming to the safety of the drugs. In practice, when you are giving levetiracetam, patient will have severe behavioral issues. So you change it to lamotrigine. Patient comes back with severe rash. So what drug do you have in a woman of reproductive age? So now there is enough evidence to show that lacosamide is safe. Even oxcarbazepine is safe. So they come under as second line drugs which can be used in pregnancy in case you cannot use. But using valproate is an absolute contraindication. And if you are using valproate, we have to take a signature that other drugs are not suiting her, and this is required for the management. Still 96% chances that you will have a normal pregnancy. And every woman should undergo TFA scan between 16 to 20 weeks, and if any significant malformations, you will terminate. Otherwise, you will continue. That is the plan.
Yeah, ma'am. One more question, ma'am. Sorry. The same regarding we can't measure the levels. Is it compulsory to, even though the well-controlled seizures, someone who is on Levipil 500 BD, levetiracetam, do we need to increase definitely the dose, anticipating that there is more clearance of the drug?
No, actually here the clinical this thing only is better. To be followed.
To continue the same dosage.
Followed. Maybe we can have an EEG along with it if there is a clinical and electrophysiologically controlled seizures. That's what we practice. Because this I talked, in the talk that I have given is ideal. Right. And last I have described also, Indian and other lower and middle countries, we don't have so much of facilities.
Thank you. Thank you, ma'am.
Everything is clinical and electrophysiological.
One question, madam.
Madam, with regards to usage of CT in pregnancy, I had attended one pregnancy-related CME for physicians, and they don't consider CT to be having such teratogenic potential.
Yeah.
Probably if it is used once or twice, even during pregnancy, for something which is probably not elective. Yeah. It doesn't have, this is overhyped, and with regards to usage of X-rays also, if a person who's probably in second trimester of pregnancy develops a pneumonia and we advise an X-ray, there is a big
uproar.
Uproar that you are using X-ray and you have advised for a CT, but good number of people who are actually dealing with them in day-to-day practice tell that it doesn't transform into high teratogenic potential.
I do agree. Actually, that is right. What is happening nowadays is a lot of Google knowledge with the patients and patient attendants. You have done this before this, and what is going to happen to our child? That is the main reason why I am advising you, as we have to take this thing. Written consent that we have. You are right. Actually, I am absolutely agree with you about this. It's not so teratogenic as it was described yet.
Changing gears, now we'll go to infections. Infections, talking to physician. Therefore, I had requested our ID specialist, Dr. Pratik sir, and recently he had made a wonderful diagnosis. I'm not sure it was possible without his knowledge. Over to you, sir.
Thank you, sir. So good afternoon. So I'm going to talk about approach to the infections in the brain and spine. So I have many case scenarios and simultaneously some theory that will breeze through. So we know this is the burden of neurological disorders across India. It's nearly 30 years data, and as you can see, around average 11%. So nearly 1/10 of what you see are infections. So it is a significant number. So we need to know about the neurological infections. So here the objective today we have is to recognize what are the infectious syndromes in CNS, to interpret the CSF and imaging findings. We need to apply the diagnostic algorithms and choose empirical and targeted therapies, and when we should go for surgery. So starting with first case here, it's a 65-year-old male, fever of 6 days with headache 5 days, vomiting, altered sensorium for 1 day. That's how he presented. He was drowsy, arousable. There was stiffness in the neck. WBC count was high. So we proceeded with the lumbar puncture. This is his CSF picture. WBC of 700, neutrophilic predominant, low glucose, high proteins. Gram-Stain was negative. This is a common case what we see. And here, as you know, the working diagnosis is acute bacterial meningitis is a first possibility here. So we did this is what we commonly use nowadays, the multiplex PCR, and it gave the Streptococcus pneumoniae here, as you can see, and enterovirus. So this is a common clinical diagnosis that we see, and with the advent of this multiplex PCR for last 10 to 15 years, I think it has made a significant change in the diagnosis. Because previously the microbiological diagnosis was not as much in CNS infections, but with this we have been able to pinpoint what is the etiological diagnosis in many CNS infections. So this is one case. So similarly, so this is another case, a 56-year-old male, post-splenectomy, not vaccinated for the required vaccines. Fever, headache, vomiting, altered sensorium, similar picture. Here again, neutrophilic, low glucose, high proteins CSF. Sorry, the 10 is extra in proteins. Okay, sorry. Yeah, so here as you can see, H influenza is detected on the multiplex PCR, and both these tests were culture negative. So as you can see, he is a high risk for the post-splenectomy, high risk for the H influenza infection. So that also reminds us that what are the indications for the H influenza vaccination, high risk individuals post-cochlear implant, post-splenectomy. So that is another case. Third case, a 68-year-old female, 4 days fever, headache. Again, WBC here is 130 in CSF. Lymphocytic predominant. Glucose was normal, little high proteins. Gram-Stain was negative here. And the multiplex PCR showed varicella zoster. So again, one of the common scenarios where you have acute encephalitis. Here, syndrome is acute encephalitis syndrome. You can see there is altered sensorium, seizures, which point towards the brain parenchymal involvement, not meningeal involvement. So this is a encephalitis syndrome where the common possibility, first possibility is of viral infections, and you can see there are multiple viruses which can cause this. I'll come to the details little later. And this was a varicella zoster. Similar patient here, again, here the diagnosis was herpes simplex virus 1, HSV1. So this is what I was talking about. So this is a multiplex PCR for the CSF. This is the only FDA approved panel. That is why we use it. There are multiple other panels available in the market. Many other labs do in-house PCRs also, but they are not very well validated. You can have a lot of false positive, false negatives. So this is the reason most of the corporate hospitals have been using the same panel, and this is the only panel approved by the FDA. So you get reliable results with that. So it identifies the common viruses which can cause the encephalitis, which is CMV, enteroviruses, HSV1, 2, HHV6, paracovirus, varicella zoster virus, the common bacteria, E. coli, not all E. coli and Klebsiella, mind it, H. influenzae, Listeria, Neisseria, strep, pneumonia, and Agalactiae, and Cryptococcus. Now, one thing which I want to tell you is this panel is meant for acute infections except for the Cryptococcus. So any chronic meningitis that you suspect, this probably may not be the right panel, because the cryptococcal meningitis, if in case you don't have financial issues, it is definitely better to do this. But if you have to choose, if your finances are limited, I wouldn't do this panel upfront in chronic patients, chronic meningitis, because for us the chronic meningitis first differential is usually a tuberculosis. The tuberculosis test is not part of this panel. So that also we have to remember, it is not a replacement. So when your working diagnosis is possibly TB, you have to do other tests. I'll come to the details of that. Now, other thing that it doesn't have is few other viruses which are endemic in India. So like it doesn't have rabies, it doesn't have JE virus, it doesn't have the KFD, the Casanova forest disease, or the Chandipura, all these, which some of them are endemic in India. So those things are not part of this panel. So that we should be mindful. That it does not exclude. See, it's a multiplex PCR with limited primers or probes. So only if the virus is included in this panel, it will pick it up. Otherwise, it will not. So negative test doesn't rule out the other viruses as a working diagnosis. So you need to know what is your syndromic diagnosis. Now, this is a case, a 12-year boy. These are all cases we had in last few days now, last 1 month. A 12-year boy comes with headache and seizures. There was no focal deficit. He already had a CT scan of the brain done outside, which showed a frontal lobe abscess. He was started on antibiotics, referred here. We drained the abscess, cultures are negative. Already he has received antibiotics. What do we do? So by the time he came and we gave him, he was posted for surgery, it took a couple of days, and cultures expectedly came negative because of the empirical antibiotics even we gave him. So now how can we reach a diagnosis here in the cases where there is already antibiotic exposure? So we did, this is a newer test which probably is available for last 1 year or so. This is a NGS test, microgenomic next generation sequencing. So here, even if it will basically try to identify the genome, it doesn't mean it's like a PCR, but in PCR you have limited probes or primers, so you have a limitation there. But here, any bacteria it can identify. So that is the thing. So here you can see it identified Strep anginosus and Streptococcus intermedius. Both are very well known to cause the brain abscess syndrome. So here we could identify the pathology. We could stop vancomycin and metronidazole here. The patient was discharged only on ceftriaxone. So that is so you can avoid, because it's a brain abscess syndrome, you are looking at 4 or longer weeks of therapy. So you could avoid unnecessary drug use for such a long time. Similar case, a 9-year-old boy, here he has a history of extrahepatic portal vein obstruction with ascites, and he also came with similar brain abscess syndrome, diagnosed outside, received antibiotics. Again here the identified organism was Streptococcus anginosus complex. Similar thing here, the possibilities were broader because he has ascites. So even gram-negative infections can cause in such scenario when you have a liver-related or gut-related issues. But here again it was strep anginosus, and he was again discharged on ceftriaxone alone. Now this is a little unusual infection, but yes, it is known. A 21-year-old male boy, his acute onset headache with left-sided hemiplegia, no fever. MRI done here showed there is an abscess on the right side, and the blood cultures were negative. Brain biopsy is done. We are awaiting. Now, again, he was on antibiotics by the time he went for a surgery here. For both therapeutic as well as diagnostic reasons, cultures were negative on a brain pus as well, the tissue. It was not exactly a pus when surgery was done. They could see a little hard material, and this is what it turned out to be, a Burkholderia pseudomallei. So this was diagnosed radiologically already. They had suspected it's based on the clinical and radiological picture per se, and when we asked him initially based on the radiology, this boy had a history of travel and he had a waterfall exposure. So he had gone to swim or he took a bath in a waterfall, so just a few days before the onset. So this is a known bacteria which can come through the water, natural resources. So this was fitting with a clinical diagnosis, and had this test not been available, probably we would have just ended up treating him. He was already on therapy for the Burkholderia pseudomallei, or the melioidosis, what we call it. But we could prove that this is the same infection, which is very rare. Neuromyelioidosis, we see other melioidosis cases quite commonly, the other systemic abscesses, visceral abscesses, but neuromyelioid far rare. Now, talking about the test, the next generation sequencing, the sensitivity is very good. It nearly around 72%, and it is a very good test for the sterile specimens. Whenever we have the abscess syndromes for anywhere, probably it's one of the very good tests which we are getting used to it more and more. We are getting experience, and it is turning out to be a good addition to our diagnostics. So TB, probably it's not very sensitive as of now, but yes, it is a good test to have. So now CNS infections, when we see, like we discussed, we have possibilities of acute meningitis, encephalitis we discussed, brain abscesses we discussed. Now coming to the red flags when we should suspect. So like we discussed, severe headache with fever, any new neurological deficits, altered mental status, seizures. We need to see any signs of raised ICP. And when there is a back pain, fever and deficits, this is when the spinal infections we should suspect. How to proceed? A suspected meningitis, this is an important step. Yes, CSF is important, but blood cultures are equally important, which is often missed. So any patient, because let us say pneumococcal meningitis is an invasive form of pneumococcal infection. Pneumonia is not an invasive pneumococcal infection. So invasive pneumococcal infection is usually a bacteremia and the meningitis. So there are good chances that you may pick up pneumococcus even in blood culture. So for some reason, if you are not able to do the CSF immediately, blood culture might still give you a diagnosis. So never forget the blood cultures even in meningitis patients. We need to check the indications of CT before the LP, which we know all well. And then we need to start antibiotics before the CT along with the steroids. That is important. Steroids should be given before or with antibiotics, not after, if your clinical diagnosis is acute bacterial meningitis. And the test what we do, commonly the cell counts, proteins, glucose and PCR. So this is just interpretation table what we have been seeing from MBBS times. So in bacterial meningitis, usually the opening pressure is high. It is also high in the TB and fungal, especially the cryptococcal meningitis. So in that, actually the repeated lumbar punctures to reduce the CSF pressure is a therapeutic indication, not only diagnostic, to reduce the intracranial pressures. In bacterial, obviously you have a lot of polymorphs. On the other three, you have usually lymphocyte predominant. Glucose is usually very low in bacterial, relatively lower in TB and fungal. However, in viral it is normal. Proteins are usually very high in the bacterial and fungal as well as in TB. So I think etiology of the brain abscess we have discussed. Streptococci, anaerobes, sometimes staph, especially after trauma and surgical cases. Hematogenous, sometimes staph aureus and GNBs. So abscess management we have discussed more or less, and the Neurosurgical drainage is required if the size is more than 2.5 to 3 centimeters. Total duration can be 4 to 8 weeks depending on the response. Empirical therapy is usually a ceftriaxone with metronidazole plus minus vancomycin depending on the risk for the staph aureus. Post-surgical, we have to cover for the gram negatives as well. In immunocompromised patients, we have to consider for the fungal and parasitic causes also. This is important. What are the antibiotics which penetrate the CNS well? So ceftriaxone, vancomycin, meropenem and metronidazole are the preferred drugs because of their CNS penetration. Other cephalosporins or carbapenems need not penetrate the brain well. So this is the thing. So among the cephalosporin, ceftazidime penetrates well, cefepime penetrates well, imipenem also penetrates, but both cefepime and imipenem can have a neurological side effects. That's the reason we usually avoid them unless we don't have an alternative. So ventriculitis shunt, I'll skip. Okay, this is another case. 45-year-old male coming with fever of 6 days, altered sensorium, no neck stiffness, but there is increased creatinine, transaminitis. So again, this is probably encephalopathy or encephalitis syndrome, and this is the diagnosis. So scrub typhus. So you need to have a collective. Many a times these patients present with CNS involvement also. So this is one paper which was published from South India, which showed association of scrub typhus with acute encephalitis and meningoencephalitis as well. And a significant proportion of patients showed their scrub typhus can have a neurological involvement, and these are the tests which can help us. PCR is available in some of the centers. We commonly don't do the IgM. ELISA is what we use, and in the appropriate case scenarios, it is confirmed. Serology, serum test also is confirmatory. We can do the test even on CSF. In some cases, we can even do a Will-Felix test because not all scrub typhus or typhus cases may not have a scrub typhus positivity. In those cases, Will-Felix can be added to the diagnostic algorithm. So another thing commonly we see is dengue. Dengue with neurological involvement is again very common. So is it visible? Yes. So since we see a lot of the tropical infections which can cause the neurological involvement, this is a paper which studied mostly the North Indian sites, Assam, Bengal and UP, I guess, where JE virus is a predominant virus. So they first, whenever there is an acute encephalitis syndrome, they first evaluated for JE virus. Then they looked at the PCRs, HSV enteroviruses, and serological tests which can be done is test for scrub, dengue and West Nile virus when it's appropriate. So these are the other infections which can present with neurological involvement. So other rare possibilities is Zika virus and chikungunya. We have, maybe last year we had a lot of chikungunya cases with neurological involvement also. So that we have to see the epidemiology also to consider this as a possibility. Now this is another case, 40-year-old male presented with headache at 2 weeks, drowsiness, no fever. He was referred to us with a wet mount suggestive of Naegleria fowleri as a diagnosis, but we ruled it out doing appropriate tests. But when we did initially when he presented, we repeated a CSF. It showed 81 WBCs, little low glucose, proteins were high. Gene expert MTB was trace detected, and RIF resistance was indeterminate. And there is a significant history, the lymph node TB that he had 2 years ago and was treated. Now, why I am presenting, I will come to that. Now, this is a common scenario when we talk about CNS TB. The gene expert showing an indeterminate report, the trace detected and indeterminate RIF resistance. But here, he had a history of TB just recently. And if he still has symptoms of TB, CNS TB, it was important to consider for MDR TB. So in this case, actually we repeated a CSF after a couple of days with a higher volume, and when we did, it turned out to be MDR TB. So it was a RIF resistance detected in this patient. So that is an important learning lesson for us to know that. First thing, gene expert and CBNAT are same in most of the government hospitals and all. They call it as a CBNAT, which is the same as gene expert. However, TB PCR is different. They are totally different tests. The gene expert, what we use is gene expert ultra, which is much sensitive test. The pickup rate is high. So when we are ordering, please specify that it is a gene expert, not a TB PCR. TB PCR will not, it is less sensitive. Second thing, it does not give you the rifampicin sensitivity. That is important. So this is a study where they looked at the volumes of CSF that will increase the yield of the gene expert in suspected TB patients. So in short, basically whenever you are suspecting a TB meningitis, the minimum volume of CSF that you need to send is around 5 to 6 ml. The lab has to be told to centrifuge it and only use the sediment of that for the performing the gene expert, so that the yield is better, so that we can get a confirmed diagnosis to identify whether it's TB or not and whether it's a sensitive or not, RIF sensitive. So this is another just example of one of the tests what we have recently. This is just 2 days ago that we got this CSF again, one patient, where the gene expert, you can see there is a very low load of TB in the CSF with no RIF resistance. So tuberculosis diagnosis is important. We know it's AB stain. Mycobacterial culture is also important. So if you send the 6 cc CSF, in that when they do a sediment 1 cc, they can use for the sediment. Out of that, only 200 microliters is used for a gene expert. Rest they can use for the TB culture, and obviously histopath whenever it's a tissue. So what is the role of MAN2 or IGRA in the TB diagnostic? It's not really, you can't make a decision just based on MAN2 or IGRA. However, it can be considered in patients. If it is negative, probability of a TB is less, but again, it may not be again reliable in very immunosuppressed patients who are not able to mount any immune response. So MAN2 or IGRA can be false negative in these patients. So TB, as you know, the therapy is nearly 1 year depending on the diagnosis. In bone TB, it can be 9 months to 12 months. It is 4 drugs for 2 months followed by HRNE. Previously, we used to say that only H and R, but we used third drug also. The reason being, in India, the isoniazid resistance is around 15%. So that is the reason. So if you are 1 in 6 patients or 1 in 7 patients will be on a rifampicin monotherapy if we are giving only 2 drug regimen as a part of continuation. So that is the reason we prefer at least 3 drugs in the continuation phase, unless you have a proven sensitivity to both H and R. So otherwise, all patients we usually give the H and R with E. So when we have a chronic meningitis as a working diagnosis, these are the differential diagnoses that we have. Tuberculosis, cryptococcal meningitis in immunocompromised patients. Brucellosis can be a closed differential. Histoplasmosis or any endemic mycosis. Fungal meningitis is a possibility. Lyme's disease is one. Syphilis and nocardiosis in immunocompromised patients. So these are the things. TB and nocardia in immunocompromised patients can be very, very similar. So we need to be very careful in getting the diagnostics done. So in such cases, whatever the sample we are doing, we need to do the stain for the modified AB for the nocardia, because we can otherwise easily miss it. So this is the next case. Coming to the spine infections now. A 60-year-old male coming with neck pain of 15-20 days duration with both upper limb and weakness, tingling and paresthesias. So he had on MRI, there was a C6, C7 discitis with erosion, and there was a pus which was drained, and that's when I was called. So this is, blood culture was ordered, and blood culture showed this staph. So again, this is a MSSA, as you can see. So same point here. There is vertebral osteomyelitis or discitis. Blood cultures are often positive. That is why whenever there is a suspicion of vertebral osteomyelitis, acute or subacute, you should do blood cultures so that you can get a diagnosis. So based on the site of infection in spine infections, you can have vertebral osteomyelitis, you can have discitis. It can be spondylitis, it can be a spondylodiscitis, facet arthritis, posterior element osteomyelitis, and hardware-associated vertebral osteomyelitis. These are the different spine infections that we have, and this is how the infections can spread. So you can have a contiguous focus from the local infections which can go to the spine, or you can have an infection from the urinary tract also can go and infect the spine. So the bacterial infections, more common being the staphylococci, gram-negative infections. Non-pyogenic are the granulomatous, common being TB. Brucella is common, which we need to have a high suspicion, and fungal infections are also possible. So the spinal epidural abscess, the triad is back pain, fever and neurodeficits. MRI is the gold standard. Staph aureus is the common diagnosis. If there are neurodeficits, surgery is to be done urgently. So like I said, MRI, blood cultures, antibiotics only if the patient is unstable. That is the difference here. Brain infections, antibiotics are empirically to be started immediately. Spine infections, unless there is a neurodeficit, you can wait. You can get a diagnosis done and then start antibiotics. So surgery, if there are deficits or any large abscess, 4 to 6 weeks minimum is the duration of therapy. So I think these are more or less similar. Now this is a case I'll discuss. 77-year-old male, fever of 10 days, constipation. WBC was normal. He was diagnosed outside with enteric fever. This was in August actually, and he was treated with cefotaxime. He got better. But September he had pain in both sides of the lower chest, and that's when he was admitted in another hospital. He had CT chest and abdomen done. Abdomen was normal, and CT chest showed prevertebral and bilateral soft tissue density at D5 to D8 with erosions at D5, D6. So WBC, CRP, LFT, everything was okay. ESR was high. MRI showed spondylodiscitis, and he was already started on ART when he came, but he was not having any improvement. This I saw, I think, 2 months later. So this is his PET CT was done before coming only. So it basically showed there is, again, diagnosis PET CT also you can see this is they have written diagnosis as possible TB. Okay, but he is not improving. So we did a biopsy, expert negative. Now what it could be? What will you do? Okay, this is a surprise here. So the biopsy showed salmonella. It's a typhoid. So basically it was a partially treated enteric fever which lodged in the spine, and he caused a vertebral osteomyelitis of the spine. So that's why tissue diagnosis is important. Getting a biopsy in today's practice is very important, especially when we have the access. When it was not available, it's fine. But now it's easily available. It is a CT guided or radiologically guided biopsy which can be done as an outpatient procedure. Here the consequences can be severe. Patient can have a lifelong deformities and morbidity. So it is important to at least offer a patient why it is important. It is important to explain what we can do to confirm the diagnosis so that treatment can be appropriately started. So that is there. So these are the different bacterial infections which can cause the spine infections. I think I'll just Staph aureus, gram-negative, which we have already discussed, Streptococci, Pseudomonas and coagulase negative, especially after the procedures. Granulomatous causes like TB, brucella we discussed. Burkholderia pseudomyeli again can cause vertebral osteomyelitis. We have a couple of cases. Salmonella is important here. Now clinical features: back pain, motor weakness, fever, and presence of indwelling devices. Any drug use can be a risk factor for the vertebral osteomyelitis. So these all history we have to ask. So there was one case which came to me with low back pain, unilateral sacroiliitis. I just asked, it was referred. He actually went to 2-3 people and then came to me. First thing when I asked, what do you do? He said, I'm a veterinarian. First test, brucella came positive. So that is important to know syndrome and what is the risk factor. So these are the tests what we can do. The imaging wise, nuclear scans, like I showed in the last case. So I think we are using more and more nuclear scans to get not only the anatomical diagnosis but also the functional diagnosis, so that we can know where is the problem and we can do an appropriate diagnostic test or tissue diagnosis to increase the yield of the biopsies. Endocarditis has to be suspected in certain cases. So blood cultures are important. Serologies like brucella and salmonella can be diagnostic. Inflammatory markers like high CRP particularly can be seen, especially in bacterial infections, not so high in TB. So doing bacterial cultures, including TB cultures, is important. Doing the TB diagnostics, we already discussed. NGS is important, new addition. Urine cultures and MAN2 and IGRA already I discussed. So I think I'll just skip this. Nuclear imaging. We know the PET CT we have been using quite a lot. There are scintigraphy scans like bone scan and gallium scan. which can be used to identify if there is any active uptake to such active infection is there. PET CT using FDG, especially when combined with a CT, is highly sensitive and very high negative predictive value for vertebral osteomyelitis is important. So blood cultures, it is reported microbiological diagnosis varying between 20% to 60%, but when you have a positive culture, it gives you a 100% diagnosis. So the sending appropriate volume of blood cultures is important, especially in meningitis, acute bacterial meningitis and vertebral osteomyelitis. Sensitivity is lower in post-operative patients and higher in patients with fever. So whenever you have a fever, make sure that you are sending blood cultures. At least 2 bacterial blood cultures, including an aerobic and anaerobic set, should be routinely performed. And candidemia can also be picked up. Brucella is also very good pickup in the blood cultures. So labs, I think I have already discussed this in patients with endocarditis related organisms. When you are finding in patients with blood culture positive, then we should suspect endocarditis. I think this is more or less we discussed. Yeah, I think this is the last case for me. A 70-year-old female diabetic, back pain of 3 months, paraparesis with bowel bladder involvement, no fever, anorexia, weight loss. WBC was normal, little high ESR for her age, CRP was high. MRI showed D8, D9 vertebral osteomyelitis. She had a spine fixation laminectomy, empirically started on ATT. Despite that, there was a worsening and re-exploration was done. And this is what we found. If you see, this is aspergillus. It's a vertebral osteomyelitis due to an aspergillus. So we started her on voriconazole. She took nearly 6 months, but she's back to normal. She's able to walk. She was paraplegic, bedridden at that point. So we could she could recover completely. So I think treatment. So duration of treatment is very important aspect in neurological infections. We don't want to undertreat. Now, as far as the spine infections are concerned, 4 to 8 weeks of therapy is important, but we need to assess it based on the clinical response, inflammatory markers. Based on that, the treatment duration can be variable. So antifungals need to be given for 6 to 12 months depending on the involvement. So the take-home message, early recognition of neurological infection is critical. We do not want to delay antibiotics when meningitis is suspected. Contrary, in spine infections, diagnosis is critical and empirical treatment should be avoided. Adequate volume of blood cultures has to be taken. Pus and tissue cultures, whenever we are doing, make sure you are sending bacterial and TB cultures as well. Serologies like dengue, scrub typhus, leptospirosis, brucella, including measles, is also important in appropriate cases. Measles can present with acute encephalitis seizures, so that is important. And malaria is that one we should not forget. We don't see it that commonly now, but acute encephalitis, meningitis, malaria is another thing. Multiplex PCRs, polymerase chain reaction, including multiplex PCRs, gene expert are important in diagnosis. NGS is one new addition. MAN2 and quantiferon is limited utility. And we need to have multidisciplinary collaboration with radiology, the neurology, and the other departments for a better outcomes. Thank you.
So my question is about this NGS, which is very exciting for infection. So is it to be taken only from the site of suspected infection, or it can be taken from blood? For instance, if a patient has a suspected vertebral osteomyelitis, can we simply take a blood sample, or we have to take it from bone only?
Sir, if there is a fever, I would prefer a blood culture to be done. It can be run on a blood also, but it is not very sensitive that way. So if there is a possibility, blood, the concentration in the tissue is much higher, so pickup rate is much better. So I would prefer it to be done on a sterile samples, like blood also can be done, false positivity is less, but I think tissue is always better. When we know there is a abscess or a vertebral osteomyelitis or pus anywhere, that sample directly is a better sample than a blood sample.
Similar question on biofire, multiplex PCR. So what is the yield? Is it much? Is the yield on this biofire better than the blood culture and CSF culture? Is like if biofire comes positive, does the blood culture and CSF culture always come positive, or biofire is sometimes positive but sometimes blood culture and CSF may be negative? Okay. So one is a time advantage, I understand, okay, but is the yield also much better on biofire?
Okay, sir. When we say biofire, there are it's not one test; it's a syndromic panel. So when we say biofire, there are 4 panels. One is a BCID panel or blood culture identification panel, which can be done only on a positive blood culture sample. When we draw the blood culture, we send it to the lab, they incubate, and when there is a certain bacterial growth, the machine gives you a positive flag. That's when we can do a BCID panel. We cannot do the BCID, or it is not recommended to do on a direct blood sample. So whenever we are running a BCID panel, it is understood that the blood culture is positive. So it is 100% true positive. Now when we talk about CSF, it is a meningitis panel what we commonly run. Meningitis encephalitis panel. In that case, the yield of the CSF cultures is very poor. We rarely see CSF culture coming positive. We have probably in last 5 years here, I have seen probably only couple of times CSF growing a pneumococcus, probably once it grew listeria. We have identified organisms post-surgical meningitis, neurosurgical meningitis we have identified. But for a community-acquired meningitis, we have rarely found the bacteria coming in a CSF. So in that case, it has a definite advantage. The pickup is much, much better for the CSF panel for the bacteria. Obviously, viruses, we don't have any other test. Means we have individual PCRs also. Now, if you compare with the individual PCRs, HSV, we have a VZV PCR also, it is almost equal. So 96 to 97% for each organisms is the sensitivity of the multiplex PCR. So that is there. So there is another panel called respiratory panel. Now, the CSF and blood both are sterile specimens, so your chances of false positivity are less. It is less likely to be false positive, more likely to be a true positive. But when we talk about respiratory panel or pneumonia panel, it can identify even the colonizers. So that's when your clinical diagnosis and whether there is actual pneumonia, patient has respiratory symptoms, any patch, how are the respiratory secretion, those things come into the picture. The panel also, it has, like we say, colony count on a culture growth. Similarly, the panel also has a semi-quantitative method. So that will also give you whether the colonies are probably 10⁻⁴ to 10⁻⁷. So that may be an add-on to your clinical diagnosis that you can consider. But again, just because you are finding something on a respiratory panel need not be treating compared to what you are finding in a blood or CSF panel. So CSF and blood is definitely much sensitive and much better. The false positivity is very less. Right. Yes, sir. It is not 100% test. It is not a 100% sensitive test. So in the best conditions, when you are, like I said, if you are sending good volume, so the pickup rate of GeneXpert is directly proportional to the volume that you are sending. So if your volume is adequate, you can pick up to 70% of the, 6 ml. That too again, now the current platform what we have is called GeneXpert Ultra. The previous version was GeneXpert alone. So with this, the CSF pickup rate and sensitivity is much higher. So up to 70% in good samples. But again, rest 30%, it is still possible that it might be negative, where your other radiological, clinical, biochemical parameters you have to consider.
So in such cases, is it required to start empirical ATT?
Definitely yes. If your other, it's not that, that's what I'm saying. GeneXpert negative, but if your clinical diagnosis is TB with no alternate diagnosis established, definitely I will start ATT. I can't say just because GeneXpert is negative, my patient doesn't have TB. You can definitely start on ATT.
So do you recommend that apart from GeneXpert, we should send a NGS panel simultaneously?
We can do that.
So how much will be the cost implication?
I think the cost of the NGS is around 12,000 rupees approximately.
Thank you, sir.
See, another thing is, now with this, the GeneXpert, the sensitivity is probably equal or even better than the gold standard, which is culture. So the other test what we can do in such cases, there are instances where we have seen that we have sent culture which grows after some time. So whenever there is a gene expert negative where suspicion is high, the other test which I would recommend is definitely a TB culture. That we should do.
TB culture takes time to know.
Yes, but in the meantime you can start on empirical ATT. If your culture grows, it confirms your diagnosis.
Thank you, sir.
Yeah, we'll end this now. We have treated stroke, epilepsy. Now comes the monitoring. I'll ask Dr. Harsh, our intensivist, neurointensivist, to take over.
Good afternoon, everyone. Welcome all the delegates. Thanks to Dr. Sita ma'am, Dr. Praveen, and the Neuro team for the invite. So today's talk will be very basic and practical discussion on the common neuro emergencies that we face day to day. Most of the cases that you see we have managed recently only. So, and the role of neuro monitoring and how we can immaculately manage these patients by the use of proper neuro monitoring. So this is a very famous photo. On the left upper side, you can see this is the famous picture from polio epidemic in 1950, where the iron lungs ventilator saved countless lives. And lower down is Dr. Peter Safar. He is known as father of CPR. So these two laid the foundation for neurocritical care, basically, way back in 1960s to 70s. Also important is to understand that the understanding of the acute brain injury has really evolved over the period of time. Right from excitotoxicity and mitochondrial dysfunction to understanding the mechanisms of edema, and also understanding that there is an impaired oxygen diffusion and perfusion mismatch to impaired autoregulation, energy dysfunction, inflammation, and consequently leading to neurodegeneration. So this has led to better understanding of the mechanisms, and that has led to better monitoring of these patients as well. Also, what this has impacted is the management, is the initial golden hour management, and it has impacted the early interventions in these neuro emergencies that can really help for better neurological prognostication. Apart from intensive care management, definitely the thing that has really helped in this is a proper neuro monitoring. Apart from the classical clinical examination, non-invasive and invasive monitoring tools have really helped in management of these patients in a far more better way. So this is the cornerstone for clinical management, basically clinical monitoring. Everybody knows about this GCS scoring. This has remained the cornerstone for clinical monitoring for a very long time. Developed in 1970 by Jennett and Tesdale, this has stood the test of time, stratifying the patient into mild, moderate, and severe brain injury. But it has pitfalls. Everyone who is practicing, they know that it has pitfalls. So it lacks reliability. It has subjectivity. M3, M4 can be M3 to somebody, M4 to somebody. So how do you really trust? How do you really monitor when there is subjectivity? Also important is it is less sensitive to the sensorium changes. Also doesn't account for brainstem reflexes. A phasic patient with unilateral neurological deficits, GCS is not the proper score. Also, in cases of ICU patients who are intubated, sedated, and relaxed, it is very difficult to assess. So what do you do? So there are pitfalls to GCS. Other important monitoring that is really, really important, and sometimes we undermine in our clinical practice, is hemodynamics. Heart is the mirror of the brain. That I always tell people, that heart is the mirror of the brain, and the most important neuromonitoring tool, and BP is the only modifiable factor that you have in your hands while you monitor. Everybody of us have seen this classical picture of what we call as this. This is how BP is closely related to the MAPS. This is cerebral perfusion, CPP, what we know as cerebral perfusion pressure. It is directly related to the MAP. MAP minus the ICP is the CPP. This is the thing that we know. So immaculate management of BP targets are very, very important, particularly in patients with acute stroke, in which you have to maintain the BP properly. So don't shy away so we don't have to shy away in putting arterial lines, and also important is to put maybe an advanced hemodynamic monitor if required. That we do regularly in our ICUs, in which threading of arterial lines are very, very common in acute stroke, in which immaculate BP management is required. Patients having a cardiac dysfunction along with the stroke sometimes might require more intensive hemodynamic monitoring, in which we can place this hemodynamic monitor, which is known as volume view. Nothing beats hemodynamic monitoring in acute stroke. Say in ischemic stroke, right from you can see starting from the initial emergency management, whether you are thrombolizing the patient or not thrombolizing the patient, or shifting the patient to a revascularization angiography suite, and also after post-intervention, whether we are medically managing the patient or managing the patient post-intervention, each has got a specific target to be achieved. So we have to maintain the BP targets very, very diligently in these patients. Also, equally important to maintain the BP hemodynamics is in hemorrhagic strokes. Every one of us knows about this MAP and cerebral blood flow relationship. The optimal range of MAP is between 60 to 150, and every one of us are aware of the fact that anything that is under it or above it will cause deficits in the CPP. So that's why AHA also recommends a systolic BP of 130 to 150 to be maintained in the patients of ICH patients, so that an optimal perfusion can be achieved. So if these two things are not adequate, then say these are two cases that we have managed. This is a 45-year-old. First one is a 45-year-old large stroke, ischemic stroke, GCS around 10-11. Okay. Second is a 50-year-old ICH, GCS of around 10 with an ICH score of 3. Now, how do we guide our anti-edema? We know that both these patients are bound to get deteriorated. GCS, is it a proper tool? GCS might not be very, very adequate. So how do we monitor these patients? How do we know? Do we do serial scans? What guides us? When do you increase your anti-edema? When do you go for decompression? So it is a bit vague. There is something missing in between that we are not doing if we are just doing the clinical monitoring of these patients. So every one of us also knows that till the late signs of deterioration comes to our picture, the third nerve, whenever it is already involved, there is dilated pupil or the Cushing's triad is triggered, already the damage has been done. There are already herniations started, and when we pick up patients at that moment of time and the ICP is gradually rising, it might be too late and we have missed out the patient. So here comes the value of ICP monitoring. Okay, ICP you can invasively monitor. There are non-invasive tools as well, but invasive ICP monitoring, intracranial pressure monitoring, is a gold standard, in which you can see there are small catheters that are placed into the intraventricular space or subdural space, and it is connected to a device that is a transducer and gives you a number. So normal ICP is around 10 to 15. Any ICP that goes more than 20, consequent to a CPP of around 50 to 70, this machine will give an alert. Okay. Also, some of the transducers will be having waveforms as well. So whenever you get an alert, we can always modulate our anti-edema therapies, like mannitol giving 4 times a day, 3 times a day, 6 times a day. It's very, very difficult to decide just by seeing the clinical monitoring. So this helps us to guide our anti-edema therapy. Also, in spite of giving anti-edema therapy, if the ICPs are still on the higher range, we can always go for an early decompression and salvage this patient. So this is the waveform that I was talking about. See, there's P1, P2, P3. This is the normal ICP waveform. As the brain is becoming more and more non-compliant, you will see that the P2 component is rising. So just by monitoring the waveforms, we can know what is happening to the patient. But it is not always feasible. I would also admit that we also don't put invasive ICP monitors very regularly because you require a surgeon to place it. It is technically, there is a lot of finance involved. Sometimes it is not feasible for us to do that, but we have a good other tools in our hand. There is something non-invasive ICP monitoring. Ultrasound has come in a big way in the ICU, and you have to know ultrasound now. To practice in the ICUs. It's such an important part now. It's almost like a sixth vital sign now. So non-invasive ICP monitoring, this is something known as optic nerve sheath diameter. What you do in this 3 to 7.5 size megahertz probe, you place it on the orbit of the patient and you try to focus perpendicular at the entry of the optic nerve. 3 mm behind the optic nerve is where you calculate the optic nerve sheath diameter. So cutoff is roughly around 5 mm to 5.7 mm. So this is one of our patients that we manage. See here, you can see the optic nerve sheath diameter is around 6 mm, that is on the higher range. As we gave anti-edema to this patient over the period of few hours, you can see that optic nerve sheath diameter is coming to normal. Okay, this is the pictorial representation of the same. You can see what happens really and how with anti-edema proper management, you can see that ONSD getting reverted back. Also helpful is TCD. TCD also has come in a big way now in neuromonitoring. Now you can see in a TCD, you use a 2.5 hertz probe. You can also use your cardiac probe. If you have an ultrasound machine, the cardiac probe can be used. Only thing you have to put a TCD software into the machine. So what you do, you put it on a temporal window. Here you can see the third ventricle, you can see a contralateral temporal bone. Okay, and as you fiddle with the probe, you can focus on ACA, MCA, and the PCA arteries, and you can calculate the pulsatility. This is a waveform that comes. So this waveform has a systolic velocity, it has a diastolic velocity. Then you can also calculate the mean velocities of all the arteries into it. And this is a normal wave that it looks like. So what happens? What can we do? In TCD, in ICP monitoring, what happens? As the pressure is rising in the brain, what happens is, there will be, as the raised ICP is there, you will see that the pulsatility index is rising because the pressure is increasing. So PI will be rising and the blood flows will also be shrinking. And as a result of that, what happens? There will be a diastolic blunting till the diastole totally vanishes. And you can see as the ICP increases, the diastole totally vanishes and the CPP also goes down. This is one of our cases that we managed. You can see that there is a diastolic blunting that is happening early on. You identify it, you increase the dose of mannitol, and consequently after hours of monitoring, you can see that gradually the diastole waveforms are appearing and getting normal. One more thing that we can do, we are still trying to learn this, is we can also see a midline shift. As we already focused from the temporal bone, we can calculate the third ventricle distance from one side, also calculate it from the other side, and try to see the midline shift. So any patient who has a midline shift, has an impending midline shift, we can always monitor and you don't have to shift the patient again and again for CTs. Once you have a CT scan, you can use your TCD to know about it. But the only issue is that there is an issue of subjectivity into it, so you need to really learn and you need to do it more and more to get a grip of this. This is another thing that it is evolving, but I won't say that we regularly do this, is TCD can also be applied in acute stroke, in which TCD if done at 6 hours and shows a better recanalization, you can always say that the clinical improvement might be better. Delayed recanalization sometimes is associated with high risk hemorrhagic transformation in acute stroke. Other important area in which TCD has really proven its mettle is patients with vasospasm. It has become one of the gold standard things to detect and monitor vasospasm in patients with SAH. So now moving to another clinical scenarios. Now this is a 25-year-old. I think I'm sure that every one of you must have encountered these kind of patients in your practice. So this was one of our patients, 25-year-old viral encephalitis patient, presents to the ER with status epilepticus. So what do we commonly do? We initiate the ABC management, airway, breathing, circulation established. You give a loading dose of benzodiazepine, patient is stabilized. And now this patient is shifted to the medical ICU for further management. In the ICUs, we continue to monitor. Loading doses of AEDs has been given. We continue to monitor this patient for a few hours, and we start seeing the patient is not doing good, and there are also episodes of recurrent seizures. Now what do we do? What is the monitor? How do we monitor these patients? Anyone? So how do we monitor these patients? So we all of us understands that status epilepticus, madam has already discussed about this in details. It's a very, very important entity to recognize, and early golden hour treatment is extremely important. In spite of giving initial benzodiazepines, you need to monitor this patient, and the gold standard test definitely will be a, if possible, continuous EEG, and that really helps you to guide the evolution of the disease. You can see the initial lorazepam as we gave, there is a generalized epileptiform discharges. As you give lorazepam, the EEGs tend to be normalizing. After a few hours of management also, as the patient is deteriorating, the patient is entering into a phase of refractory status. So we need to act really fast, start them on anesthetic infusions as quickly as possible, and monitor the continuous EEG over the period of time to really manage this patient. This is how it really helps us to manage. Another area in which EEG is really important, I think, these are two of the patients that you will very, very commonly see geriatric patients with altered sensorium. So this is one of the patients, 75-year-old, altered sensorium with fluctuating sensorium, and other one presents to you. How to discriminate between the two? It can be anything. The first, you see the EEG, there are epileptiform discharges more than 2.5 hertz, polyspikes. This is typically NCSC. That is the tip of the iceberg diagnosis that we do. Many people, many times we get the patients in our ICUs with roaming around many places, not knowing why the patient is having this altered sensorium. You just put the EEG and monitor the EEG for some time. You get NCSC patterns. Simply, you need to start. You need to look for the cause, and you need to start some AEDs, and you see the EEGs and the patient settling down. Second, most commonly you see definitely is a septic or metabolic encephalopathy. 75-year-old with a UTI. As you do the EEG, you see a generalized slowing delta, theta and delta waves. As you evaluate the patient, there is UTI. Sodium is 124. As you treat these patients with antibiotics and correction of sodium over the period of 3 to 4 days, they tend to stabilize. So EEG definitely is one of the gold standard neuromonitoring tool in the ICU that is required. Not only it tells about the electrical function of the brain, it is also, apart from the cases that we already mentioned, also it has a very good role in to predict the neurological outcomes in patients with hypoxic injuries, or also useful in patient with brain death. Another patient that we manage, say 40-year-old male patient admitted to ICU with viral pneumonia with severe ARDS. This is a very common clinical case we get as a critical care physician. So managed with mechanical ventilator, you start them on mechanical ventilator, oxygenation is not getting maintained, so you prone the patient. We prone the patient was on neuromuscular blockade for 6 to 7 days, and patient also received steroids. Now, tracheostomy was done, and slowly, as the patient started improving on 12th day, we are starting to wean the patient. Now what happens? There is a weaning failure. We are trying, the patient lung has improved, oxygenation looks better, we are not able to wean the patient. There is tachycardia, tachypnea, patient is perspiring a lot whenever we are trying to wean the ventilator. There is insufficient tidal volume generation, and there is quadriparesis, and the power has also come down. Any ideas? What can be the diagnosis? So the most common approach that we do in these patients is definitely look for the cause. This patient has risk factors, definitely. He has gone into a hyperinflammatory phase. We have used a lot of neuromuscular blockade. This patient has undergone proning, and he has undergone the entire inflammatory cycle. So we need to definitely neuro-examine these patients very nicely. Also there can be a neuromuscular blockade, residual effects of that. So that has to be seen. And also what we always think in critical care is critical care myopathy, neuropathy. So these two will be the number one DDs that we think of, because he has all the risk factors. This patient has all the risk factors. So there is something known as strain of 4 monitoring. It is like an electrophysiological test that we do, in which residual neuromuscular blockade can be seen. And this test, definitely there was no neuromuscular blockade. Another useful tool that we use in the ICU is a ultrasound to see the diaphragm. So you see the diaphragm, you see a reduced diaphragmatic excursion, and there is a reduced diaphragmatic thickness fraction. This tells you that there is a muscle weakness. There is a muscle weakness going on, and that might be the reason the patient is getting stuck up to the ventilator and not able to generate adequate tidal volumes. So the most common DD we need to rule out is already discussed is critical care illness, myopathy, polyneuropathy. This is one of the most common things that we do encounter in patients in which we are not able to, which spend a bit of time on the ventilator. So what do? Electrophysiology, ENMG, gold standard test in which you can do a ENMG, and particularly if the patient is of critical illness polyneuropathy, there will be reduced CMAP amplitude with reduced compound SNAP. If it is mainly myopathy, you get a reduced CMAP amplitude with increased CMAP duration with a normal SNAP. So you can put this as a very good tool to monitor these group of patients and try to reach to a diagnosis and then continue with the management. Another case, 72-year-old male patient with a community-acquired pneumonia with moderate ARDS. The patient is on mechanical ventilation. The pneumonia has reverted back. He's doing fine. Oxygenations are maintaining well. Again, this patient gets stuck up. We are not able to wean the patient. There is a weaning failure. Insufficient tidal volumes are getting generated. When you see there is a facial weakness and there are drooping of the eyelids. So what is the most common clinical diagnosis? Anything else? Yeah, myasthenia. So many of the myasthenias, we always have to keep in mind that there are very subtle myasthenias that goes around. Whenever they get into a crisis mode, they can go into. So our clinical diagnosis definitely here was myasthenia. So we did a neostigmine test. It was positive. AChR antibodies takes time. So the gold standard will be a repeated nerve stimulation in this case, which will definitely show a decremental response. That is a classical response that we see in myasthenia patients. So as we get the AChR antibody review, and so the diagnosis comes as underlying myasthenia with crisis. Immediately with RNS, as you neuromonitor these patients, you get the diagnosis. So what do? As you diagnose them early, you start plasma plex very quickly in them. Plex, because the patient is stuck on the vent, plex is a better option in these patients. We do a plex. Along with that, you add a pyridostigmine and a small dose of steroid. Patient starts recovering the third day, and you are able to wean and extubate these patient. Another common case that we see, 22-year-old male patient, history of bilateral lower limb weakness, symmetric ascending flaccid paralysis. I think this is very, very classical, with a history of fever and diarrhea 10 days back. Over the next 2 days, the weakness is increasing, bilateral upper limbs and respiratory muscles getting involved, patient getting tachypneic, dyspneic, with a single breath count decreasing from 24 to 11. So we received the patient with this history basically. On receiving, the patient definitely requires an intubation. So we intubated and ventilated this patient. So what is the most common? Anybody? So yeah. So this is a classical case. So importance is that our clinical diagnosis is definitely a GBS. So we confirm that very, very important is to do a nerve conduction test. NCS is one of the electrophysiological tests that is of profound importance as a very good neuromonitoring tool for neuromuscular disorders. So this is one of the tests that we can do in this classical. Not only NCS tells you about the demyelination or the axonal variants, it also helps you to prognosticate. Every one of us knows that the axonal variants and the MAN and MSAN variant have a bad prognosis. So in the initial part, if you do and you know whether it is axonal or it is demyelination, you can always prognosticate your patients. And one more important thing about NCS is that in the initial part, when you are receiving the patient in the weakness in 1 or 2 days, sometimes NCS might not be very, very sensitive. So always we should have a habit of repeating the NCS at 5th day or 6th day. And also if the weakness is persistent, you can always repeat it later on to really see how the graphs are holding. So in this patient, you have a diagnosis of demyelination. We start IVIG at 2 gram per kg, and over the period of 3 days, we see that the power is starting to improve, and on 5th to 6th day, we were able to extubate these patients. Another important area in which neuromonitoring helps is declaration of brain dead. I'm not going into details of it, in which EEG and a TCT do really help sometimes, because we get stuck up in many of these patients in which there will be some reflexes here and there, and many times attenders and many times the we would be confused about what is really happening. EEG is one of the very good tools in really diagnosing these patients, and also TCD. TCD, there will be typical patterns in ECG, in TCD, which is known as oscillating waveforms or small systolic spikes or total disappearance of the intracranial flow. So TCD is of very, very much important. So now, just to summarize, so neuromonitoring, advanced neuromonitoring has really evolved in critical care. So we only saw few aspects of it. So ICP and CPP monitoring to know the driving pressures. Then we also come to know the blood flows by using PCDs, and we can see for the local cerebral blood flows and the regional blood flow. The next level, what we can do is using a near infrared spectroscopy, or we can thread a jugular venous oxygenation to know how is the oxygen getting delivered. We can also see the metabolism part of the brain by using microdialysis catheter, the functional part by using EEG and electrophysiology. So this entire gamut of neuromonitoring can be done right now, and they can be combined together in what we know as multimodal monitoring. Now you can see in one of the bad patient who is very, very sick and he has a lot of edema, you can see how multimodal monitoring can be combined. You have a cortical EEG, you have a parenchymal ICP monitor placed, you have a microdialysis catheter placed, you have a brain tissue oxygen tension getting measured. So you can combine these all together to manage the optimal CPP of the patient, and the therapeutics can be directed accordingly. So to summarize, golden hour management is very, very important in neuro emergencies. So, and particularly in neurocritical care, you need to know that time is tissue. So you have to have a high suspicion of the disorders and try to work on that. Trust your clinical instincts, definitely, and add on to the monitors as and when required as quickly as possible. Teamwork is important. Involving the neurology team early in the diagnosis whenever you have a high suspicion is very, very important, and involving the critical care team for better monitoring of the patients definitely will help you. Also important is to early refer these patients to a better equipped center. Sometimes we get patients quite late in the cascade. When the cascade is already evolved, sometimes it's very difficult then to salvage and monitor the patient. The outcomes definitely is directly proportional to the early intervention in neurocritical care. So you have to refer this patient on time whenever you have a suspicion that these patients can deteriorate. Thank you.
If there are no questions, we'll break for the lunch, and we can always ask Dr. Harsh over the lunch. We'll get together again at 2:15. Till then, we'll have a nice lunch. Thank you, sir.
headache. So is it frequency or the duration? So according to the ICHD-3 criteria, it is both. So any headache which lasts for more than 15 days and that lasts more than 3 months is a chronic headache. However, there is an exception to this definition, that is in case of chronic trigeminal autonomic cephalalgias, where if the remission between the attacks is less than 3 months, that is considered to be a chronic headache. So let's begin with this a simple case scenario. So this is a 25-year-old female who started having headaches since age 15, and she had worsening frequency for the past 3 years. Currently she is having 16 to 18 headache days per month, which lasting for 8 to 12 hours. The pain is unilateral, throbbing, associated with photophobia, phonophobia, nausea and vomiting. There is no worsening with Valsalva, change in position, diurnal variation, no focal neurological deficits, and no disc edema. So the diagnosis is? Yeah. So how many would want to do neuroimaging in this case? You can raise your hands. So not many hands. So this is a systematic review which assesses the chances of finding a significant neuroimaging finding in patients with any form of headache. So we can see that the probability of finding a significant neuroimaging finding in any patient with headache is 8%. And if it is only acute headache, the probability increases, the chance is 14%. And they have done a subgroup analysis where they analyzed that CT is almost as good as MRI in diagnosing something abnormal in patients with headache. And the probability of finding significant increases when the age is more than 60 years. So what are the clinical things by which we can increase the yield of MRI findings? So the American Headache Society in 2019 has proposed this SNOOP 10 criteria, where they identified 15 clinical signs and symptoms through which we can identify the red flags in headache, which require neuroimaging. So of importance among these are the presence of focal neurological deficits, papillary edema, which are examination findings, and based on history, change in pattern, positional headache, headache with autonomic features, and medication overuse headaches. So these are some of the important red flags. Now if we go to the most common primary headaches, so chronic headaches, so these are the three, which are the chronic migraine, chronic tension type headache, and new daily persistent headaches. So as we can see, there is a huge overlap between all these three things. So the common between them among all three are that the headache should be present for more than 3 months and more than 15 days per month, and all of these headaches can be bilateral, all can have moderate intensity, and all of these can coexist with medication overuse headache. And we look at the definition of chronic migraine according to ICHD-3. So it requires only 8 days of typical migraine headache out of those 15 days per month. The rest of 7 days can be chronic tension type headache. So there is a clinical overlap. So as we move on from episodic headaches to chronic headaches, the typical feature of the headaches are lost and the diagnosis becomes challenging. So let's move back to the case. So these are all the highlighting feature of this headache where there are no red flags. So the diagnosis is chronic migraine. So according to ICHD-3, as I was saying, out of 15 headache days, only 8 need to be typical migraine. The rest can be of any other form of headache. So the migraine features also they have defined. There should be at least 2 of 4 features. So now coming to the management of migraine, it can be divided into 3 parts. One is the acute or the symptomatic treatment, then comes the preventive treatment, and the third and most under-recognized management is lifestyle management. So coming to the acute symptomatic treatment, so usually we all start with NSAID. There are many symptomatic treatments that can be used, but usually everyone starts with NSAID. And if a patient doesn't respond to NSAID in more than 3 consecutive attacks, then it is advised to stop treating the headaches with NSAID and move on to triptans. However, triptans are vasoconstrictors, so there are contraindications in refractory hypertension, cardiovascular as well as cerebrovascular diseases. So in these cases, we either choose a ditan, which is lasmiditan, or a Z-pant. Or if the headache doesn't respond to triptans, then also we consider these acute symptomatic treatments. Now coming to the preventive treatment, every patient with chronic migraine will require preventive therapy. However, in case of episode migraine, so what is the number of headache days in a month that requires preventive therapy. So the guidelines differ between American guidelines and European guidelines. According to European guidelines, it is 2 days in a month that requires preventive therapy. However, when it comes to the American Headache Society, it is more than 3 to 6 per month, depending on the disability. So there is a huge armamentarium of drugs which we can choose from depending on the comorbidity, tolerability, costs, and experience of our own experience. However, the newest block among these therapies is the CGRP targeted therapies, which target CGRP, calcitonin G related peptide, which is a neuropeptide and a vasodilator, which is a key molecule in the pathogenesis of migraine. So the advantage of these are they are not vasoconstrictors like triptans. So there are no contraindications in cardiovascular diseases or hypertensive patients, and they have better side effect profile. And compared to analgesics and triptans, there is no risk of medication overuse headache, and the ease of administration is also good. They require once a monthly or quarterly administration. So there are two types. One is GPANTs, which are approved for both acute symptomatic treatment as well as for prevention. And the second one is CGRP related monoclonal antibodies, which are approved only for prevention of episodic and chronic migraine. So what is the current indications of these drugs? So if we see the left side, this is a 2021 consensus statement from the American Headache Society, where they have indicated this use only when 2 of the conventional preventive therapies have failed. However, according to the latest position statement which was published in 2024, they can be used as a first-line drug for the management of both episodic migraine as well as chronic migraine. So now coming to lifestyle management in headache, which is often under-recognized. So this is a cross-sectional study which was published recently in patients with migraines about the patient's awareness. So we can see that the patient reported, only 63% of patients reported that their physician has advised lifestyle changes when managing migraines. Of the frequently discussed aspects, sleep hygiene, stress management, and diet modifications are the common things which were discussed by physician. However, when it comes to what patients are actually following, out of them only 30 to 50% are actually following these lifestyle changes. And when it comes to the migraine triggers, physicians discussed only in 50% of cases. Of them, only 43% of patients had sufficient knowledge of what are the migraine triggers, and only quarter of patients actually manage their triggers actively. So this indicates a very clear gap in effective communication between healthcare providers and patients while managing migraines. Next, coming to similar headache, which is a chronic tension headache, which often coexists with migraine. So the main difference between tension type headache and migraine is quality of headache. So compared to migraine, which is unilateral pulsating type of headache and moderate to severe headaches, tension type headache is a bilateral headache, non-pulsating, mild or moderate in intensity. And compared to the migraine, it is not aggravated by routine physical activity. And both migraine and tension type headache can have photophobia, phonophobia, or mild nausea. And the drug of choice for tension type headache is amitriptyline, and if it is not responding, we consider mirtazapine or venlafaxine. Now coming to case 2, this is a 41-year-old female who had no prior history of headaches and no prior comorbidities. She started having daily headaches for the past 3 months. She underwent a laparoscopic surgery around July, and 2 days later she started experiencing headaches while she was sitting on the floor and watching TV. The pain is bifrontal, occipital, retroorbital, and it has moderate and sometimes very severe intensity. So the diagnosis is, any possibilities? Any guess? So usually post-op surgery, most of us think about post-dural lumbar puncture headache. Okay. So the headaches were almost daily for the past 3 months, and she doesn't report any positional change, diurnal variations, or no worsening with Valsalva, no focal neurological deficits. See, examination was normal, including fundus, MRI, brain and spine were normal. Now any guess? So this is a new daily persistent headache. So Previously, it used to be called as chronic headache with acute onset. Patient remembers the exact date of onset of the headache, and since then the headache will be persistent. It can have both migraine features as well as tension type like features, and a trigger factor can be identified in about 50% of cases, most common being infection or stressor or a surgery. So currently, as of now, there are no guidelines on managing these headaches. This is a very headache with a very poor prognosis, and we have to identify what is the predominant phenotype. Is it the migraine or is it the tension type headache? Then we have to manage accordingly. And as we can see, the remission is very poor. That is up to 30% only of the patients only respond. Now, case 3, 43-year-old female having headaches since 12 years of age, past 13 years, the frequency has increased to 2 to 3 per week, and for the past 6 months, it has become daily. The pain is bifrontal, throbbing with associated phonophobia. The severity is moderate. So, diagnosis? No, new daily persistent headache will have acute onset. Patient remembers the exact date and time of the onset of headache. So this is a typical tension type headache. Okay. However, the patient was not taking any preventive therapy and keep on consuming these acute painkillers. She is taking paracetamol, naproxen, and also triptans many times a week. So this is a medication overuse headache. So if you see the definition, medication overuse headache often coexists with some underlying headache like a migraine headache or tension type headache. So, and as per definition, the patient should take at least 10 days per month for triptans, combination analgesics or opioids, and 15 days per month for NSAIDs and paracetamol. So if you see the SNOOP 10 criteria from the American Headache Society, so medication overuse headache is a red flag. So it requires neuroimaging to rule out any sinister cause as to why patient is taking more and more analgesics. So how do we treat this medication overuse headache? Should we withdraw the symptomatic treatment? Should we add the preventive therapy? How should we manage this? So this is a randomized control trial which addressed this issue. So in this trial, they have divided the patients into 3 groups. One is the first group. In the first group, they have withdrawn the medication, that is the analgesics, and added a preventive therapy. In the second group, they have added preventive therapy without withdrawing the offending analgesic. In the third group, they have added withdrawal. They have withdrawn the drug but did not add any preventive therapy. So what they found was there was no difference was found in reduction of headache days per month, migraine days per month, use of short-term medication, and headache intensity. So these 3 are equivocally efficacious. However, when it comes to the secondary outcomes, though in the withdrawal plus preventive group, significantly more number of patients had reverted to episodic headache and cured of medication overuse headache, indicating that complete withdrawal and simultaneous initiation of preventive therapy is the best strategy at present. So this is the table summarizing some of the preventive therapies and bridging therapies that can be used in medication overuse headache. Now case 4, he is a 42-year-old male who presented to OPD with persistent headache on the right side of his head for the past 4 years. He describes the headache as dull continuous ache with some episodes of exacerbation, which he describes as sharper and stabbing pain lasting for around 15 to 20 minutes. The pain was deep-seated and it always on the right side, and it is localized in the periorbital region and accompanied by some autonomic features. So initially the headache used to last for whole day and it used to last for 1 to 3 weeks in a row, but and after that he would have completely symptom-free for around couple of weeks. Gradually the pain became severe, and for the past 1 year the pain lasted for periods of about 20 to 25 days in a month with intervals free of pain of about 10 days. He was initially managed as allergic conjunctivitis with some eye drops. There was no focal neurological deficits, fundus was normal, and MRI brain was also normal. So diagnosis. Okay. This is not a cluster headache. So I have given him indomethacin 25 mg twice daily, and he had improvement within 2 days of onset of starting this indomethacin. Now the diagnosis. Okay. So So this is a unilateral headache which has some autonomic dysfunction. So which we call as primary side locking headaches, meaning the headache will be on the side of will always be on the one side. It doesn't change side like migraine. Sometimes with migraine we see that patient complains of headache on right side, and sometimes later he will have headache on the left side. But these are primary side locking headaches, also known as the trigeminal autonomic cephalalgias. So depending on the duration of each episode, we can differentiate further into cluster headaches, paroxysmal hemicrania, sunk, and hemicrania continua. So of them, hemicrania continua will have continuous headache. On top of it, patients will have exacerbations. And among these, the two syndromes that respond to indomethacin are paroxysmal hemicrania and hemicrania continua. So if we see hemicrania continua, the patient will have headache which is persistent for more than 3 months, which is continuous, and on top of it, he will have exacerbations of at least moderate intensity. So one thing that is important is hemicrania continua is often misdiagnosed as chronic migraine, because if you see the definition, diagnostic criteria of ICSD-3, it contains patients need not have autonomic features to diagnose hemicrania continua. He should have either or both of at least one autonomic symptom or sense of restlessness. So the differentiating factor between chronic migraine and hemicrania continua is the restlessness. Typically, patient with migraine will switch off their light, plug their ears, and sleep in a silent room. However, when it comes to hemicrania continua, patient is usually will be restless and he cannot lie down when he have a headache. So usually he will run or walk in the room or corridor whenever he gets this headache. So that is the differentiating factor. And this is the headache which absolutely responds to indomethacin. So any headache with autonomic features requires neuroimaging as per the American Headache Society. This is a red flag in SNOOP 10. So we usually should perform neuroimaging to rule out any posterior fossa tumors or aneurysms. So what is the indomethacin dose that should be used? So usually we should start with 25 mg thrice daily, and if there is no response in 2 to 3 days, we should escalate it to 50 mg thrice daily. So the mean dose which is advised at which the symptoms should disappear is 150 to 200 mg per day. If the patient is not responding with this dose, we have to reevaluate our diagnosis. So these are some other indomethacin responsive headaches where indomethacin is effective. Now moving on to case 6, 35-year-old female presented with headache for the past 3 months. Headache was sudden in onset 30 minutes after waking up when she started sweeping her room. And the headache is in occipital region associated with neck pain and nausea. Headache is positional, which increases on sitting and standing and relieves immediately on lying down. And prior to onset of these symptoms, for 2 weeks she had history of fever and sore throat followed by bouts of cough. On examination, there was no focal neurological deficit. So the diagnosis? Intracranial? Yeah, this is intracranial hypotension. So the red flags here are the sudden onset of headache, positional headache, and a precipitating factor of cough for 2 weeks prior to the onset of these headaches. So any red flags, we have to do neuroimaging. So here is the neuroimaging of the patient where we can see the subdural collections and thickening of the durometer, and also there is increase in anterior posterior diameter of the midbrain and pons. So these are all features suggestive of spontaneous intracranial hypotension. So any headache because of low CSF pressure and presence of evidence of CSF leaking on imaging is considered to be associated with low CSF pressure headache. It can be spontaneous or it can be post-surgery or post-lumbar puncture. So the most common symptoms are orthostatic headache, which is usually seen in around 90% of headache, 90% of cases. So 10% of cases can be non-orthostatic. That is important. And how do we treat? So this is again a systematic review where they have seen, and with conservative treatment, that is bed rest, hydration, analgesia and caffeine, only 25% of patients the treatment will be effective. So in the rest of 75% of the patients, most likely they require a epidural blood patch. And again, they have done a subgroup analysis where they have seen what is the success rate of non-targeted versus targeted epidural blood patch. According to this systematic review, the chances of the effectiveness of both are equal. And as compared to a small epidural blood patch, at least 20 ml of blood should be injected to achieve a good success rate. So, final case. So, 32-year-old female presented to OPD with history of headache since she was 18 years old. Initial frequency is 1 to 2 per month, and she used to take analgesics. For the past 2 years, the frequency has increased 4 to 5 per month, precipitated by sleep deprivation, travel, and menstruation. The headache is hemicranial most of the time, throbbing, moderate to severe intensity, lasts for 4 to 6 hours, and sometimes up to few days. Associated with nausea, photophobia, and phonophobia. There was no change in position, no focal neurological deficits, no disc edema. Diagnosis? This is episodic migraine. This is not chronic migraine because the frequency is only 4 to 5 per month. To label it as chronic migraine, you need to have at least more than 15 headache days in a month. So this is a episodic migraine. She was given propranolol and advised lifestyle management with which she improved. But 1 year later, she was diagnosed as hypothyroidism when she was evaluated for weight gain and cold intolerance. And since then, she started having recurrence of headaches with similar character. The frequency is 3 to 4 per month. However, this time when she was given propranolol followed by fluonoragine, there was no improvement. So the next few weeks, the headaches became more severe, affecting her sleep. She used to wake up most of the times with headache in the early morning and feels better as the day progresses. She also describes episodes of transient blurring of vision when she gets up from sitting or supine position, and there are episodes of buzzing sounds in the ear. There was no double vision or decreased vision. So diagnosis? Yeah. So IAH is a diagnosis of exclusion. This is a raised ICT symptom. So this is the fundus of the patient showing blurred disc margins, suggestive of papillary edema, and the visual acuity is normal in both eyes. And this is the visual field of the patient showing enlargement of the blind spot. So if we take this history, there are multiple red flags, like patient had early morning headaches, there is a change in pattern of headache, positional headaches, papillary edema, history of tinnitus and TVOs. These are all features suggestive of raised ICT. So again, this requires a neuroimaging to rule out any cause of raised ICT. So this is the MRI of the patient showing where we can see there is a tortuous optic sheath, indentation of the posterior part of sclera, there is an empty cella, and the MR venography showing left transverse sinus is hypoplastic with a smooth tapering end, also on the right side, suggestive of transverse sinus stenosis. So this is IIH. So again, IIH is a diagnosis of exclusion. In IIH, the most common complaint is headache, and the headache can be migrainous or tension type headache. Migrainous headaches usually will be seen in around 50% of cases, and patients usually can have a prior history of migraine before they develop this IIH. So again, the diagnosis requires papillary edema with a elevated raised CSF pressure in the presence of normal neurological examination, normal neuroimaging, and normal CSF. So how do we treat IIH? The most important one is the weight management. So usually it affects obese women. So at least 6 to 10% of weight loss is recommended. Then the management depends on if the vision is impaired or not. If there is no immediate threat to vision, we usually start the patient on acetazolamide. Or if the patient has threatened vision, which we call as fulminant IIH, we manage the patient with a CSF diversion procedure like a LP, VP shunt, or optic nerve sheath fenestration. So a brief note. So this is in the advances of management of IIH. So the GLP-1 agonists, which are being commonly used in endocrinology and cardiology. So they have also shown benefit in IIH in randomized controlled trials as well as some cohort studies, and the benefit is independent of the weight loss. So in these studies, it has been shown that GLP-1 agonists, there was improvement in both intracranial pressure, headache, as well as visual acuity. So with this, I conclude my talk. So first of all, whenever a patient will have chronic headache, we have to rule out secondary causes. The SNOOP 10 criteria the red flags help us in differentiating between primary and secondary headaches. And once we rule out secondary headaches, we have to identify what is the phenotype of the primary headache, because the treatment strategies and the prognosis differ between each primary headache. And most of the time, medication overuse headache coexist with all the primary headaches. And trial of indomethacin should be considered in patients after ruling out intracranial lesions in patients who have headaches, chronic headache with autonomic features. And optimal management combines both lifestyle modification as well as pharmacological therapy. Thank you.
Any questions? What about interventions? When do you suggest?
Sir, actually, there is a recent consensus published in the parental emergency management of primary headaches. So, in that, the level A evidence is given for greater occipital nerve block, and grade B evidence is given for supraorbital nerve blocks, and they can be used most of the time as a bridge therapies. And also, botulinum toxin is has grade A evidence in the management of chronic migraine.
And there are such a simple blocks, each one of us can learn it. And
yes, sir. They are.
And also in that they have suggested using Stemetil injection.
Yeah, that is a grade A evidence, which we usually use ketorolac. That has grade B evidence.
Yeah, true. Okay, then we'll go for the next topic. One more very common topic of the low backache, and we had requested Dr. Shweta to talk us when should we refer cases to a neurosurgeon as a priority basis.
Good afternoon, everyone. I'm Dr. Shweta, consultant neurosurgeon working here. So today's my topic is approach to low back pain. This is the most common symptom all of us will see in OPD, day-to-day basis, low back pain. So I just want to insist on some of the causes of surgical causes and when it should be referred to a surgeon and what all things we have to look at when we are dealing with back pain. So after a careful history and evaluation, we have to have a panoramic view and looking at the back pain, because it may seem something very simple, but there may be underlying causes which are causing that. So you have to understand the cause of the pain before jumping for any treatment. So the back pain can be from a different origin. That can be a spinal origin or other than spine. As neurosurgeon or neurologist, we try to look at the spinal origin, but we have to rule out other causes like neurogenic, viscerogenic, vasculogenic, and psychogenic causes. So generally, the viscera which will cause a referred pain or mimicking spine pain are like renal colic or pyelonephritis or perinephric abscess, and gastrointestinal causes like cholecystitis, pancreatitis. And in females, generally PIDs and recurrent UTIs can also present with low back pain. They may have a disc prolapse on the spine MRI as a incidental finding. So one should be able to differentiate what is the cause of the pain and treat for it. And sometimes aortic aneurysms and retroperitoneal hematomas can also present as low back pain. So depending on the age of the patient, the most common causes, most likely the surgical causes per se, I can say. In infancy to adolescence, spinal dystrophisms, infections, deformities, and inflammatory followed by tumors. In the middle age group, generally degenerative causes like disc prolapse and listhesis, followed by tumors, trauma, and inflammatory. In the elderly people, metastasis, osteoporosis, trauma, and degenerative are the causes. If I go one by one depending on the age, when it should be referred to a surgeon. In children, starting from infancy to adolescence, the spinal dysraphism is the most common thing, which is missed actually by parents, because they may present asymptomatically and without any signs also. They may just have a simple hyperpigmented patch, which is generally missed. Or they may have a simple fatty deposition over low back, and they are never investigated for that unless they develop some symptoms. So when adolescent people present with a back pain radiating to leg pain, you should have a less threshold for asking imaging and to look for tethered cord symptoms. Adolescents with repeated UTIs, generally you should evaluate for a tethered cord, especially at the growth spurt age. When you look at the origin of symptoms, according to the age groups, generally less than 6 years of age people most of them are asymptomatic. But after 6 years, most of them will become symptomatic. So offering treatment when they are asymptomatic and identifying the symptoms is very important for the prognosis. When you look at the outcomes, when surgery is done at younger age, when they are asymptomatic, they have a good outcome compared to adults who are symptomatic. And timing of spinal dysraphism surgery should be always as soon as it is detected, especially like at least first 6 months. If it is not emergency, we can wait, but 6 to 12 months or at least from 6 months to 2 years, it should be addressed even they are asymptomatic. If proper spinal dysraphism is there, then we can offer a good outcome to the child. And generally, spinal dysraphisms are associated with spinal deformities. If we leave them untreated, this scoliosis can grow as with the age, and it may cause symptoms in future. Scoliosis may not be always associated with dysraphisms, but there can be idiopathic scoliosis also. In those cases also, we have to carefully observe the patient with repeated intervals, and we should be able to measure the curvature of the spines at regular intervals, and they should maintain a diary for their corpse angle measurement. And if the curvature is progressing, then it should be addressed. If it is not getting corrected with bracing and special physical therapy, surgery should always be given as an option to prevent abnormal curvature of the spine and to provide some cosmetic correction and to prevent neurological deterioration. Generally, in children with abnormal curvatures, they may have a restrictive lung disease with thoracic abnormalities and ribcage abnormalities. In those cases, offering scoliosis correction always helps to improve the lung function. In some cases, simple hemivertebra at one level can cause the scoliosis, and correction of that hemivertebra will actually address the problem. And sometimes there can be rare syndromes like congenital conditions where lumbosacral transitional vertebra are there. In those cases, the transverse process of lower lumbar vertebra will fuse with the sacrum, and that will cause the pain. The removal of that transverse process excess growth or the fusion of the segment may relieve the pain. Sometimes we may have a kissing spine in where any two lumbar vertebra transverse process grow excessively and they will touch on the lateral side. So that will cause pain. The removal of the excess transverse process will relieve the pain. Sometimes, rarely, a lumbar rib can be present from L1 vertebra. In this situation, the patient will have a typical renal angle pain bilaterally, and this is mimicking as a renal colic. And the excision of lumbar rib will give a significant relief. Coming to the second most common cause in adolescents, that is infections. Commonly we see COX. We may see from just reduction of disc space to the destruction of body to the deformity. So when should we offer surgery for that? Whenever there is a spinal instability with spine at risk signs, which I will tell you now, and kyphosis with a corpse angle of more than 30 degrees, or there is rapid deterioration in neurological signs, or in case of cervical COX where airway compromise is there, swallowing difficulties are there, or there is paraplegia and abscess around the spine, or when there is a severe pain without responding to AKT, then the surgery should be offered. there is a score to evaluate the spinal instability and to offer surgery. So age less than 15 years and junctional tuberculosis like cervicothoracic or thoracolumbar, a deformity more than 30 degrees, and a vertebral body height loss and spine at risk signs. If the score is 1, then it is considerably stable. If it is 2, it is partially unstable. And if it is 3 or more than that, it requires surgical stabilization. What are the spine at risk signs? There are 4 grades. In that first one, there is facet joint instability, separation. The second one is posterior retropulsion. Third one is lateral translation. And fourth is toppling signs. If you find any of these signs, then that means spine is becoming unstable and a correction should be offered. Another next common cause in the middle age group, what we see is disc prolapse. So when to offer surgery for disc prolapse? Do all disc prolapse need surgery? So that means like normal disc bulges without neural compromise or some minimal pain can be managed conservatively. But when we offer surgery in disc prolapse, like pain not responding to medication, when there is neurological deficit and bladder bowel involvement. But generally, foraminal discs, in where even the small disc also will cause a severe pain, and generally it is not responsive to the medications. So one should be offering surgery early to the foraminal disc patients compared to the central disc patients. And next is the pars fractures and listhesis. The patients come with severe back pain. Generally nowadays all the patients come with MRI already done outside. So MRI shows normal in pars fracture cases, unless if we ask for an X-ray and see for that. So we miss the pars fracture generally, commonly it is done. So always have a X-ray, that too a dynamic imaging where you can identify the listhesis properly. Because neutral lateral X-ray may not, every time may show listhesis, so dynamic imaging is also necessary. And the next most common cause is in elderly patients, the metastasis. In females, commonly breast carcinoma, and in males, prostate and lung carcinoma and multiple myeloma. These causes should be identified because in elderly patients, generally disc prolapse, canal stenosis, everything will be there when you look at the spine. But one should not go by those things. We should always look at the vertebral body intensities also and try to find out the history to look for any metastasis. So whenever there is spinal metastasis, first we look at whether there is any neurological compromise or not. If there is neurological compromise, then we look at instability. If there is instability, you always go for surgery, decompression and stabilization. And if there is no instability, then decompression alone. How much stabilization and decompression is necessary, that depends on the prognosis of the patient. And then when there is no neurological compromise, you look at the instability again. If there is instability, stabilization is offered. If there is no instability, then medical management. So how do you decide on what type of surgery, how much surgery to be offered for the patient? That depends on the prognosis of the patient, which can be scored with 3 factors. We look at the primary tumor growth, if it is slow growing, moderately growing or rapid growth, and if there are any visceral mets or bone mets. Depending on that, we'll decide the prognosis of the patient and we decide the treatment goal and surgical strategy. If you are looking at a good prognostic patient for a long-term local control, then we offer wide and marginal resection with a stabilization. If you are looking at middle-term control, then some marginal and intralesional excision. And if you are looking at a short-term goals, then palliative surgery, and in terminal patients, only supportive care. And some other most common causes of back pain in elderly are osteoporosis, especially in the females. They present with axial pain most of the times without radiculopathy and continuous pains. So whenever they are facing the medically refractory pains, we can offer vertebroplasty and kyphoplasty procedures to increase the vertebral height. But in some cases like active infections, severe bleeding disorders and allergy to bone cement, we can't offer these treatments. But whenever the posterior cortex is intact only, we can do this vertebroplasty or kyphoplasty. When posterior cortex is not intact, then we can't do that. In those cases, we can offer some definitive fixation procedures, But in osteoporosis patients, the regular screws won't hold. So we use a special screws, fenestrated screws, where the screws will have holes and we can inject bone cement into the screws so that it is held properly in the vertebra. So before offering any treatment, it is very important to identify the cause of pain and pain generators. So any structure which can cause pain will have either a physiological innervation or a pathological innervation. So you should identify always the pain generators and the type of pain and then go for a treatment. In disc related pains, generally grade 3 and grade 4 tears will have a more pain. So if you look at the disc related pains, in internal disc disruptions, pain generator is inside the disc due to intradiscal pressure changes, and the nature of pain is on the sitting. When there is obvious disc prolapse, the nerve roots are getting compressed due to disc, and the pain will be increased on standing or walking and relieved on sitting and lying down. When there is severe canal stenosis due to ischemia of nerves, they will have neurological claudication. And most commonly, most of the elderly patients will have disc bulges, but the pain generator will be different. Whenever the pain is because of facet joint, the pain will be predominantly in the back, non-dermatomal leg pain, and pain relieved on sitting and bending forwards and walking. Pain increased on extension, lateral bending and rotation. There won't be any neurological deficit. If it is because of SI joint, there will be localized tenderness and low back pain. It increased on sitting and relieved on walking. Then muscle as pain generator, they will have a repeated stress injury history, trauma or prolonged muscle spasm or any paraspinal tumors can cause this kind of pain. And piriformis syndrome also can present as a low back pain. Now, vertebral body as pain generators, trauma, malignancy, mets and osteoporosis, they can present as a pain. In the hip joint, this is very important to rule out hip joint because AVNs most commonly, they will also present as a low back pain. But patient will have a restriction of movement or limping gait and tenderness over the femoral head. So it is always important to examine hip joint before offering any spine surgery. So ligaments as pain generators, generally any chronic inflammatory conditions like ankylosing spondylitis, Paget's disease, rheumatoid arthritis, all these things can have back pain where the pain generator is ligaments. Thank you so much.
Any questions? Okay. No, thank you, madam. After this, a very interesting session on optimal management of Parkinson's disease and newer management strategies. The first one will be medical management of Parkinson's disease by Dr. Jayashree.
Good afternoon, everyone. I am Dr. Jayashree. First of all, I thank Dr. Kaul sir and Dr. Praveen sir for giving me this opportunity. My talk is on optimal medical management of Parkinson's disease. So Parkinson's disease is the second most common neurodegenerative disorder in the world, and it is incidence is around 1 to 2 people per 1,000 people. And according to the global disease burden study, it is projected to affect around 25 million people by 2050. So the hallmark features of Parkinson's disease include tremor, rigidity, bradykinesia, and postural instability. So for optimal management of Parkinson's disease, proper diagnosis is very important. So Parkinson's disease is mostly diagnosed clinically. So initial diagnostic criteria were given in 1988 by Gibbs and Lees, that is UK Parkinson's disease brain bank criteria. In this, they suggested essential criteria, that is bradykinesia, along with at least one of following, that is muscle rigidity, rest tremor and postural instability, and also suggested exclusion criteria and supportive criteria. In 2015, the Movement Disorder Society has revised these diagnostic criteria, as the previous criteria have not included non-motor features, which are very important part of the Parkinson's disease. According to the new revised diagnostic criteria, they suggested mandatory criteria, that is bradykinesia plus at least one of rest tremor and rigidity, along with supportive criteria, that is clear dramatic response to dopaminergic therapy, rest tremor of one limb, levodopa-induced dyskinesia, and presence of olfactory loss or cardiac sympathetic denervation on MIPG scintigraphy. So according to the new criteria, diagnosis of established PD requires absence of absolute exclusion criteria, at least 2 supportive criteria, and no red flags. So here we can see this is an elderly 70-year-old male presenting with rest tremor of right upper limb. Along with hypomimia, we can see that it is affecting only one side of the body. This is a stage 1 of Parkinson's disease. Here we can see that there is a rest tremor in a 50-year-old male patient affecting right upper limb. This is considered as an early Parkinson's disease affecting one side of the body. And not only rest tremor, patients can also have postural tremor. Here we can see there is a postural tremor involving right upper limb. This is called a re-emergent tremor in patients with Parkinson's disease. Here we can see an elderly woman with the tremor, rest tremor affecting both upper limbs. She is in a stage 2 of Parkinson's disease. In stage 2 of Parkinson's disease, the symptoms affect both sides of the body without any impairment of balance. Here we can see the tremor is affecting both upper limbs. This is a patient with Parkinson's disease. Here we can see with finger tap test, there is a severe bradykinesia and also hypomimia, and also we can see there is a jaw tremor. And this patient has akinetic rigid type of Parkinson's disease, where both upper limbs there is severe rigidity and bradykinesia, along with requiring support to get up and walk. The patient is in the 3rd stage of Parkinson's disease, that is HN by stage 3. And here we can see an elderly male with a severe tremor involving both upper limbs and lower limbs, and also is requiring 2-person support to get up and walk. So patient is in advanced Parkinson's disease, that is stage 4 of Parkinson's disease. Patient has severe freezing of gait, severe axial rigidity. Here we can see this female old lady with a severe tremor, rigidity, hypomimia, severe bradykinesia, and patient is confined to bed. So this is a stage 5 of Parkinson's disease. This is in off, patient is not able to be mobile. And this is in on, after syndopa, patient has severe levodopa-induced dyskinesia. So patient is in stage 5 of Parkinson's disease. So apart from these motor manifestations, patients can present with early symptoms of Parkinson's disease many years before the onset of tremor, rigidity and bradykinesia. So the early motor features include frozen shoulder, difficulty turning in bed, limb pain, stiffness, micrographia, difficulty with finger movements, facial expression, decreased arm swing and soft voice. Many patients will be seeing in OPD where they can come with frozen shoulder and pain of one limb. They can be in early stage of Parkinson's disease. And early non-motor features include constipation, REM behavior disorder, can be seen in 50% preceding the diagnosis by 14 years. Depression, hyposmia. Hyposmia is the most consistent non-motor feature in Parkinson's. So, before starting medication, the important considerations to be taken into account are the patient's symptoms, signs, age of the patient, stage of the disease, their degree of functional disability, and the patient's level of physical activity and productivity. These are very important to take into consideration. And the spectrum of therapies available include levodopa, dopamine agonists, ropinirole, pramipexole, rotigotine, MAO-B inhibitors, selagelin, rasagelin, safinamide, amantadine, and anticholinergics. So the main concern is when do we start therapy for patients with Parkinson's disease. So the therapy should be started whenever the patient is disabled and the disease is interfering with the activities of daily living, and the disease has affected dominant hand, and in the presence of significant bradykinesia, gait disturbance, patient values and preferences. This is very important in determining the initial drug therapy for patients with early Parkinson's. And also the fear of starting levodopa due to association with motor fluctuations and dyskinesias. So here, this is a 46-year-old male. He is a software executive working in Singapore. So he presented with history of tremor of right upper limb and slowness of gait since 2021, since 4 years. And in day-to-day activities, because he is an executive, he had difficulty in using the mouse and he had difficulty in typing on laptop. And on examination, there was very mild rest tremor. Here we can see there is a very mild tremor of right upper limb, and there was a mild rigidity and mild bradykinesia. Off score was 30 and on score was 3. But as the patient required good mobility and use of his right upper limb and should not impair his activities, patient was advised levodopa carbidopa 125 mg. Initially patient was using twice daily and patient was tremor free and was able to work. And recently we got a call from the patient that in between his symptoms are again recurring, so we had to increase to thrice daily. So levodopa is the most effective drug available for control of motor symptoms, and it is the drug which requires most frequent dosing, and it has the highest risk of motor complications such as wearing off phenomenon and dyskinesias. So always patients should be counseled before starting levodopa about the side effects and long-term consequences and long-term risk of dyskinesias, and preferably should be taken on empty stomach. So here, this is a 62-year-old male. He presented with complaints of tremor in the right upper limb since 4 years and tremor right lower limb since 2 years. The tremor was at rest, and also patient had a postural tremor. Here we can see patient had a postural tremor of right upper limb along with a tremor of the right lower limb, and the tremor was interfering with daily activities. He was a business person and he was having difficulty to sign the checks, and he also had difficulty in eating food with the right hand and drinking water. And the tremor was aggravated on stress and anxiety. There was a strong family history of tremor in grandmother, 4 aunts, and there was also history of Parkinson's disease in uncle. So the patient was being treated in their local place with Pacitane 2 mg TID and Ropag 0.5 mg once daily. And these medications were not at all helping the patient. Patient was not able to use the hand, not able to sign, and had difficulty with daily activities. And on examination, there is a rest tremor of right upper limb and lower limb and postural tremor of both upper limbs. But it is more on the right side, but both upper limbs there was a postural tremor. And patient had rigidity, bradykinesia, right more than left upper limb. And off score was 37, on score was 15. So after levodopa, patient had a very good response, good on. So here the diagnosis is PD along with essential tremor, ET. So not always patients need to be having a single diagnosis. They can have a combination of Parkinson's with essential tremor, and that we need to carefully identify. And the patient had a remarkable response to levodopa and carbidopa after starting levodopa along with propranolol 20 mg and trihexyphenidyl as well as primidone. And patient was tremor free and was able to sign and eat and drink without any difficulty. So the available formulation of carbidopa and different dosages are available, which they can be used based on the requirement, and controlled release formulation is also available. So initially you have to start with a low dose, half tablet 3 times a day. Initially better to start with meals, as it can cause nausea and intolerance, and eventually patient may not like to use the medicine. So initially it can be taken with meals, and later after establishing tolerability it can be increased and can be better to give it later on before meals. So the common side effects are nausea, somnolence, dizziness, headache, confusion, delusions, hallucinations, agitation, psychosis, sometimes orthostatic hypotension. So levodopa is known to achieve good response initially, but later on after 4 to 5 years, usually there is a waning of response, and there is a decrease in the benefit from each dose, and they can then after few years when the patient has progressed to advanced, then we need to adjust the dosing and have to increase the frequency. So there are a lot of concerns regarding levodopa causing motor fluctuations, dyskinesias and long-term effects, which prevent most of the physicians to start levodopa early. So there were few trials which were conducted, that is L-DOPA trial. Here they studied the long-term effects of levodopa on the progression of the disease. So the trial showed that there were no significant effects of levodopa on the progression of Parkinson's disease, but the neuroimaging data suggested that the levodopa accelerated the loss of dopamine nigrostriatal dopamine terminals. And there was one more study, that is a LEAP trial, which studied the risk of motor complications and dyskinesias after 80 weeks in patients, and they compared early and delayed start of levodopa. Finally, they concluded that there was no difference between early and delayed start of levodopa in regard to development of motor fluctuations and dyskinesias. So there is no need to worry about the long-term effects, because they are due to disease related and not due to drug related. This is another patient. He is a 53-year-old male, and he is a security guard. He working as a security guard at bank, and he presented with the tremor of right upper limb since 2021. Patient has the tremor is not affecting the daily activities, and patient is able to carry out all his daily activities. So on examination, there was a mild tremor, rigidity and bradykinesia of right upper limb. So patient was very much worried about the long-term side effects and was not willing to take levodopa. So he was started on pramipexole twice daily until the last visit when he was getting interference with the tremor, and he was started on levodopa 125 tablet half daily. So this is the algorithm suggested by American Academy of Neurology for patients with Parkinson's disease, that is early Parkinson's disease. So preferably when the patient is young, less than 60 years, so and it's a tremor dominant, better to start with anticholinergic or a dopamine agonist. And if there is a response, we have to continue with the same drug. Otherwise, if there is no response, we can either add levodopa or you can add a beta blocker to dopa agonist. So the dopamine agonists available include pramipexole, ropinirole and roticotin. They can be used as, they are effective as monotherapy in early disease, And monotherapy has a less risk of development of future dyskinesias or motor fluctuations. Usually they are suitable for patients less than 60 years with high risk of dyskinesias. So these dopa agonists, they have to be avoided in patients with history of impulse control disorders and those with cognitive impairment, excessive sleepiness, hallucinations. And also should be avoided in drivers and those handling heavy machinery due to the risk of sleep attacks. And the common adverse effects of dopamine agonists include nausea, vomiting, sleepiness, orthostatic hypotension, confusion, hallucinations, peripheral edema, and impulse control disorders such as gambling, compulsive buying, and compulsive sexual behaviors. So there is one entity called dopamine agonist withdrawal syndrome, and the dopamine agonist should never be stopped abruptly, which can result in dopamine agonist withdrawal syndrome, which is characterized by anxiety, panic attacks, depression, sweating, nausea, pain, fatigue, dizziness, and drug craving. They usually respond to resuming of dopamine agonists. So the next class of drugs include MAO-B inhibitors, and these are also can be used in early Parkinson's disease requiring once daily medication, and those who need only modest benefit can be started on these drugs. They are well tolerated, but they have low potency. Amantadine is an NMDA receptor antagonist, and it acts by increasing dopamine release, inhibiting reuptake, stimulating central dopamine receptors, and it is also can be used as an alternative to levodopa in young patients who are at risk of dyskinesia, and it is useful for managing levodopa-induced dyskinesia and decreasing off time in advanced Parkinson's disease. So recently in October 2025, a study was published, and in this study they have studied the effect of amantadine on the risk of dyskinesias in early Parkinson's disease, and they concluded that adjunctive amantadine in early Parkinson's disease decreased the risk of dyskinesias by up to 50%. So it is recommended to add amantadine for all patients with who are started on levodopa in early Parkinson's. And anticholinergics, they can be used as monotherapy in younger patients with significant tremor, and they can be used as adjunctive therapy for refractory tremor or dystonia, and they have to be avoided in older adults and also those with cognitive decline. So adverse effects include memory issues, confusion, hallucinations, dry mouth, blurred vision, urinary retention, sweating, and impaired sweating and tachycardia. And caution need to be used when using trihexyphenidyl in patients with prostatic hypertrophy and closed angle glaucoma. Recently, there was a study which was published which showed that the anticholinergics can cause significant cognitive and gait burden in patients with Parkinson's disease. So they are suggesting better to avoid using anticholinergics in patients with advanced Parkinson's disease with severe cognitive impairment and freezing of gait, or you have to use it in a very low dose in these patients. So coming to advanced Parkinson's disease, so patients who are in H&Y stage 4 and 5 are considered to be in advanced Parkinson's disease. This advanced PD is characterized by motor fluctuations, varying of, unpredictable of, failure of on response, freezing of gait, acute akinetic periods, and dyskinesias. That is, there are different types of dyskinesias: peak dose dyskinesia, diphasic dyskinesia, and early morning dystonia, varying of dystonia. This is a 60-year-old female who is diagnosed to have tremor-dominant Parkinson's disease since 2016. So patient had rest tremor, rigidity, and bradykinesia involving both upper limbs, but more on the left side more than right. And patient was being treated at Vijayawada since the last 8 years, and she was on levodopa and carbidopa combination 1.5 tablet for 4 times a day. So all these years patient was doing good, but recently patient developed a wearing off of the response, and patient came here that her levodopa is not working at all. So we did a UPDRS assessment. Off score was 75 and on score was 23. So patient was given during UPDRS assessment. We usually give double dose of levodopa, that is 250 mg we give to check the response. So just a simple half dose of increment has resulted in a remarkable response, and the patient attenders were surprised. What is this? With just half dose there is such a great response. So always we have to try to adjust the medication properly, and also doing an on-off assessment, that is UPDRS assessment in such patients can help a lot. So patient was started on levodopa 275 mg 4 times daily along with entacapone, pramipexole and safinamide. So dyskinesias, these are very common complications seen in patients with advanced Parkinson's disease. After 4 to 5 years of disease, patients eventually develop dyskinesias. These are overexpression of movement, and they are due to dopamine receptor hypersensitivity and also excess of dopamine levels. So any agent, not only levodopa, any agent that can stimulate or enhance dopamine at the receptor can induce dyskinesias, and these dyskinesias are more common in young onset Parkinson's disease. Here we can see in a female patient with severe dyskinesias in on-state. Peak dose dyskinesias are those dyskinesias which we see after 30 minutes of a dose, and during the peak there is a severe dyskinesia and they decrease by 90 minutes. These are dose dependent and they are predictable. The younger patients are more prone, and we have to manage by decreasing the dose of levodopa and shortening the intervals in between, and also we can switch to controlled release formulation and can add a long acting dopamine agonist, and as I said previously, amantadine can reduce the dyskinesias by 50%. This is a young onset Parkinson's female with severe dyskinesias in on state. We can see that. So this is a 72-year-old male. He presented with history of slowness and stiffness of left upper limb since 6 years, and tremors in right upper limb since 4 years, and slowness of gait since 1 year. So recently the on time has decreased to only 2 hours. Here we can see there is a severe tremor of the right upper limb and also stiffness of the left upper limb. So patient also had severe dyskinesias in on. Here we can see that there are severe dyskinesias of both upper limbs, lower limbs and also the face. And patient had severe freezing in off. So on UPDRS assessment, off score was 62 and on score was 18. So patient was counseled for, after medication adjustment, patient was counseled for deep brain stimulation, as after advanced Parkinson's disease, patients need to be referred to a definitive management. So with DBS, after DBS, patients on time increased from 30 minutes to 4 hours, and there were no dyskinesias, tremor decreased significantly and freezing decreased significantly. And we were able to taper the levodopa dose, and now we are only giving half tablet 4 times along with amantadine and levodopa here. So this is after DBS. Patient's tremor is totally disappeared, and also there are no dyskinesias in on. So in advanced Parkinson's disease, it is essential to differentiate between tremor and dyskinesia. Sometimes patients get confused with confused dyskinesia with the tremor and keep on taking the levodopa to get relief from dyskinesia, which is other way around. So we have to inquire the patient whether the patient is taking levodopa according to the schedule, and also have to review home videos, and proper on-off assessment is important. Symptom diaries are important, and careful patient education is important. And wearing off phenomenon is seen in advanced Parkinson's disease, and it can be managed by dietary adjustments, and we can space it with the meal time. That is, protein-rich meal should be avoided in the mornings, and better to advise patient to take protein-rich meal in the evening. And levodopa need to be taken 30 to 60 minutes before, or 60 to 90 minutes after the meal. This is a 52-year-old male presented with severe tremor of right upper limb and lower limb, since 2017. And since 2 years, the patient developed left upper and lower limb tremor and severe freezing of gait in off and dyskinesias in on. And also patient developed a delayed on. This patient has a peculiar varying of phenomenon where his on time was only 1 to 1.5 hours at home, whereas on time at hospital was much better. It is up to 4 hours. This was because of stressors at home, and there were a lot of arguments and fights in the family because of his disability, and the frustrated by patient attendants were getting frustrated. So this patient, on examination, there is a tremor of right upper limb more than left and rigidity and bradykinesia. There is axial and rigidity and freezing of gait. Patient requiring support of one person to walk, and on assessment off score was 103 and on score was 19. And patient was receiving very high doses of medication, that is levodopa 275 5 times, entacapone 200 5 times, levodopa CR 125 twice, amantadine twice, pramipexole ER 1.5 twice daily, and safinamide. So patient was in a very advanced stage of Parkinson's disease, and patient was counseled for DBS versus MR guided focused ultrasound. Patient opted for MRGFUS as they were not willing for a surgical procedure. So after MRGFUS, we can see there is total resolution of tremor. So patient was treated for right upper limb tremor with left limb ablation and PTT ablation. But here we can see that tremor of right upper limb has totally disappeared, and also we can see that the left upper limb tremor is also decreased in severity, because he was very anxious and the anxiety was triggering his tremor. So that helped him decrease in the severity of tremor in the left side. So the adjunctive therapies in advanced Parkinson's disease, we can combine and use dopa agonists, COMT inhibitors, MAO-B inhibitors, and this is a PD-MED trial where they have tested the long-term effectiveness of adjuvant treatment with COMT inhibitors, MAO-B inhibitors, and compared with the dopamine agonists among patients with advanced Parkinson's disease. So according to this trial, it was shown that the PDQ scores, that is quality of life, was better in patients receiving dopamine agonists compared to MAO-B inhibitors, and least in patients with COMT inhibitors. So in advanced Parkinson's disease, it is recommended to give dopa agonist in all patients as adjuvant therapy. So COMT inhibitors, they can prolong and potentiate the levodopa effect and reduce off time when used as adjunctive therapy, and can reduce the dose, levodopa dose, and by 10 to 30%. They are usually given as 200 mg with each dose of levodopa. And MAO-B inhibitors, they can increase the dopamine levels. And yeah. So this is a patient, advanced Parkinson's disease. She was suffering with PD since 25 years. In her, the on time was decreased to 2 to 3 hours, and patient had severe motor fluctuations and severe dyskinesias. And patient had a severe anxiety, and tremor was always aggravated due to anxiety. And this patient was taking levodopa every second hourly, and she was thinking dyskinesia was also a feature of Parkinson's, and was taking the repeated doses of levodopa, and was taking up to 12 to 20 tablets, and then she landed in dopamine dysregulation syndrome. Patient developed severe delusions, hallucinations, and psychosis, and there was decreased sleep. So here we can see patient had a severe tremor and severe rigidity, bradykinesia, and her off score was 87 and on score was 28. Patient was admitted to ICU, and then we had to stop all the dopaminergic medication, and we have decreased the levodopa to half tablet 4 times a day, and then slowly we had to explain the patient and give her according and explained about the tremor and dyskinesia, and slowly we have escalated to control, to achieve adequate control. So for the psychosis part, patient was started on pimavanserin and quetiapine, and as well as clonotril was given initially. This patient, again we opted, we gave them option of DBS versus MRGFUS. Patient tenders and patient did not want surgery, so she was treated with MR guided focused ultrasound. So before the procedure, this was the severity of the tremor on the right side, right upper and lower limb, and patient underwent left limb ablation, thalamotomy and PTT tractotomy. So after procedure, after MRGFUS, there is complete cessation of tremor on the right side. This is follow-up after 1 month. So there are few rescue strategies can be used in advanced Parkinson's disease. That is, we can use subcutaneous apomorphine and sublingual apomorphine and continuous apomorphine infusion and device-assisted and surgical therapies in patients who are very advanced Parkinson's. So to manage unpredictable ops, again, patient education is very important. Timing of the drug and timing of meals is very important. Sometimes we can advise apomorphine for these patients. Dystonia is also one symptom seen in patients with advanced Parkinson's disease or young patients, young onset Parkinson's who are untreated, they can have dystonias. And also it can be seen in off period due to withdrawal. So withdrawal dystonia is commonly seen in early morning, that is early morning dystonia. This off period dystonia, early morning dystonia can be managed by giving a dose of CR preparation at night. And peak dose dystonia can be managed similar to dyskinesia. So this is a young onset Parkinson's patient. Here we can see there is a neck dystonia as well as bilateral foot dystonia. This is patient is in off. So take home message is proper clinical diagnosis is very important for optimal management of patients with Parkinson's disease. Levodopa monotherapy is recommended in patients elderly who are elderly more than 60 years, and also depending on the patient's preference, their profession and all, their independence, the level of independence they want in day-to-day activities. And in younger patients with early Parkinson's, preferably MAO inhibitors monotherapy along or dopa agonist monotherapy can be recommended. In advanced Parkinson's, adjunctive therapy with the dopamine agonist is recommended in all. And amantadine preferably to be added as adjunctive therapy in all patients on levodopa to decrease the risk of dyskinesias. And trihexyphenidyl to be avoided in elderly patients and with freezing of gait and cognitive impairment. Thank you. Severity and also adding adjunctive therapies that can help us in decreasing the dose of levodopa like dopa agonists and COMT inhibitors or MAO inhibitors, and we have to try like that. You use a combination of medication and decrease the original levodopa dose. But definitely once they go to advanced stage, we have to start counseling the patient for a definitive management strategies like surgical therapies, DBS or MR guided focused ultrasound.
Yeah, as madam suggested, once the patient crosses the honeymoon stage, that is needing more drugs, that is the time when an option of either a DBS or focused ultrasound can be suggested. That is the focus of the next topic. For that, I would request Dr. Gopal to come over. yeah, and talk about the focused ultrasound that we have here since about a year, and we have a wealth of experience about more than 30 patients now, and the initial results have been quite encouraging. Most of the patients of Parkinson's don't want a surgery. Therefore, without a surgery, we have this very viable option of treating. And let's hear from Dr. Gopal.
Good evening, everyone. Honorable patrons, Bhaskar sir, Mohandas sir, Sambit sir, and the course director, Kaul sir, Sita madam, and organizing secretary, Praveen sir, and respected delegates. It's a privilege for us to present in front of you our recent experience with the focused ultrasound. So, can disabling tremor treated without an incision or a suture and scar? Yes, it can be. And we can reach deep targets inside the brain with the skull intact without opening the skull. And neurosurgery is nowadays outpatient based and image guided procedure. So basically, sound is a form of energy which is produced by any vibrating object, and it propagates through the medium, either air, liquid, or solid, but it cannot propagate in vacuum. So sound energy, one of the basic properties of sound is frequency. The frequency distinguishes into three types. One is the audible range frequency, which is 20 to 20,000 hertz. Then infrasound is below 20 hertz, and the ultrasound is above 20,000 hertz. Medical imaging typically uses ultrasound range frequency of sound, and this high frequency gives us special properties for imaging and recently in therapy. So it's nothing but focused ultrasound is nothing but focusing sound beam on precisely on a target. It's similar to how a magnifying glass concentrate the sunlight to create burn in an object. This is one animation which I regularly show to our patients who come for this procedure. So it involves placing a ultrasound transducer, which is in the shape of a hemispheric design, half circle transducer with elements on it. Each element emits the ultrasound beams, and they penetrate the intact skull. And they reach the target, and once they meet at the target, they release thermal energy and create a small lacunar infarct. So this is not a new technology. It was done in early 40s and through the 50s, but it was abandoned due to the lack of technology at that time. And at that time, often craniotomy is required. Craniectomy, then do the procedure, and then put the bone back. So the modern HIFU, which was in mainstream since 2011, it is a combination of three technological advances. The one is the intensity. The intensity of present HIFU is very high. It can somewhere give around 60,000 joules. That is a limit which can be given to a patient. And second thing is it is guided by real-time MRI, and the MRI has a temperature-sensitive software that is called the thermography. We can measure the temperature at the target where we do the ablation. And the third thing is the transducer is an advanced transducer called the phased array transducer, which means it corrects the skull distortion, which I'll show you in the next slide. So for this treatment, one important factor is skull density ratio, which is the ratio of the cortical bone thickness to the cancellous bone or the diploid bone. So if the diploic bone is more, the SDR will be less. And similarly, if the diploic bone is less and the cortical bone is more, the SDR will be high. So the high SDR is much more suitable for performing focused ultrasound. In case of low SDR, the energy efficiency is less. Treatment can be done, but the efficiency will be less. Most of the energy does not get delivered into the target. So this is an schematic of a transducer, and this is one of our patient's skull. And if you can see, the ultrasound beam hits the outer cortex, then traverses the diploid, then reaches the inner cortex and goes into the brain. So you can see if by this slide you can appreciate that if the thickness of bone is more, the amount of energy that gets absorbed in the bone is more. Normally 90% of the energy gets absorbed in the bone at the calvarial level, and only 10% goes inside and produces the lesion. So what is meant by phase array, which I have mentioned before, is like once the ultrasound beam hits and it deflects inside due to the diploic bone or the incident angle, the phase has to be changed so that lesion can be produced. So the recent machine has a phased array transducer. And if the incident angle, which is the angle at which the beam strikes, is more, the beam does not go inside. So all this is computerized and automated, and the system gives real-time energy efficiency. So each of the individual beams, there are 1024 elements which are arranged like this, and each of them produce one beam, and each of them is harmless, but only once they meet at the focus, they produce a lesion. So this is a system which we have at KIMS. It's called the Insightec Exablate Neuro. The operating frequency is 650 to 670 kilohertz, which is coupled to 3 Tesla GE MRI. As I told, the transducer is a hemispheric 30 centimeter diameter helmet, which has 1024 transducer elements. So the treatment process goes in this way. One is the patient preparation. In patient preparation, we fix the patient with the head frame, then apply the membrane. This membrane separates the patient's head from the face, and the cold water circulates above the patient's head. The second part of the treatment is planning. The planning is, there are various methods of planning, direct, indirect planning. The planning decides where we choose the target. Once we create multiple targets, multiple methods, and also 2 different targets, so that if one fails, there is a backup. Then the third treatment process is alignment. So this is the center of the transducer. We bring the center of this transducer to our desired point, which is planned, and test it. This is a thermography spot. Both should be aligned. The target, the actual thermography spot, and the position of the transducer should be aligned together. And then we perform something called intra-op testing. This is the testing phase of the treatment. In this, we give a sub-thermal dose of temperature. That's around 48 to 51 degrees. It produces a temporary effect. Initially, the tremor subsides, and later it comes back. In this patient, we can see the right-sided tremor has come down, but still he had a left-sided tremor. In the same patient. During this phase, we check for side effects also, like numbness, any heaviness in the hand. Then if there are no side effects and we see the effect like this, we produce a permanent lesion. But if we stop at this level, there won't be a permanent lesion formed. In case if we see any side effect, we stop at this level and we move the transducer accordingly. So this is the thermography of a permanent lesion. The blue image shows the permanent lesion and it's close to our expected target. Once the treatment is done, we confirm again with intra-op MRI. The MRI shows a lesion. Then we should assess the characteristics of lesion also so that the treatment longevity will be more. So in this case, you can see a nicely formed lesion which should have two components: the inner core of hypointense area and surrounded by hyperintense cytotoxic edema. If such a lesion is found, the duration of effect will be longer. So I'll take through few cases. So the first case is a 76-year-old male with post-CABG status with low ejection fraction. He has tremors for past 15 years, slowness of activities and gait for last 3 to 4 years, and difficulty in activities of daily living for 3 to 4 years. And he is totally dependent. So he is on Sindopa plus thrice, 125 thrice daily, Pacitane twice daily. His UPDRS is 34, Hemi UPDRS, and CRST is 102 with Hemi of 58. So this is him. Postural tremor, intention tremor. Severe rest tremor. So we apply the membrane which attaches the patient to the ultrasound transducer. So the patient's head is fixed to the MRI gantry so that the head becomes, even though if he has tremor, the head becomes immobile. The head will be rigid and fixed. Then the ultrasound transducer comes over the patient head and we fix the membrane, the white circular membrane, to the transducer. And the space between the transducer and the patient's head is filled with the cold water so that it prevents skull heating, the scalp heating. And if you have noticed, this patient, all the patients should undergo a clean head shave, even though it is non-invasive. The clean head shave should be done to prevent scalp burns. So this is an intra-op image. It's basically the treatment image is based on T2 sequence. This is surrounding cold water, and this is thin T2 image. So we move the transducer manually to the target. The MRI guides which side you should move the transducer so that the focal point will be at the target. So we do some intra-op testing. After that, if there are no side effects, we do permanent lesioning. And you can see one side of the tremor is, the right sided tremor is gone, but still left side persists. Focused ultrasound is done one side at a time, and with a spacing of 6 to 8 months, we can do the second side. So this is his spiral after the procedure. So it greatly improves the quality of life with such individuals with severe debilitating tremor. And the post-op MRI, the lesion looks like this. For this patient, we have done one WIM lesion and one pallido-thalamic tract lesion. Then coming to the second case, she is a 58-year-old with history of Parkinson's disease for last 8 years, but she has unilateral disease. Such patients are ideal candidates for such treatment, because if you do one side, it greatly improves the quality of life, but still they might have a pretty good long-term benefit. So rest tremor, then postural reemergence tremor. She has minimal bradykinesia and rigidity. For her, we chose two targets, WIM and PTT, and her SDR is quite good, like it is 0.6. And out of the 1024 elements, we could use 960 elements. And we could complete the treatment in 13 sonications, means 13 times we have sent the ultrasound beam. The actual treatment ones are 4 for 2 targets. Rest will be the alignment and the testing, verifying sonications. So in her we gave a maximum energy of 5,500 joules and we achieved temperature of 57 degrees. Temperature greater than 55 causes immediate thermal necrosis. If the temperature is less than 55, the longevity of the effect will be less. So MRI again showing well-formed lesions. This is the post-op MRI done 24 hours to 36 hours after the procedure. This is her after 3 months. Left hand, no tremor. Overall, she is doing very good. In such cases, the doses of medications can also be come down, especially unilateral disease. So this is a 63-year-old male with bilateral tremors. UPDRS was 78 enough and 13 very good response, decreased on time. He has difficulty in eating, drinking, and shaving, and he has social inhibition. On examination, he has bilateral postural action and intention tremor, right greater than left, bradykinesia and rigidity, no axial symptoms. So a rest tremor, postural tremor, right greater than left. So we did 2 lesions for him, the WIM and PTT. WIM is basically to address the tremor. It's in the cerebello-thalamocortical tract. And pallidothalamic tract is the output of pallidum to the thalamus, which controls bradykinesia and rigidity. So SDR is good, and we can use, in this case, 940 elements were used, and treatment is done in 11 sonications. And the maximum temperature achieved is 57. So immediately the tremor comes down on the treated side. Even before tremor response is very immediate, like it's like immediately seen on the table. And his handwriting improved. And this is a post-op spiral. These are the two lesions. This is the WIM lesion, and this is the pallidothalamic tract lesion. Even though the lesion appears so large in the immediate post-op scans, they almost disappear by third month. You can see only a faint dots. This one and these are the two lesions. These are the faint streaks. So the take-home message is focused ultrasound is safe and very precise. It is non-invasive, although it appears non-invasive, inside it is still invasive, and it's preferable for unilateral tremor-dominant symptoms. It has low complication rates, no issues of hardware, and good long-term outcomes. The long-term outcomes, if you see the long-term outcomes, the CRST scores will improve by around 70% at 5 years. And the combined hand scores improve by around 40%, which is significant. And in tremor-dominant Parkinson disease, the CRST scores remain significantly improved till 60 months, that is 5 years. This is a multidisciplinary team approach involving movement disorder neurologist, neurosurgeon, neuroradiologist, clinical psychologist, and physiatrist. Thank you for your attention. Thank
you. Will you be presenting any case, sir? That's okay. That's fine. I was also not sure how much will the benefit, but when I saw the patients coming out, in fact, there's a dramatic response in the amount of tremor. Therefore, there's very good viable treatment for Parkinson's patient, especially who are having tremor predominant. Any questions, please?
Cost is 15 lakhs, sir, for one side. It's less than DBS for one side at our institute. Yeah.
Will this procedure work for familial tremors?
For essential tremor, it works. Familial tremor, we should have some caution. Like, you mean ataxia scar you were asking, sir? Or?
No.
Yeah, it works. For essential tremor, familial, it works. Yes. Parkinson familial, it works. Yeah. So the chances of recurring to baseline tremor in the literature is around 8 to 9%. And under control, as I have mentioned, the tremor score, CRST, will remain significantly improved by at end of 5 years. Yes.
When we're talking about the familial tremors, the team has done a recent for SCAR12 and spinocerebellar ataxia 12, which present mainly as a tremor. And she also had a good response. The thing is that how many years it will last, that's we don't know. But at the end of the procedure, tremor came down dramatically. No, sir. It was more component of essential tremor.
Thank you.
If there are no questions, sorry. Yeah.
Sir, you said the chances of recurrence around 8 to 10%. Is it something similar to like how radio frequency ablation is done in few arrhythmias for cases like WPW syndrome, where is it the same principle works or is it different?
No, it's a lesioning procedure. Means we produce a lesion using, but not radio frequency, but using sound. Okay. There are certain differences. Because I have seen radio frequency lesioning also in the brain. Okay. This is more precise. The chance of collateral damage is less in this, but principally it both produce heat and kill the tissue. But there are differences because it is more precise, very fine. You don't see a residual lesion after 3 months. That is what the major difference which I have seen.
One thing, is it quite opposite to cryo procedure? Cryo procedure is basically you freeze Here
Cryo procedure in brain, I'm not sure it's...
No, sir, not in brain.
It was done in Cooper days, cryo in Japan, but after that, no, it's not been done.
Ultrasound, if you use the photon therapy, which is nowadays used for this type of deep-seated tumor, where you should not damage the surrounding structure, vital structure, where the waves are passing.
Yes. So, this is, first of all, this is not a ionizing radiation, the first thing. The second thing is ionizing radiation takes its effect not immediately like we see in this, because the next talk will be on that and he'll tell you on that. And this, the chance of testing will be there in this treatment. Like if you raise the temperature of target to 48 to 50 degrees, temporarily the neuronal firing stops and you will see the response. But that is not possible in proton. Yeah, that's it.
Yeah. Now coming to the last topic, that will be some talking about definitely the, as you were talking, sir, the beam therapy and the utility in trigeminal neuralgia and deep-seated tumors. This is the last talk of the day.
Good evening, everyone. Thank you for your patience for attending today's neuro update session, and thank you for the organizers also for giving me this opportunity to talk on this gamma knife. So today I will be discussing regarding the gamma knife stereotactic radiosurgery. So first, before going directly into the session or into the topic, so we need to discuss regarding two important people. One is Lars Lexell and the other one is Borge Larsen. So both are, one is a neurosurgeon and the other is a radiobiologist. So both are, they have combinedly invented gamma knife in 1970s. This is not like a recent innovation or a recent technology. It was found in 1970s, 60s. So to be precise, he is a neurosurgeon, Lars Lexell. So he first, he wants to do a brain tumor treatment or any brain related surgeries without opening the skull or without having a skin incision. So the first technology that he used is ultrasound technology. But as my colleague Dr. Gopal has said, so at that time there is no much technology to exactly utilize that ultrasound energy to exactly focus. So then he shifted to the other thing is that is radiation, where he has succeeded in it, and today it has revolutionized the brain tumor surgery treatment as well as other brain related conditions as well. So so there is actually, before going there, so there are few radiation techniques and we should understand the differentiation between these techniques. So initially it was radiation therapy, so that we standardly know that the patient will be having a 6 weeks radiation, 5 weeks, 5 days a week, 2 days off, and they'll need to come to hospital for close to 1.5 months and they need to take the treatment. But then there is another concept, that is stereotactic radiosurgery, which the patient will come either single day or to a maximum of 5 days. And they will be getting discharged in single session treatment, they will be getting discharged in a single day. So the difference you can see in the table, that in conventional radiation therapy, so the dose will be very low. So why they use the very low dose is, they need to, when we give a radiation, we need to also save the brain tissue also, along with when we are treating the brain tumor as well. It should be a balanced one. So when you give a low dose, the normal tissues recovers well and the tumor dies with repeated accumulation of dose. But still overall the effect of the treatment is not that great when compared to the single session. But when we try to give a single session, we don't have that equipment in before 1970s that they exactly focus and there will be a significant dose fall, sharp doses at that time. And so that is the reason there is no concept before 1970 radiosurgery. So with Lexell, when he invented the gamma knife, then the concept of radiosurgery that it has developed. So the radiosurgery is nothing but it is a like in a surgery you will do it in a single day, the session, and it is like a scalpel accuracy that it will treat the tumor. So that's the time the word they have coined radiosurgery. So that is the difference between the radiation therapy and the radiosurgery. So when coming to the radiosurgery, so there are it is a technique. First of all, radiosurgery, as I mentioned prior, it is a technique of giving radiation in a 5 days or in a single day, or preferably mostly in a single day. So here there are various machines that are available that they can deliver these radiosurgery. So when you see, you can see that there are two different, one is radioisotope, one is the particle accelerators. Like the one is electron and the other category is the proton. But when it comes to the radioisotope, it is the gamma knife. So why the differentiation is important? So when we say some accelerator, particle accelerator, apart from any non-gamma knife machine is a particle accelerator. So what's the difference is particle accelerators are very high energy machines, like close to 6 million electron volt. But when it comes to gamma knife, it is 1.1 million electron volt. So amount of energy that is being delivered is less in gamma knife, but it will exactly focus that radiation in a particular point. So there is a difference between these two, because if we use a high energy machines, we generally assume so we can deliver more amount of energy. But on the contrary, what happens when you deliver more amount of energy, parallelly the brain tissue also will be getting affected. So that's the reason we need to use a machine which is very accurate focuses and a low energy machine. So that machine is gamma knife. So to achieve the success in stereotactic radiosurgery by any means, so we need three things. One is rigidity, stereotaxy, and dose fall. So what is rigidity? So it is not like something when you radiate to the other part of the body that a small fraction of normal tissue, if it is getting involved, okay, that might not show a clinically significant problem to the patient, maybe. But when it comes to the brain, even a 0.5 millimeter of the tissue, suppose let's assume a brainstem tissue gets affected, the patient will show a significant deficit, and it is very morbid to the patient. So to achieve that accuracy, you need to first immobilize the skull. So that concept is called as rigidity. And the second thing is stereotaxy. Stereotaxy is nothing but localizing a particular point in a space. So we know as a surgeons or as a doctors that okay, this is where it is located, but the machines don't understand where it is placed. So they will just deliver the tissue. So we need to give it a space where it will be having a specific coordinates. That coordinates placed Lexell space is called stereotaxy in a simple terminology. Like you can target in that area very precisely, close to 0.1 millimeter accuracy. And the other thing is dose fall. So once the radiation dose we give to the tumor, beyond the tumor, there should be a significant fall in the radiation dose so that it should be within the limit of the tolerable dose to the normal brain structures. So these are three are like the pillars for the stereotactic radiosurgery. So now coming to this focused radiation. So in this example, we can see if we put a magnifying glass under the skin, we all know that the underlying, it will create a burn on if you place something like paper or a grass, dry grass. So it will immediately burn the tissue. But when we stand in the same sun, even if we stand for a couple of hours, we are not affected by anything. Because what is happening here is all the radiation or all the sun rays, they are getting focused at a single point. So in the same way, even in the gamma knife, there are close to 192 beams of rays that will be getting focused at a single particular point. So when it enters into our body, so each individual ray carries a very low amount of energy, which is like almost negligible, creates a negligible damage to our skin or the bone or the underlying brain. So the second thing which I told is rigidity. So like in this image, you can see that the sniper is holding his rifle. He can able to target only if he can able to stabilize his gun. In the same way, we need to stabilize the patient's skull, only then the radiation will get delivered. So for that, we need a frame. So this is the most important instrument that we use in our stereotactic procedures, and even in gamma knife also we use this frame. So there are two frames, one is G frame and Vantage frame. Each has their own different advantages and disadvantages, but we can use any of these two instruments. So this frame, when we fix it to the skull, and that frame we will attach it to the table, radiation table. So the whole system is now fixed. Even if the patient tries to get mobilized, it is not possible for him. So what makes gamma knife so special here? Because this immobilization technique of fixing the frame is only being done in gamma knife machine, not in other machines like CyberKnife, Zapex, Linax, X-Knife, whatever the machines, you name the machine, they don't have this method of fixing the frame. So that is the reason the accuracy there when it comes to the close to critical structures like brainstem and the optic nerve cochlea. So there is a change in accuracy, and definitely there is a change in dose that is being delivered, and the clinical outcomes also vary with each procedures. So that makes the unique with the gamma knife. So so one thing is rigidity, and the other thing we have seen this how the dose fall is, and now the thing is stereotaxy. So we need to identify where the space is. So here in the image you can see this blue color is the frame, and the outside there is a N color shade, N like thing. So that is called as fiducial markers. So that is the fundamental space where based on that the system recognizes where is the target when we place it, and based on that the system recognizes and delivers the radiation in that particular space. So combining all this, it is like multiple focused beams of radiation that can be used to treat varied brain conditions. And the name was coined like a knife because it is having a surgical knife precision when it is giving treating the brain conditions. And it is a completely incisionless technology, and which is having a surgical precision, and no cuts, no stitches, and no hospital stay. So what is the basic workflow? So once we decide this particular patient requires is a candidate for the radiosurgery, so we advise him to undergo few blood tests for our basic investigations, and on the day of procedure he will get admitted in the morning on daycare basis, and we will fix the frame. We will get the MRI based on that fixed frame in the fiducial box, and we mark the tumor boundaries, and we deliver the dose. And after the procedure we remove the frame, and we will discharge the patient on the same day, and there are no any restrictions or any additional medications required also. He can just travel even 200 kilometers overnight to go to his destination. So this is the workflow how we do it. So there are two types of workflow we have. One is with the fiducial frame, and the other with the CBCT. So here there are two types. One is we can fix the frame, we put the fiducial box for the stereotaxy, and then we do the MRI. That is one workflow. And the other workflow is if the lesion is located in non-eloquent area of the brain. So you can prior do an MRI, and you can do the planning and everything. And on the table you can do a CBCT, which the stereotactic accuracy is very close to the Lexel frame, Lexel fiducial box. So with this we can do like a two types of workflows through which we can deliver the radiation. So when it comes to the radiation, we hear a lot of machines that which normally we don't understand. The very first thing is between the names itself, the nomenclature itself is a huge barrier, because everything looks same, like gamma knife, cyber knife, X knife, some other knife, Zapex, True Beam. So there are like similar names, we all get confused. But we have to remember one thing, as I told you, the very fundamental principle of the gamma knife is it will deliver a low energy but a very efficient energy to the tumor, and we will fix the patient with a frame. That these two are the main thing that makes the gamma knife so superior, that it has an accuracy of close to 0.15 millimeters. You can imagine what's the accuracy of 0.15 millimeters in a medical thing, particularly when it comes to the brain. So then we have to understand the differences, what exactly is gamma knife and what exactly is the cyber knife. So gamma knife is only built for the brain. So suppose if your patient is having some lung tumor, you can't treat it with a gamma knife. It is only for the brain, exclusively for the brain. it is designed for the brain. But when it comes to the cyber knife, it is designed for everything else. You can treat it with anything in the body. So here are the few differences that you can see. The accuracy is very high in our thing, that close to 0.15 millimeters, and the immobilization technique itself is frame based, and there is no real time tracking. In other systems, what they do is they put a mask and they'll be having some tracker, so if you try to move, it will try to adjust and everything, but everything it will come and at the cost of accuracy. So here, and another thing is with the gamma knife, the side effects are also very less, because there are multiple rays that are entering into the body, like focused ultrasound, multiple ultrasound waves entering in various directions, but they are focused at one point, so the energy is more. In the same way, here multiple rays will be entering into the body, and the side effects which we generally see when we see a patient having a hair fall, skin color changes. So we don't have all those issues with the gamma knife. But when it comes to the cyber knife and other things, they have a little bit of large beams, so that they create a larger amount of radiation fields over the skin, and they cause these hair falls and the skin changes. Another one is inhomogeneous and homogeneous fields. So when we know the fundamentals of the radiation, like in the center of the tumor, so there is always a hypoxic environment, because the angiogenesis is not great at the center, but it is good at the periphery. So at the same time, the central area, which is very hypoxic, is very radio resistant as well. So you need to give a very high doses, but you need something unique, that it will create a very high doses in the center, and it will create a very low dose and a prescribed dose at the margin. So that you can achieve with the gamma knife, where you have a central dose will be very much high, like close to double the dose. Suppose let's assume I give for a meningioma some 13 gray. The center of the meningioma will be receiving 26 gray. But with the cyber knife and the Linax, if I give a 15 gray dose, the center of the dose will be close to 17, and it can't pull or push more than a particular level of that 17 gray or 18 gray. It can't give a double the dose. So this creates a more advantage. Even the resistant part of the tissue of the tumor, we are delivering very high energy, and it will get destroyed. So ultimately we will see that in the form of response. So that is the reason, even in the outcomes also, with respect to the gamma knife, the results are much higher and better. So another thing is, when you say for the gamma knife, as I told you, it is only for the brain. So the accuracy, everything depends on each and every single factor, as well as how you are saving the brain as well. So it is made up of 20,000 kilos, like tungsten material, that is bound by it. But when it comes to the cyber knife, it is a robotic arm. So robotic arm couldn't withstand such a high loads, because obviously 20,000 kilos, it is not possible. So the weight of the machine itself, they have dropped down to close to 1200 kilos. But at the same time, there is no that much amount of radiation protection that it will save the normal tissues if there is a loss in accuracy or something. So when you compare these two things, so there is definitely a huge difference between these two. So in a simple way to say, so like other radio systems will be like a torchlight, and gamma knife will be like a laser, where you don't find any penumbra of the radiation to the surrounding tissues. So that is the reason we can able to deliver even higher radiation doses in a single session. But at the same time, if the other system tries to deliver a higher same radiation doses in a single system, then the patients will land in big trouble because of the radiation toxicity. So we have to remember one thing is, like, not every knife is gamma knife, and gamma knife is a pure neurosurgical instrument, and it is designed for the brain, and it is perfected for the brain. So here are the few literature data, and that is suggesting the significance of gamma knife in controlling the radiation toxicity and delivering the outcomes. So even in the literature evidence, if you see, there is a 3 times more literature evidence combined with all the radiation equipment that is available in the market. So that is the value, and that is the accuracy and the efficacy of this machine. So coming to the side effects, as I told, there are no hair fall, no skin changes, there is less chances of radiation necrosis, and there are no much of the visual disturbances. So here I will be discussing few cases that we have done in the last 6 months after the induction of gamma knife at our center. So this is a small jugular schwannoma case where the patient presented only with a mild headache. It is exactly placed in the jugular foraminal area. So we all know that jugular foramina is associated with the lower cranial nerves, which are vital for the swallowing and for breathing as well. So going there and tackling the tumor and operating may create a more of morbidity. But in these cases, it is very small, and we have delivered the radiation in single session, and the patient till now is under our follow-up and had no issues. So this is a small meningioma. He presented with seizures. So here generally it is a small meningioma. Actually, it is not having even perilesional edema as well. But as a neurosurgeon, you need to cut open the skull. It's a more procedure. You need to do a surgery, big surgery, and you need to treat it. So for these cases also, even if the patient is having seizures, we can deliver the radiation, and once the size reduces, the seizure activity also goes down, and patient doesn't require long-term medications as well. Pituitary adenomas. So a lot of times pituitary adenomas, they invade the cavernous sinus, and opening the cavernous sinus is a bit difficult for 2-3 reasons. One is for the bleeding, and the other one is the extraocular movement cranial nerves associated in the lateral wall of the cavernous sinus. So it is not feasible to go in and pull out the tumor completely to give a complete tumor relief, and we need to also control the bleeding. So it is not possible all the time. And particularly if it is a functional tumor, then even if you leave a small speck of tissue, again it will regrow, again it will create a huge disturbance in the functional status of the patient. So even in that scenario, we can safely give the radiation without damaging to the normal tissues. So other one is the AVM. So AVMs as such, traditionally it is a controversial topic actually because of multiple things. Endovascular we can treat by radiation, we can treat by surgery. But all depends on how you choose a patient for any modality of the treatment available. It is not like I have the machine, I will treat with that machine every patient available. It doesn't work that way. So here we have to identify what type of AVM that we can able to treat with the radiosurgery. So here we have to see whether the lesion is located in the eloquent area, what is the size of the AVM, whether it is deeply located, superficially located, and whether it is most important ruptured or unruptured. In a ruptured case, it is not advisable to give any radiation or embolization. It is better to go and operate. So AVM, we have to choose the cases wisely, and the obliteration rates are close to 90% if you plan it very well. And next is trigeminal neuralgia. So even in trigeminal neuralgias, we can treat patients with the gamma knife. So here trigeminal neuralgias, generally they have, the most common thing is having a vascular loop that is compressing at the root entry zone. So here the standard procedure is always MBD. Even now it is like MBD. But if the patient is not fit to undergo surgery, or already underwent surgery and had a recurrence, or if the patient is not having any loop radiologically, or if it is a case of some multiple sclerosis associated trigeminal neuralgia. So this is a very efficient, good modality of treatment that we can deliver, and the patient will be having close to 6 to 8 years of pain-free interval when you compare with the other non-invasive procedures like radiofrequency ablations. So glioma. So this is one case which we have treated. He was a doctor by occupation. He was treated at Australia for the right frontal glioma. So he received conventional radiation, and then he received chemotherapy as well. And after that few months he had a recurrence. In June he had a recurrence. So then we planned a gamma knife for this. And after 3 months of MRI, so you can see there is complete loss of enhancement, and the patient is not having any edema or any related radiation necrosis as well. So till now I have discussed all the cases about the benign conditions only, and it is like a gamma knife can be given only for the benign tumors. No, we can even give even to the malignant conditions as well. Like in this case with glioma, it is a grade 4 GBM case which we can able to treat it well. And most important topic with respect to gamma knife is metastasis. So when it comes to metastasis, traditionally, like, you don't know where it is, so there might be small lesions. So the traditional way of treating is whole brain radiotherapy. You give the radiation to the whole brain, and that's it, everything will get affected. But 2-3 decades ago, it is like if the patient is having brain metastasis, within a 6 to 8 months, the patient used to pass away. So we don't have any data. But with the advancements in the chemotherapy, immunotherapy, and a lot of things, now the survival has increased after diagnosing the metastasis close to 2 to 3 years. So then people started recognizing with the whole brain radiotherapy. So there is a loss in the cognitive decline over a period of time, because we are giving radiation to the whole brain. So in these circumstances, even if the patient is having 20 metastasis, we can easily deliver the radiation without affecting the normal brain, and we can plan it very well that the threshold of the brain will be very far below to the recommendations. So you don't need to worry even with the multiple metastasis also. In fact, in Western countries, 70% to 80% of the caseload, what they do with the gamma knife is metastasis only. So metastasis is one condition which gamma knife is absolute superior. So here is the protocol for the metastasis, what Pittsburgh people used to follow. Pittsburgh is the center where the gamma knife was treated for almost close to 4-5 decades. So here we can see what are the how you can treat the case. So it is like, even if it is the volume of the combining all lesions, if it is less than 25 cubic centimeters, you can easily deliver in single session also the whole radiation without damaging the normal brain. So along with the gamma knife, we use additional recent advances which are available, like contrast clearance analysis, and another one is gallium scan. So contrast clearance analysis, why it is required is, once when we give a radiation to the patient, later on they come with some enhancement and we are not sure whether it is a recurrence or whether we can, is it a radiation necrosis. So in these circumstances also we can use contrast clearance analysis, which is a specialized MRI that we do with the brain lab support, and based on this also we can plan, and if it is a recurrence we can be able to give the radiation even in these scenarios. So another one is gallium PET scan. So in meningiomas, most of the time, when we see the post-op imaging, so there will be some amount of enhancement at the dural borders post-surgery. So a lot of times it will be a tricky situation, whether is it a recurrence or is it just a post-operative enhancement, nothing more. So then we can use this gallium PET scan, and with this PET scan also we can incorporate it into the gamma knife, and we can able to demarcate the lesion precisely without damaging the normal structures, and we can deliver the radiation. So these are the two additional things that we take help to give more support to the gamma knife to deliver the treatment. So now who can benefit from these tumors? Like now I have discussed metastatic tumors, AVMs, trigeminal neuralgia, meningioma, schwannomas, pituitaries, gliomas, choroidomas, even chondrosarcomas, and even pediatric tumors also. So any pediatric patient who is not less than 2 years, above 2 years, so we can give the radiation, gamma knife radiation. So now why it is a game changer? Because it is like no open surgery, no incision, no blood loss, and no infection. And it is has a very high precision, which is safe, fast recovery, and very cost effective. So till now we have discussed regarding the advantages, so why it is so superior, why we need to use gamma knife and everything. So now why a neurosurgeon, he is presenting equipment which is completely a radiation based machine. So because radiation oncologists, they are already available, so they can deliver this treatment. That is not it shouldn't be an issue, right? So why a neurosurgeon has a role in this, and why he is the main person? So 2-3 things. One, because as a neurosurgeon or as a neuro doctor, so you always have the complete knowledge of brain functioning, brain anatomy, because we go inside and we do surgery as well. So we know exactly things where it is placed and which is a complicated thing which we shouldn't touch, which is an easy thing to do. So we can decide better which patient is better, he will go with the surgery, and who is better with the radio surgery, so that we can easily choose the patient. One thing. And second thing, as I told you, I have shown you in my initial slides, there is a frame fixation that we do. So it is like a daily procedure in our neurosurgical OT suits, like daily we put the frames. So we know the accuracy, how it is, and we know the importance of maintaining that accuracy in delivering treatment to the brain. And we also know that stereotactic principles, how the stereotaxy works. because like we do DBS, we use stereotaxy. Like we do biopsies, we use stereotaxy. When we do a brain tumor surgery, open surgery also, we use stereotaxy. So stereotaxy we don't use only in gamma knife. It is used in the whole neurosurgery all the time, every time. So that is the reason a neurosurgeon role is very crucial in deciding a case whether it is a fit for a radiosurgery or whether it is fit for a microsurgery. And we also have an experience in, obviously when we do a surgery, we have an experience in handling post-operative care. So we have the thought in mind, once we do a treatment to patient by radiosurgery or a microsurgery, so what I can see post-operatively or post-radiation, what I can expect from the patient. So that also decides our management, which I should choose. So coming almost my session is going to end. So now the question comes like, what is is there any limitation for this to give a gamma knife? So there is only one limitation, is the size of the tumor. So generally if the size of the tumor that we see in the reports or something, if the one dimension is more than 3 centimeters or 3.5 centimeters, then by any other thing, so it is not advisable to go for a single session GKRS. But if it is like the patient is not fit for surgery but he needs treatment, so then something has to be done. So in that scenario, so with the recent machine available in our institute, Esprit, so it has even we can deliver it in multiple sessions also, like 5 sessions, which is hypofractionated radiosurgery we say, which is also safe even if the lesion size is more than 3 centimeters. So 3 centimeters is the limit where you have to see if you want to deliver a patient with a single session. So from the fear of having a brain surgery and to the stage where the patient can go home the same evening walking without having any problem. So a new way, it is a new way to heal the brain without any fear. Thank you for listening to me patiently.
Thank you, sir. The neurosurgeon talking about non-surgical equipment, both Gopal sir and Dasreddy sir. Any questions? Even for a big tumor, this can be used for decreasing the size or no?
When it comes to big tumors, there are 2 things. We can treat even big tumor with multiple sessions, like 5 sessions. But the thing is, generally big tumors more than 3 centimeters, the patients will be having a gross neurodeficits.
Okay.
In that scenario, we can't wait for the radiation to work, because it will take at least 6 months time to start decreasing in size. In the meantime, if you don't address that patient who is having a deficit, so the patients will land up in a permanent deficit and it is not advisable. So we have to see first how is the patient clinically. If the patient is having a gross deficit, then by any means any radiation is not advisable. Then we have to go immediately, you have to relieve the symptoms for him, so we have to operate him. That's the deciding factor.
Even for trigeminal neuralgia, does it take time?
Yes, it takes at least a couple of weeks, close to 10 days to 2 weeks.
Okay.
Yeah.
Any questions?
Not like based on any, first thing is not like trigeminal neuralgia is one, some cost is different, one tumor it is different. It is standard, same for all the pathologies. It is like close to 4.5 lakhs that we are charging. Even if the patient is having multiple metastases, so we don't charge for any single lesion, 1 lesion, 2 lesion, 3 lesion. It is like considered as a single session and a single cost. There is no change in cost further. If it is for single session, it is the same cost. If it is like multiple sessions, then the cost is 5.5 lakhs. Is that 3 sessions or 5 sessions? And we don't give more than 5 sessions with gamma knife. It is max 5.
Okay, it has been a long day. Thank you all the participants who have spent the Sunday with us. And thank you speakers, and thank you the whole team who has supported us along with Sun. We are planning to have it as a yearly, possibly in the next November or December, we will have a second session, and we will again meet at that time. Thanks once again. Oh, Adi. Please join us for tea. Welcome.